Hi everyone, very good afternoon guys. I hope I'm audible and visible to all of you. I hope all of you are doing well. It's been a while that we've met and many of you I might be meeting after the NEET PG. So many of you might be taking forward that journey and continuing with INI-CET. So yes, very good afternoon. I've got a general list कि हमें क्या क्या पढ़ना है in today and in day after tomorrow's session. What all do we have to study? I have kept you a list. You know these are INI loves all techniques and techniques of pathology we don't study, let's be honest. So I will be teaching you all these techniques, which includes electrophoresis, histopath, PAP, FNAC, immunohistochemistry का एक question आएगा. They will club it with these tumors, how to implement, how to apply it to these tumors. Then they will give you some genetic analysis also. So that is the plan for INI for techniques. Then of course side by side I will keep telling you what all chapters, tumors, theory to chalta rahega side by side. Whatever I feel is important, I will teach you. Then in the next session, I will start talking about hematology techniques, where we will talk about CD markers, flow cytometry, because we know that these are pakka wala definitive questions in INI, which you're going to get. Vacutainers, those tubes like Sally's hemoglobinometer, Winthrop, Westergren, we have to identify those. Thromboelastography, platelet aggregometry. Khushi, don't worry, stains will be a part. So now, of course, as I keep teaching you, say I've divided it. One list is of all techniques and one list is of all the topics that you have to do from theory. So don't worry, stains are automatically going to come under those. But if everyone is ready for the time being, I've just given you a brief so that you are settled. I'm starting with the first topic. So I've got this to you from your PrepLadder Q bank only. Which mutation is not associated with this 32-year-old woman who has had a gradually increasing painless neck mass, and there's a firm irregular mass in the right thyroid lobe. So thyroid history is given and the following finding is also been given. So at least when I talk about, see, what you have to be very, very clear over here, like everyone has started answering A. But guys, we have asked you which of the following is not associated. This was the question. So now tell me, pehle to just tell me diagnosis, even if you can't tell me the answer. And I'm talking about thyroid and I've got to see this round. So obviously these are Sarcoma bodies, right? And as soon as I see Sarcoma bodies in thyroid, of course, nothing else but papillary carcinoma thyroid. Now, when I say papillary carcinoma, of course, the next thing you will say is, oh, the most common mutation is what? The most common is BRAF mutation. So that is just one mutation. Till now, you have seen what question? Aisa wala simple question, ma'am. We have seen that, oh, they will give me the orphan annii, khali wala orphan annii nucleus. And in that, they will ask me, this is papillary carcinoma thyroid. So which is the most common genetic mutation? We mark BRAF V600E. This is the usual. I have not got you the usual easy wala question. I've got you the tougher question that other than BRAF mutation, what else can be seen? So in papillary, RET PTC fusion can be seen. Thoda sa dhyan se, if you would have seen, PTC is papillary thyroid cancer gene only. So we have the RET and PTC fusion that can also be seen. And for INI-CET, I want you all to know that NTRK fusion or gene mutation can also be seen. So which is the one that is not seen is the CAS-R mutation, which many of you give me as a right answer. This question, of course, is tough, is not something which you cover routinely, but INI-CET here, you have to take it one edge above, right? So now coming back, all of you made it what? Sarcoma body and papillary. I want to add one thing. Till the time they write RET PTC fusion, they've added PTC, it is papillary carcinoma thyroid. If on the other hand, they would have given you a case of RET mutation, then what would you have thought of? If they would have given you a RET mutation, then I would have thought of medullary carcinoma thyroid, because that is what you have to watch out in the exam. Only RET mutation is medullary carcinoma, but RET PTC fusion, if I club it, that is going to be your papillary thyroid cancer. Okay, I'll be talking more about it. I've got a question from Dr. Day that, ma'am, then where is CAS-R mutation seen? That can be seen with follicular neoplasms. It has been seen with many autoimmune disorders of thyroid like Hashimoto's, Graves. So it is not seen in papillary carcinoma thyroid. Now, before I move forward, what is it about papillary carcinoma when it comes down to your histopath? Orphan Annie sabko pata hai, but what else? Firstly, this is Orphan Annie nucleus. I think everyone by now knows the history behind it, that Orphan Annie was this cartoon character, and cartoon character, the cartoonist did not draw eyes. That is why the eyes were white, and I can see the nuclei are white. Everyone knows Orphan Annie. They will ask you something extra about it. They will not write Orphan Annie for papillary carcinoma. They will instead say that there is an optically clear nucleus. That is the terminology that will be mentioned. There is going to be an optically clear nucleus mentioned. So now you will be searching for that buzzword, that where is Orphan Annie, and Orphan Annie will not be there. They will write clear nucleus, optically clear nucleus, empty looking nucleus. These will be the words given. So this is point number 1. Point number 2, if you look carefully, can you all see that if this is the nucleus, I can see a dot inside it. Like for example, if this is the nucleus, I can see a dot inside it. That will be known as intranuclear inclusion. What else? I can see one more over here. There's a nucleus and a dot inside it. I can see one more thing if I zoom in. Inside this nucleus, if I look carefully over here, which I can zoom in and show you, inside this nucleus there is a line also going, and that line is known as intranuclear groove, which I think everyone knows as, and I would want more answers in the chat box also. That is known as the coffee bean appearance, isn't it? So coffee bean nuclei are also seen. Have you noticed something? Papillary carcinoma is all about nuclei, nuclei, nuclei. If there is Orphan Annie, that is in the nucleus. Inclusion is in the nucleus. Groove is going to be in the nucleus. That is coffee bean nucleus. Everything is nucleus. Now coming to that calcium body, Sarcoma body, which everyone knows. Now they will ask you, these 4 are your photos. These 4 are your options, A, B, C, D. They will say which of them is not seen on FNAC, because on FNAC, otherwise all 4 are seen in papillary, but which is not seen on FNAC. Please remember, yes, any answers? Orphan Annie is only on histopathology. It is only seen on histopathology. It is not seen on FNAC. Any reason? Anyone who can tell me why? Because Orphan Annie nucleus, is it a real finding? No. Orphan Annie nucleus is an artifactual finding, artificial finding. And because of what? Because we put tissues in what? We put tissues in formalin. Do we all know that in pathology, whenever a surgery is done, the tissue or the organ is put inside formalin? So formalin creates these nuclei. Formalin is only used in histopathology. Formalin is not used in FNAC. So if formalin will not be used, FNAC will not show you Orphan Annie nucleus. That could be an INI-CET level question. I hope the questions up till here are clear. Yes. Now we will go on to, yes, Dr. Day will come to that point also. We will take one more question and we will come back. Abhi ke liye we have learned that papillary shows you Orphan Annie only on histopath, not on FNAC. It shows you inclusions, coffee bean grooves. It shows you Sarcoma bodies. Most common mutation is the BRAF V600E mutation. It can also show you RET PTC fusion. It can also show you NTRK. It will not show you CASR. But till the time RET PTC fusion is there, okay. If they say RET mutation, then that is medullary carcinoma thyroid. But now let me see the next question. Let's see if we can answer this. There is a 44-year-old female who presents with a swelling in the anterior neck since 4 years. It is growing in size and moves with deglutition. Moving with deglutition matlab now you are certain that you are dealing clinically with a case of a thyroid swelling. Now on performing FNAC, there is microfollicular pattern. As soon as they say the word follicular, I can only think of 2 things. Either it is a follicular adenoma or it is a follicular carcinoma, because the pathologist has told me that this is a follicular pattern. But now they are saying diagnosis of a follicular neoplasm is given. Why, ma'am? Why did the pathologist do this kind of kamchori? Why did the pathologist do FNAC also and still did not tell me ki adenoma or carcinoma? He just or she just said, oh, it's a neoplasm, because on FNAC you cannot make the diagnosis of follicular tumors. Why? You have to make it only and only on histopathology. So you will take that nodule out, you will do histopathology, and then they saw there is no capsular invasion, there is no vascular invasion. If it is not invasive, then of course this is a case of a benign tumor. If it would have shown capsular invasion and vascular invasion, let's assume that this is the photo given to you. If they say that look at this pink color structure over here, I'll want you to look at it carefully, because in the exam I won't be there to help you. So if you look carefully, this pink color structure over here, can you see it has broken in between, and there is a capsular invasion that you can notice over here. Next, if you look at this huge blood vessel. Inside the blood vessel, I can see that there is a tumor sitting inside it. So blood vessel invasion, vascular invasion, when both these invasions are seen, now it is follicular carcinoma. Before I proceed, can anyone tell me which is the most common mutation of follicular carcinoma thyroid? Like for papillary, you told me it was the BRAF mutation. For follicular, you will tell me it is the RAS mutation, which they ask you in the exam. And how do you make the diagnosis? So coming back, there was no capsular invasion, no vascular invasion. So that is why it was follicular adenoma. If both would have been present, then my answer would have become follicular carcinoma. Why is it not follicular variant of papillary carcinoma? Because papillary carcinoma के लिए वो सब तो है ही नहीं ना, orphan Annie and etc. Those are not there. Why is this not Hurdle cell adenoma? Because Hurdle cell लिखना होगा. They will have to write Hurdle cells are seen. Till that time, I cannot make Hurdle cell adenoma or any other Hurdle cell tumor. So this is settled. This is not over as of now. These days, you will read all big tumors, but they will ask you a very simple question in the exam. Identify the normal organ. Last time they asked you how to identify a normal kidney, normal glomerulus. Before that, they asked you how to identify normal thyroid gland. So they are asking you histology also. Before I wrap up, this is the normal thyroid gland. You have to identify it. All these round things. What is the lining of these follicles? These thyroid follicles are lined by these thyroid follicular cells, and common sense, the pink material in the center is colloid. So this is thyroid follicular cells. What else can I see? Do I also see one more cluster over here, which is what? The apart from follicular. So this cluster now becomes thyroid parafollicular cells, which are also known as the C cells. Normally in you and me, forget cancers, in you and me, what does normal C cell release? C cell is responsible for the production of calcitonin. Very good. So now I will combine normal with cancers, and that will tell me, you tell me guys, when I say thyroid follicular cells, all the cancers come from here. So if you ask me where does papillary carcinoma thyroid come from, follicular thyroid cancer comes from, or anaplastic cancer thyroid, follicular, papillary, anaplastic, all cancers come from follicular cells, but medullary carcinoma thyroid comes from the parafollicular C cells. That is why, what is the tumor marker of medullary carcinoma thyroid? It is calcitonin. One more question I want to ask you. This calcitonin later on becomes an amyloid. What is the name of that amyloid? A for amyloid and cal for calcitonin. So now if I ask you what is the tumor marker for medullary carcinoma, it is calcitonin. What is the amyloid that you see in medullary carcinoma? It is ACAL. All of this comes into one sheet over here. So this is normal and correlation. But what if instead of these chota small cells, you start seeing such big pink cells in the thyroid? What if the smaller cells have transformed? This is not a new cell. Hurdle cell kuch naya nahi hota. Now they are saying it's a kind of a metaplasia. These small cells have suddenly started looking like these big pink cells. We call them Hurdle or Ashkenazi cells. Scientist ka naam. Hurdle cells or Ashkenazi cells. What is the real meaning of it? Oxyphil cells or oncocytic cells. Ye naam, this will be asked to you in the exam. Anyone who can tell me? I'm reading through comments. Please do be interactive, because I really like when I know that you, so that I know till where have you studied and what can I add on further. So what is oxyphil or oncocytic meaning to us? It means those things which have a lot of mitochondria. Anything in the body which is very rich in mitochondria will be called as an oncocytic cell. That oncocytic cell could be in the thyroid, it could be in the liver, it could be in any other organ, it could even be in the breast. Anywhere they say oncocytic cell means that it is very rich in mitochondria. That's the meaning of the word oncocyte. Is that okay? Yes. Pink, you are right. Soumya is right that ma'am, it is very pink also. You are correct. Adityanshu is also right. Now let's move forward. This was normal. Normal thyroid pehchan loge. You will even identify the Hurdle cells. Yes. All that is okay. But now I want you to come down to another famous, this was your PYQ in INI-CET 2 years ago. Which of the following statements is accurate when it comes to sufficient sampling of FNAC of thyroid? They ask you questions on FNAC thyroid, and I'm sure everyone knows who has given us this criteria. It is the Bethesda group which has given us the criteria. Most of you have answered A, some of you said B, but correct answer of course is going to be A over here. So what is FNAC thyroid? Pad lete hain. This is exactly exactly a screenshot from your rapid revision videos which I've got, so that you keep having the visual memory also again and again. If you look carefully, they will show you this kind of a picture. See, now what I expect, they will not ask you ऐसा question, 6 clusters of 10 cells नहीं आएगा. They will show you a picture and they will say, can you apply that knowledge and can you tell me, is this an adequate smear or not? So what is 610? Adequacy tells me that there should be at least 6 follicles. How do you count follicles? Groups देखो, clusters, vaguely just try to make circles, that okay, this seems to be one group, this seems to be एक और group लग रहा है, this looks like one more group, this looks like one more cluster, one more cluster. Are you seeing more than 6 clusters? Yes. So one criteria done. Inside every cluster, how many cells should you be seeing? At least 10 cells per follicle. I don't think I have to count. 10 se to zyada hi hai. I'm seeing more than 10 in every, so I don't have to sit and do the counting. But broadly, is this adequate? Yes, this is going to be adequate because I can see 6, 10. Now everyone's understood. 6 follicular clusters, each of them having 10 cells. This is the adequacy criteria for Bethesda. And now tell me something. There are some questions which I've got on below for FNAC. Is this criteria followed everywhere, or is there any exception? Is there any exception that you have for this criteria? So the exception is going to be CCI. What is this? Very good. I've got those answers. Exception means colloid goiter. If I have a patient of colloid goiter, I will only see colloid here. I will only see a lot of fluid, lot of colloid. I won't see all these so many cells and clusters. Nahi dikhega. Then that is fine. You still give the diagnosis. Then you don't go for this adequacy. Second, cancers. Even if I see one cell of cancer change, I am not going to say that, oh, I will not give the diagnosis of cancer till I don't see 6 clusters and so on and so forth. So even one cell of cancer is a diagnosis. And lastly, any inflammation, like for example, I'm dealing with Hashimoto's thyroiditis. Over there, I will see more of inflammation. I won't see so many of these 6 and 10 cells. So CCI are gonna be exceptions. When I'm talking about colloid goiter, cancer and inflammation, these are exceptions and these are not considered under this 610 rule. Some more questions. Which is the thyroid cancer? ये तो अभी पढ़ा था. Which thyroid cancer cannot be diagnosed on FNAC? I just told you. Which thyroid cancer? Follicular cancer thyroid cannot be diagnosed on FNAC. For that, you will have to do histopathology. Remember, I showed you capsular invasion, vascular invasion. Good. Next, in papillary carcinoma thyroid, which is the finding not seen on FNAC? ये भी हमने अभी पढ़ लिया, that orphan ani was not seen on FNAC because orphan ani is a formalin artifact. It is something you will see only on histopathology. So this one flashcard becomes all of your FNAC thyroid related questions. Before I move forward, I told you all of this was given by a group that is Bethesda. Do you in gynae also somewhere study Bethesda? Apart from thyroid FNAC, has gynae also taught you some criteria of Bethesda group, which is for the pap smears? I will teach you pap smears today in like say half an hour. We will reach there. So pap smear ka bhi jo criteria you study, that was also given by the Bethesda group. Very good, Khushi. Perfect. Chalo, let's move forward to the next one. This is a path micro integration. Just a random question. Quickly give me an answer and we'll move forward. What infectious disease is characterized by a mild form with fever and bradycardia? Fever with bradycardia is a rare combo, so think on those terms. And a severe form with hemorrhagic manifestations, platelet dysfunction, and hepatitis with mid-zonal necrosis. Please don't give your answers only on the basis of platelet dysfunction. On basis of that, if you're thinking of dengue fever, please read carefully. Firstly, you are, and only also don't, firstly, चलो यहाँ से स्टार्ट करते हैं. फीवर विद ब्रैडिकार्डिया वाज अ क्वेश्चन दैट केम इन द लास्ट FMGE एग्जाम एंड एवरीवन वाज वेरी वेरी वरिड कि कहाँ कहाँ दिखता है. सो फर्स्ट, कैन यू टेल मी, फीवर विद ब्रैडिकार्डिया इज सीन इन टाइफॉइड फीवर. Fever with bradycardia can be seen with typhoid fever. Fever with bradycardia can also be seen with brucella. It can also be seen with dengue fever. So never give an answer based only on fever with bradycardia. Read further. Further, I saw there was a platelet problem and hemorrhagic problem. Yes, it could be dengue fever. Platelet can go there. But as soon as they said hepatitis with mid-zonal necrosis, Khushi was right and others are also right. This is a case of yellow fever. undoubtedly. And that is the catch point that they ask you. Now I am for INI-CET, I'm not expecting the usual cirrhosis wala questions. I'm expecting mid-zonal necrosis questions. What is mid-zonal necrosis? A very brief. I hope you remember this is how the liver used to look like. That is a usual hexagonal lobule. Center mein kya hota hai? It is the central vein, and in the periphery what you have is the portal triad, right? Center mein central vein, periphery pe portal triad. So of course I'm talking about the zone in between these two. In between, in the center, that is the mid zone, and mid-zonal necrosis. This mid zone going off is what you see in yellow fever. More on yellow fever I will teach you when we go to microbiology, but a quick review. What is the vaccine for yellow fever that they really ask you in PSM, also in microbiology also? That is the 17D vaccine. I hope you remember that is a live attenuated kind of a vaccine, and live attenuated vaccines are usually said to be contraindicated in pregnancy. So although nowadays they are taking a chance, but theoretically speaking they are contraindicated. Someone said Gerillin, nahi. Gerillin is the vaccine strain for what? See, I always taught you in your RR videos, Jerry is a cute little bacha. Cute little bacha is that cute bacha with chubby cheeks, that is whom you see in mumps, because mumps ka bacha chubby cheeks because of parotitis, right? So Jerry is that cute bacha. Gerillin is the strain for mumps, not for yellow fever. For yellow fever it is 17D. Chalo, ho gaya. This was one thing which I just wanted to tell you because it's a path micro correlate. Now, because you're talking about liver, why don't we do another question also to do with liver? Which of the following statement is incorrect about fibrolamellar carcinoma? Now, fibrolamellar carcinoma, even if the organ is not mentioned, it is what you will assume that they have given to you for liver only, because there is no other fibrolamellar in the body which is as important as this. Even can be used in pregnancy, you are right, Mustafiz. That is exactly what I was saying. Theoretically, 17D vaccine is live attenuated, should not be used in pregnancy, but now if a person is traveling and she's pregnant and all those complications come in, so nowadays they are saying it can be used in pregnancy. Okay, coming back, fibrolamellar carcinoma, you had to pick up the incorrect statement, and I have got some answers that it is associated with hepatitis B and C. Ye galat hai. To chalo, what I'll do, this is the same screenshot from your RR videos. All of you are going to fill in the blanks and you will do one quick review with me. When I'm talking about liver tumors, before I start, which is the most common liver malignancy, if someone asks you? Most common liver malignancy is not hepatocellular carcinoma, in case you were going to type it. Most common liver malignancy is going to be metastasis, and usually it is from the intestinal cancer. Colonic cancer metastasis tends to come to the liver. These are some questions that you have to be careful. So if I ask you, which is the most common cancer in the brain? It is metastasis. Which is the most common cancer in the heart? Metastasis. Most common cancer in the lungs? Metastasis. Most common cancer in the liver? Metastasis. Most common cancer in the bone? Metastasis. These are the 5 organs, and I've gone pretty much head to toe if you look carefully. In the brain, metastasis. In the heart and lung, it is going to be metastasis, and liver and bone. All of these are going to be answer 1, metastasis. But if they don't have metastasis in the options, now these were there in the options, then of course the most common is hepatocellular carcinoma, and the classical variety of hepatocellular carcinoma is going to be the most common over here. So quickly fill in one column with me. What is the age? Hepatocellular carcinoma classically occurs after that 40s, also book mein likha hai, but वैसे 50-60 tak hota hai. It's an old age thing, right? And because of alcohol consumption, it is more commonly seen in males. Is it associated with hepatitis? Yes, you must have read in medicine also, hepatitis B and C are associated with this condition. What is the tumor marker? And you cannot mess up on this. This is the most important. Alpha fetoprotein levels will be elevated. Before I move forward, alpha fetoprotein levels are increased in 3 things. Of course, we all know in gynae it is the yolk sac tumor. In pathology, it is hepatocellular carcinoma, and one more thing in pathology, that is hepatoblastoma. Very good. Coming to the next, how will it spread? Liver has hepatic vein, it will go into the vein, it will spread. So what will I say? That the spread is going to be via blood, that is going to be hematogenous, it is going to be via blood, and hepatic vein, common sense. And we all know that unfortunately the prognosis of this patient is going to be poor, they don't have much of a survival. This was the usual classical HCC. Iska opposite kar do. There is a variant called fibrolamellar HCC. Do everything opposite. Is that occurring in old age? No, that occurs in the 19s. How I have learned, fibrolamellar age group is also 19 years of age. And if I talk about, is it because of some hepatitis? No, it is not hepatitis B and C. It is deletion chromosome 19. So 19 years of age and 19 chromosome deletion, and I'm settled with this. Okay, 19, this means you have entered into adulthood. You are now very, very tensed. Your nerves are very tensed. What is my future career and income going to be in life? So now your tumor marker is not alpha fetoprotein. Now it's tensin. Now it's a lot of tension. So there is neurotensin which is elevated. Please remember, alpha fetoprotein likha hoga. The levels of AFP are normal. If I have someone with hepatocellular carcinoma and alpha fetoprotein levels are written as normal, it is pakka a case of fibrolamellar HCC. Coming further, everything ulta. Is there any male-female problem over here? No, it can happen in any gender. How is it going to spread? Opposite, it will go into the lymphatic, and then God was kind that, oh, it's occurring in such a young little lad, then let me make the prognosis also good. So God decided to make a better prognosis. Sab kuch ulta kara. So how I've learned, last day, fibrolamellar, 19 years of age. 19 is the chromosome deletion, and that is the age of a lot of tension. So that is going to be neurotensin. Coming back, they asked you, fibrolamellar, is it an intrachromosomal deletion of chromosome 19? Yes. Is neurotensin the tumor marker? Is it lymphatic route spread? All these are correct. Is it associated with hepatitis B and C? No, it is not. It is chromosome 19 problem. So this question is also done. Are we okay with this? Can I move on to, abhi we are talking too much about chromosomes, to ek aur chromosome ka question kar lete hain. This is a pure AIMS exam question. Once upon a time it used to be, okay, but now when INI-CET came into it, they kind of got lost and they forgot this table. I feel this table is going to do a comeback very soon, either in this or in the next session. So I think you should be prepared for this. They ask you, infantile fibrosarcoma is associated with infantile fibrosarcoma. Yes guys, I've got option B and C mein confusion hai. The correct answer is going to be translocation 12 and 15. Now, as I said, this used to be like till 2020, it was AIMS and JIPMER mein to pakka wala one question had to come, and then they kind of lost track. But today we will get it back. So what are these? These are all said to be soft tissue tumors. If you go into Robbins, there is one entire table of soft tissue tumors that they make you do, and that's the most impossible table to learn. Today we will try our level best that we can learn that table. So let me start with this only that I have just now taught you. When I say infant, infant is what age? It is till 12 months of age, right? And fibrosarcoma reminds me of 15. So infant 12, 5, 15. So now what is the translocation going to be? Translocation 12, 15. Is that okay with everyone? Infantile fibrosarcoma. Now let's move forward. Let's try and ask you, what is translocation 11, 22 for? This you've read somewhere in bone tumors. You know that. 11 for Ewing's sarcoma. So let's start my journey from here. I've got you that entire table of Robbins, but I've written it in my own handwriting so that you have a visual memory. When I talk about Ewing's, E for, they will say, oh, E for 11. So chromosome first that you will write is going to be chromosome 11. And when they say sarcoma, the S can flip and look like a 2. So now the next chromosome is going to be 22. Yaad rahega? Translocation 11, 22, but they don't stop here. They say when there is translocation 11, 22, it is which genes that are fusing? Very simple. Ewing's sarcoma, it is the EWS gene, Ewing's, and wings help you fly. So wing sarcoma with fly gene fusion is going to be seen when it comes to Ewing sarcoma. Acha, ortho ka you guys have had LRRs and you've of course read. Can you tell me something on radiology about Ewing sarcoma, which is very characteristic? And I've written that photo. It shows you that periosteal reaction. It shows you that onion skin appearance, which is very important. And yeah, so please let me know if we are connected back. I believe there was a minor 10-second lag which led to disconnection. I'll just quickly give you a recap of what I just told you. When I talk about Ewing sarcoma, E for 11 and sarcoma for 22, the gene is going to be EWS and the wings help you fly. So EWS and fly fusion. Pehla ho gaya. Now look at the next one. Maybe you've never seen a patient of this and you will never see a patient of this also, but they will ask you in the exam. This is a soft tissue tumor which is known as what? It is desmoplastic small round cell tumor, and it's impossible to learn, but then I look at the translocation and the translocation is the same. And what is the translocation? It is again translocation 11, 22. Yes, so now tell me, how do I learn? Desmoplastic, dobara Ewing's sarcoma. Sorry, but that's that's the best way I could pick it out of how to make you learn it. It was Dobara Ewing's sarcoma. So means it is again going to be translocation 1122. Let's start further. There is a type of a chondrosarcoma for which translocation. These are only INI. Learn for INI and then forget it forever. Okay, that is how it is. There is something known as extraskeletal myxoid chondrosarcoma. If you look carefully, extraskeletal myxoid chondrosarcoma. So of course it's a kind of a chondrosarcoma you've heard of, but you've heard of chondrosarcoma in the bone. I'm talking about chondrosarcoma outside the bone, somewhere in the thigh or the muscle or the tissue. So extraskeletal myxoid chondrosarcoma shows you translocation 922. Who will tell me where do we study translocation 922? This is reminding me of Philadelphia chromosome, which I see in CML. So where do I see Philadelphia chromosome? I see it in CML. Now I just need to read it opposite. If I read it like this, it is going to be CML. If I just twist it and read it a little other way around, it becomes extraskeletal myxoid chondrosarcoma. So both of them show you what? It shows you the translocation 922. Ye dono तीनों याद हो गए? We will do a revision in the end. What others? There are two more soft tissue tumors, synovial sarcoma and alveolar soft part sarcoma. These are all soft tissue tumors. So remember, both of them are translocations involving chromosome X. Synovial. So remember, sin. You always commit, bacche, kids never commit any sin. Only adults commit sins, right? So sins and bad activities are only done by adults. That is why synovial sarcoma is going to be translocation X and 18 for adult age. Whereas alveolar soft part sarcoma, these are in soft-hearted kids, and anyone who is less than 18 will be soft-hearted. That is how we've learned it. Yaad rahega, synovial sarcoma, sin committed at 18 years. So X18, and alveolar soft part sarcoma is going to be translocation X17. Coming back to my question, infantile fibrosarcoma, infant is 12, fibro is 15. Now you tell me, very good, Dr. Ripunjay has said that, ma'am, in orthopedics, we had read that synovial sarcoma is a biphasic tumor. Perfect. But then now that you've told me that, I will ask you in pathology, which is a triphasic tumor in the kidney that they ask you. Triphasic. Pehle to biphasic means that in pathology slide, you will see two parts. Epithelial part also and mesenchymal part also. When you see epithelial and mesenchymal both, that is known as biphasic. So yeah, that is a case of synovial sarcoma. But if you see epithelial, mesenchymal and blastema means something to do with embryonic tissue. Very good. It is now a case of Wilms tumor. Wilms tumor in the bachcha, of course, it's a childhood renal tumor. That is going to show you be a triphasic tumor. Very good. All of you are right. So coming back, a very quick recap. If I will ask you the tumor, you quickly give me a list of all the numbers. When I ask you about Ewing's sarcoma, just don't write the full thing, give me numbers as a short form. Which translocation? E for 11, sarcoma for 2. So translocation 1122. When I say desmoplastic small round cell tumor, desmoplastic small round cell tumor was Dobara Ewing's sarcoma. So that was also translocation 1122. When I say infantile fibrosarcoma, infant is 12 and fibro is 15. Very good, translocation 1215. Now if I say synovial or synovial sarcoma, so that is going to be sin at the age of 18, so translocation X18. If I say, very good, the toughest table you guys are answering so well. If I say alveolar soft part sarcoma, so you'll say soft-hearted people are the ones who are less than 18, bachas, that is X17. Now itna acha sab kuch pad liya, then do two more and finish the entire Robbins ka table. Now the last two are from dermatology. In dermatology, have you heard of DFSP, dermatofibrosarcoma protuberans? This also shows you translocation 1722, and nodular fasciitis also shows you translocation 2217. So you will say, ma'am, chromosome number to wahi hai, but what gene is moving from where will tell me whether it is 1722 or whether it is 2217. Now that is what you have to watch out. Sunne mein it's the same, but it's a lot different when you talk about genetics, because which gene is moving from which chromosome is why 1722 and 2217 are different. So now what will you think of that? Okay, dono ka 17 and 22 hai. So 22, whenever, if you remember, how many of you ever played, there's an Indian game called Tambola. And if you've seen your in your childhood people playing around you, so whenever they had to say the number 22, they always used to say two big fat bellies. That is how they used to objectify and body shame people, but that is how always tambola was, right? So tambola mein they will always used to say two big fat bellies 22. For some reason, that's how they used to describe it. So now you have to look at the same belly, the tumors. If you look at the names of these tumors, there is something protruding in these tumors. Dermatofibrosarcoma protuberans. It comes above the skin. Skin ke upar hota hai, protuberans. Whereas nodular fasciitis, there is a nodule also which is protubering. So now just look at where is the big fat belly placed. Agar wo starting mein placed hai, nodular fasciitis, so then you make it 20 to 17. If it is dermatofibrosarcoma protuberans, agar end mein word aa raha hai, then you place the bellies later on, right? So this is how we are going to define it. Is that okay with everyone? Wherever the word protuberance baad mein aata hai, to protruding belly 22 comes later. Nodular word comes first, so in that the 22 word comes earlier. Now you finally complete your list. You have finished the toughest table of Robbins. Dermatofibrosarcoma protuberans. What will you write it? 1722 or 2217? That will become 1722. Whereas when I talk about ulta, when I say I'm talking about nodular fasciitis, now nodular will say it is going to be 2217. Bas khatam. This was the table that you were so scared of. Now don't open Robbins because all of it is already written over here. So I think I can move forward and go on to little easier things in life. Not so easy, but abhi I'm starting me because you're alert. I want to give you the tougher things, bombard you with tougher things so that the tough things fit in your brain. The easier ones you have anyway read in your rapid revisions. So no point just telling you easy things again and again. One more thoda sa tough question. Which of the following statement regarding polymyositis is most accurate? I have seen students don't understand muscle biopsies in the exam. One very big problem. So let's tackle that in one slide. You know two myositis, polymyositis and dermatomyositis. So between these two myositis, now you guys have to tell me कि कैसे इसको हम differentiate करें. First select one answer. This is also from your Q bank only, by the way. So polymyositis is CD4 T cells, pathogenesis is significant vascular injury, polymyositis is associated with cutaneous features, or polymyositis, the inflammation is endomysial. I can see many of you are answering A and B. I knew that I'll get wrong answers over here. See, now first you have to tell me, they've asked you most accurate. Okay, so there could be some statements which are very close to being correct, but I have to select the most accurate one. So let me first teach you something. Let's start with, firstly, no one said C because polymyositis having cutaneous features is stupid, right? That cannot happen. When I'm talking about cutaneous features, that has to be which myositis? That has to be dermatomyositis. It cannot be polymyositis. So ye wala to pakka hi galat tha. Next, is it going to be a vascular injury? Is that correct? No. Polymyositis is an autoimmune disorder, guys. There are autoantibodies in polymyositis and dermatomyositis. It is not a vascular injury. It is an autoimmune disorder. Autoimmune matlab there will be CD4, CD8 T cells involved, antibodies involved. Is it characterized by more of CD4 T cells? No. It is CD8 T cells more than CD4 T cells. So this statement was also wrong. The correct statement was this, that the inflammation is endomysial. So what I'll do, I will show you a picture of how to pick up on pathology. How do we differentiate dermatomyositis versus polymyositis? So wrap up, listen to this very, very carefully. Let's start. When I say dermato, pehle to dermato mein na, if you say ma'am in the exam I don't understand all this na, pink and blue nahi samajh aata, never mind, ignore it. Dermatomyositis, they will have to tell me some derma manifestations. Right now you must have gone through the derma LRR with Khushbu ma'am also. So let me know कि dermatomyositis में क्या derma में क्या क्या दिखता है. Can you just quickly wrap up this flashcard with me? In this, firstly, what you see around the eyes is a rash which is known as the heliotrope rash. Very good. Then very good, Khushi says that ma'am on the knuckles and on the phalanges we get to see these rashes which are known as Gottron papules. Very, very good. Then we see rashes on the front of the neck. The front of the neck can look like a V or a necklace sign, like the patient is wearing a necklace. And same rash you can see on the back also. So on the back, what will you call it? You will call it as if the patient is wearing a shawl. So that is known as the shawl sign. I can see everyone's answering this very well. तो ये सबको पता ही अच्छा वाला revision हो गया. Now what can I take it forward towards? I can say that over here there is, look at this, look at the crusting and the hardness and the thickening of the hands that has occurred. So this is of course a case of mechanic hands. ये features होंगे, then you will make dermatomyositis. Without this cutaneous manifestation, you will not make. So derma I have understood. Now tell me the myositis part. Is it proximal muscle problem or is it a distal muscle weakness? So any kind of myositis that we deal about is going to be a proximal muscle weakness. So now let me actually tell you, very good, Dr. Day is right that these two photos are the most famous ones, but nowadays they've stopped giving such famous photos. They try to give you little bit of uncommon manifestations also. But now before I go on into details and go back to that histopath, dekho, there are three types of myositis. One you have told me dermatomyositis, one you have told me polymyositis, and then I will tell you one more in medicine which is known as inclusion body myositis. Ye wala topic somehow students don't have the capacity only to read it, because after reading so much, by the time they reach muscle chapter, they are so exhausted that they leave it. Hence, I'm teaching you over here in the beginning. Please remember that dermatomyositis and polymyositis are going to be proximal muscle weakness. They are proximal muscle involvement, whereas inclusion body myositis, everything in inclusion body myositis might be written as IBM in the paper. Everything in IBM is late. Means at what age does it occur? It occurs in old people, it occurs late in life, elderly, and distal part of your life it will occur in. And what muscle group will be affected? The distal muscle group will be affected. This is a problem in the distal muscles. So repeating, it is distal age and distal muscle. That is inclusion body myositis. Poly and dermato are proximal. You are right. You are saying patient cannot stand easily. Perfect. Ab aata hai main trouble. How should I differentiate it on histopathology? So what you will see in polymyositis, what you have to see over here, guys, pehle to please do give me your pathological difference. Khushi, exactly what I'm telling you. So tell me something now. Can you all see these are the round pink color का क्या है? These are all muscle. You will say, ma'am, muscle ऐसा कैसे? Muscle तो हम ऐसा draw करते हैं. We used to draw in our histopath folders like this in MBBS. I have cut the muscle from center, cross section liya. That is what I have done. So on cross section, this is how goal the muscle is going to look like. Muscle dekh liya, myo part is done. Now you have to talk about the itis part. Where is inflammation? So you tell me, all these blue color dot that are seeing, these are inflammation. ये वो CD4, CD8 T cells, this is inflammation. Autoimmune disorder hai. Is the inflammation seen at the periphery? Means is it perimysial, or the inflammation is seen within the muscle, endomysial? You tell me your own observation. Batao, because many of you have this problem कि मैम exam में समझ नहीं आता. Is it seen at the periphery, perimysial, or is it seen endomysial? You answered it yourself. What kind of inflammation do you see in polymyositis? You see inflammation within, means there is going to be endomysial inflammation noted. Okay, now let's go to dermatomyositis. You tell me your observation over there also. First, what will you see? That ma'am, jo goal tha, these were all the muscle fibers. You told us muscle has been cut like that, so it is all goal. So now look at it very carefully, and I want you to see this बहुत ध्यान से. If you look a little carefully and try to compare, look at the muscle in the center, big muscle bundles I can see, and try comparing it with what has happened at the periphery. Can you all notice periphery पे जो muscle बन रहा है, that is a little smaller somehow. Look at the muscle fibers always at the periphery. Ma'am, they are becoming chota, they are becoming atrophied. One finding. Second, all that blue color dot that you were saying, that is also at the periphery. So in dermatomyositis, everything is at the periphery. There is perifascicular, muscle becomes chota, atrophy, and the inflammation is also perifascicular. Now will you be able to memorize this? That polymyositis mein the inflammation is inside, it is endomysial, and dermato mein to everything is periphery muscle also becomes chota, that is atrophied, periphery inflammation is also seen. Come back to your question. Over here they said in polymyositis, inflammatory infiltrates are endomysial in location. This was the most accurate statement that I could pick up over here. Now is it okay? Khushi, you've understood. Everyone else, pathology samajh aa gaya of poly versus dermato. Now you won't mess up. Just in case in the exam you forget all this, go by the simple rule that dermato mein derma manifestations will have to be there. We are done with this. Lot of tough things done. Let's move on to the last year's question, which I've twisted a little, but I think you will be able to answer. There is a 60-year-old person, switch off soft tissue done, thoda badalte hain topic, okay? 60-year-old person presented with some stomach tumor, at least organ is given. There is a mesenchymal mass which is present below the mucosa of the stomach. spindle-shaped cells and epithelioid cells are seen on biopsy. This tumor is positive for typical INI-CET question where a lot of options are there and they will tell you that, oh, mix and match and tell us the correct answer. So let's take your take first on this. Everyone is saying option D hai ma'am, A, B, C, matlab 1, 2, 3, 4. D is maximum what I've got. ठीक है, very good. So first tell me what diagnosis did you make, because as soon as they said it's a stomach tumor, and if you realize what is written, they said below the mucosa. See, my basic ideology I should not move away from. Basic ideology is mucosa matlab epithelium. When I talk about mucosa, that is epithelium. Epithelium say always what arises? Carcinomas arise. If they would have said adenocarcinoma, the mucosa would have been damaged. Mucosa mein problem hota, epithelium mein problem hota. They said there is a mesenchymal tumor. It is not an epithelial tumor. It is a mesenchymal tumor below the mucosa. Means there is a tumor which is here, mesenchymal. The most common mesenchymal tumor of the stomach is GIST. Exactly. So now I have to answer some questions on GIST. Gastrointestinal stromal tumor. Something about this came in your last year's exam, precisely why I'm discussing it today. First, tell me what is the cell of origin. The cell of origin is the cell of Cajal. What is famous about the cell of Cajal otherwise in you and me normal people? Cell of Cajal is said to be the pacemaker of the GIT, right? So like pacemaker, we used to have that NEET UG question hota tha na, what is the pacemaker of the heart essay node? So NEET PG question is what is the pacemaker of the GIT, that is cells of Cajal. All of us have it. But now the problem is that in the cell of Cajal, if we end up having a c-KIT or CD117 mutation, a c-KIT or CD117 mutation, that is when I am worried. Why am I worried? Because as soon as CD117 mutation occurs, there is an increase in an enzyme called tyrosine kinase. Now tell me, this increase in tyrosine kinase will cause GIST. This I know. So if I have to do the treatment of GIST, what is that going to be? The treatment of GIST will be a tyrosine kinase inhibitor, exactly, and the name of that inhibitor is imatinib. यहाँ तक का story तो पता था, for NEET also, for FMGE also. What for INI-CET extra? They said okay, all this is fine, this is the most common mutation, but what other mutations can be seen in GIST? That is what was asked. So this is mutation number 1. What is mutation number 2? It is the PDGFR mutation. PDGFR. PDGF is a growth factor receptor. So platelet derived growth factor receptor mutation. Full form is not needed for you to know. So PDGFR mutation was asked in the last exam. And number 3, and this PDGFR you might have missed out in your rapid revision, and hence I'm telling you because main videos mein tha. And next, it can also show you SDH mutation. SDH, if you remember from your biochemistry, it is succinate dehydrogenase. Yes, and succinate dehydrogenase, excellent. You say it is seen in small kids. Basically, it is associated with pediatric GIST. These are the 3 mutations जो अब आपको INI के लिए याद करके जाना है. c-KIT you anyway know, PDGFR mutation and your SDH mutation. Mutations are done because now I come down to which is the most common site. Gastro and intestinal. It can occur in stomach also, it can occur in intestine also. But which is the more common site? Obviously, the word that comes first is gastro. So the more common site is going to be the stomach. Yes, it's in RR. Earlier it was not, Dr. Vikalp, it was not. So I had added it as one addition. I had added it as an extra line later on. So yeah, it has been added now, of course. So the most common site, and by the way, for others, I don't know how many of you have seen RR 5.0 versus RR 6.0. If you've seen 5.0, stick to 5.0 and then go to my Telegram group. I have posted one PDF regarding what all additions I have made in 6.0. So then that doesn't mean you have to go through the entire 6.0 to find out that ma'am ne kya do line add kara, one MCQ added. All those additions chapter wise I have added so that you would save out on your time. If you've never seen rapid revision earlier, then don't get into this confusion, then directly pick up RR 6.0. Okay, coming back, now left with the markers. Yes, very good, excellent. So Khushi, exactly why karna hai. There's not much of a change. I would say 10% change hai because I've added the recent exam questions, the recent INI questions, NEET questions, FMG. So because of that, obviously updates are there, but aisa kuch overall 90% of pathology shall remain the same, right? Okay, coming back, now coming to markers. Agla question. Best part about GIST is Mutation and marker is the same. This means the marker is CD117 or c-KIT, that is the marker. There is one more CD marker, that is CD34, and there is one more marker, that is DOG1. There are three markers, CD117, CD34 and DOG1. But now what you have to know, sensitive and specific. Very good, you guys have told me. Which is the most sensitive marker? It is CD117. And which is the most specific marker? It is going to be DOG1. So now let me come back to the question. When I said CD117 and c-KIT, वो तो दोनों same चीज है, that is a marker. CD34 is a marker, DOG1 is the specific marker. So the correct answer to this was all four, that is 1, 2, 3, 4. It was not CD99. So now you will tell me CD99 कहाँ होता है. Although CD markers is for tomorrow or day after tomorrow when we have the next part, but CD99 कहाँ होता है? तो सबसे पहले it is seen in a bone tumor, that is going to be Ewing sarcoma. Everything about Ewing sarcoma we have done today. If I say Ewing sarcoma, radiology you guys told me onion peel appearance, then location you guys told me it was diaphyseal in location, translocation abhi pada tha was translocation 1122. Now you're telling me what is the CD marker? It is CD99. Please remember, for Ewing sarcoma, CD99 is also known as MYC2. For Ewing sarcoma, the question does not come in, and AIMS का तो ये favorite होता था. I don't know, millions of times this has been repeated. MYC2 is a marker of. So MYC2 is a marker of. Simple, you will say it is Ewing sarcoma. How I have personally learnt it, I will share with you. MYC2 sounds again like in India the famous pet name that we have is Mithu. छोटे बच्चे को, that is what they call him Mithu. Why did I say Mithu to MYC2? Because when I ask you, all bone tumors are seen in that old age वाला situation ना, 30, 40, 50, 60, वो वाले age में दिखता है. Which is the one that can be seen in adolescent and kids. Adolescents में जो bone tumor होता है, that is going to be Ewing sarcoma. So Ewings can occur in MYC2. That is why the tumor marker is, or the genetic CD marker CD99 is also known as MYC2. Yes, it is seen in adolescents. CD99, it can also be seen in a 99-year-old female. 99 is just for learning. Basically an old female, a post-menopausal female, and which is the tumor that occurs in post-menopausal female in the ovary. Granulosa cell tumor of the ovary, and we have always learned granulosa cell tumor occurs in grannies, 99-year-old grannies, old women. Perfectly right. Now coming back, someone said MYC and MYC are different. Bilkul, Khushi is right. See now, so that Bella, I'll finish this question. This is done, everyone. Gist is done. You have learned the gist ke markers. You've learned CD99 is a marker of this Mithu wala bacha, as well as for granny 99-year-old. Now Khushi has brought up something which is very, very valid, and that is that, ma'am, there are a lot of MYCs that we talk about. So for example, right now we said it was MYC2, and MYC2 was nothing but CD99. You are correct. Then Khushi said there is something called MYC also, ma'am. MYC is the name of a gene, MYC. There are three types of MYC if you remember. C-MYC, L-MYC, N-MYC. Kuch yaad aa raha hai? C-MYC, L-MYC, N-MYC. So if you tell me something, then I will ask you more questions. So tell me, C-MYC, L-MYC, N-MYC, what are they going to be the mutations of? I'll give you some hints. N-MYC was for N, that is neuroblastoma. L-MYC was for L, that is lung cancer. Which lung cancer? Small cell lung cancer. All the L, small cell lung cancer. And C-MYC, yes, C for child, which is the lymphoma that occurs in children, bachas. Very good. Burkitt's lymphoma. So this was a separate MYC that you have. Okay with everyone? Ye MYC wala MYC hai. The other one right now, MYC2, wo CD99 alag tha. Now that you mentioned it, I will have to complete it. Do you know there is also something known as MIB1 labeling index? For INI-CET, you should be knowing this. MIB1 labeling index, sunne mein it's very, very scary. It is not at all scary. It is the other name of Ki-67. Now you will tell me, which are the two places in path and surgery that you study Ki-67? First, I'll tell you, hota kya hai? Labeling index, ma'am, you are telling us an index. What does it mean? It is a proliferation marker. Proliferation marker means it will just tell me, like when a pathologist says Ki-67 is 10%, ya fir if I say Ki-67 is 90%, what am I trying to tell you? How much is the tumor proliferating? If I say Ki-67 is 10%, matlab tumor is okay proliferating. But if I say Ki-67 is 95%, oh, the tumor is dividing like anything. The tumor is highly proliferative. And do you know that Ki-67 for Burkitt's lymphoma, Ki-67 for Burkitt's lymphoma is near about 100%. near about 100%. They will write something like Ki67 is 99, 98, 97%. You know they are dealing with Burkitt's. Means Burkitt's divides at a rate that you can't even imagine. Second, Ki67 is very important for breast cancer, which I will teach you in a while. In surgery, surgery, I think LRR is tomorrow only, but otherwise you know that in surgery for breast cancer, there is something called luminal A category, and then there's something called luminal B category. Luminal A category, Ki67 is less than 14%. Luminal B category, Ki67 is more than 14%. What do you think if I ask you, ये तो रट लिया, that okay, for breast cancer, Ki67 is less than 14 and more than 14. You tell me that which of them is more proliferative. What does that mean? Interpretation. More proliferation of breast cancer is seen in which category? Luminal A or luminal B? Obviously, more the number, more the proliferation. Before that, now I have two doubts, very valid doubts. Someone had asked me, Tanay wants a repeat of it. Very good. We will just repeat this Ki67 jaldi se. And now very genuine doubt has come, ma'am, is Ki67 hai kya? Is this something that the tumor is making? No. Now, see, what is the tumor doing? Let's keep it very simple. The tumor is proliferating. What are the cancer cells doing? Cancer cells have come for only one thing in this world: divide, 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 and keep on spreading. So they are dividing and they are spreading. I want to find out. I, as a pathologist, want to make things complicated. I can't let it be simple, right? That is what pathology is. So then I decided, let's try and see how much is this tumor proliferating. Not that I want to torture you, but I want to find out that if this tumor is, you know, if a tumor is highly proliferative, what do you think is going to be the impact of chemotherapy on that tumor? More the cells are dividing, it will be easier to kill them with chemotherapy. That is the entire agenda. So I want to find out, cancer कैसे divide कर रहा है? जल्दी जल्दी divide कर रहा है? Is it dividing a lot? If it is dividing a lot, then this means chemotherapy is going to have a very good role in it. Is it dividing less? Then probably chemotherapy is going to have a little lesser role in it. So now to find out that proliferation, I have a test. Ki67 कोई बना नहीं रहा. Ki67 is a marker, is a stain. You all have heard of immunohistochemistry, that brown color stain of pathology. Ki67 is a immunohistochemistry stain. So I apply a few drops of Ki67 on the slide, and then I count how many percentage of tumor cells have come positive. 90% have come positive, 10% have come positive. So this is a staining that I am doing. Ki67 the tumor cells are not making. Is that okay? But more details on IHC are coming up soon. So before that, MYC2 is going to be CD99. MYC is a separate gene, वो अलग चलता है, and MIB1 labeling index, Dr. Tanay, is the other name of Ki67. It tells me how much is the tumor proliferating. So more the number that I get, more the tumor is proliferating. Burkitt's is 100%, मतलब Burkitt's तो divides beyond the roof. Sky is the limit. And why did I say sky is the limit for Burkitt's? Because Burkitt's shows you that starry sky pattern also. So for Burkitt's, sky is the limit. It shows you starry sky pattern. Proliferation करता करता 100% पहुंच जाएगा proliferation. It proliferates a lot. Breast cancers also, they might proliferate, they might not proliferate. So luminal A breast cancers less than 14% means less proliferative. Luminal B breast cancers more than 14% means more proliferative. Okay with this, Dr. Tanay and everyone else? Because now coming back, this entire story started because we were referring to GIST. Now because we were referring to GIST and हम थोड़ा सा sideline हो गए, let me get you back. We were talking about stomach tumors. So now I've got you 2-3 photos which I want बिना MCQ के fill in the blank कर दो. These 2-3 pictures of stomach are very important. So you tell me, when I talk about stomach and they will give you this kind of a picture, even if you don't read anything, can you give me the diagnosis? This is a stomach and this is showing you the stomach has started looking like a walnut. It has started looking like the brain. So if it has started looking, no, this is not FAP. Stomach, no, FAP will have polyps. This is a case of, yes, when the stomach starts looking like the brain, it is a case of Menetrier's disease. Exactly. So now let us understand what is Menetrier's disease. Menetrier's disease is a mutation, genetic problem. Genetic problem ki wajah se which mediator increases, TGF alpha increases. So if someone asks you, why does someone suffer from Menetrier's disease? Because TGF alpha increases. Examiner will see, someone said TNF beta, then someone will say after some time, ma'am, TNF alpha, someone will say TGF beta. So much of confusion. Let us settle it. Nahi hona confuse exam mein. Last year a question aaya tha. You have 3 different things. There is something called TNF alpha, there is something called TGF alpha, and there is something called TGF beta, and all 3 will be there in the options. Examiner is damn sadistic over here. वो तीनों options देता है और फिर पूछता है. So now tell me, NF alpha stands for no food appetite. When you say I'm not feeling hungry, मुझे appetite नहीं है, fever में I don't feel hungry, so no food appetite. Why does our appetite decrease? Because of TNF alpha. अब याद रहेगा, no food appetite is TNF alpha. When I say TGF alpha, G and A stand for the gastric disease. That is when you will mark Menetrier's disease and not get confused. Is that okay? Menetrier's is gastric ka problem, so G and A. And abhi last time ka question was, which is the most fibrogenic cytokine? Most fibrogenic means the one that is going to create lot of fibrosis in your body. So बहुत fibrosis, or for those who don't understand Hindi, बहुत fibrosis is big time fibrosis. So बहुत fibrosis or big time fibrosis is going to be caused by whom? It is TGF beta. Please don't get confused between these three. They are pakka wala questions and they will always give you these three options. So when they ask you most fibrogenic, a quick repeat, let me ask you without you looking at it. When they ask you which is the most fibrogenic, बहुत fibrosis, TGF beta. When I say patient is having fever and he's saying that I'm not feeling hungry, my appetite has gone down, so you will say no food appetite, TNF alpha. And when I say there's a patient with stomach looking like the brain, you will say, oh, gastric problem, that is TGF alpha. Why did you say gastric problem? Because I am seeing giant cerebriform rugae. Look at the stomach has started looking like the brain. So this is, isn't it looking like salkai gaira brain ka lag raha hai? So giant cerebriform appearance has started coming up. But when I talk about pathology, which is the cell, there is foveolar cell increase. There is a foveolar cell hyperplasia that I notice. प्रॉब्लम क्या हुआ पेशेंट को, ये सब तो समझ आ गया, बट बिकॉज ऑफ दिस फोवियोलर सेल हाइपरप्लेजिया व्हाट एक्चुअली हैपेंस इज दैट पेशेंट स्टार्ट्स लूजिंग प्रोटीन मतलब दिस इज अ प्रोटीन लूजिंग एंटेरोपैथी, एंड एनीवन हु विल लूज प्रोटीन will end up with what? Attacks of edema, swelling, and that is how the patient comes to you. Patient has multiple intermittent attacks of edema. Patient is having, this photo will be given. This is the gross examination of the picture. Then they will ask you either the mediator or the cell increasing. ऐसा कुछ question होगा. But edema will be there when it comes clinically. ये खत्म हो गया. और क्या क्या आता है? एक तो gist पे question आता है, पढ़ लिया. Menetriers पे question आता है, पढ़ लिया. Now you get a question on this leather bottle stomach. Can you tell me the questions of this also? Leather bottle stomach, we all know it is known as linitis plastica. The stomach is looking like a leather bottle. Leather bottle is not like it's not like plastic. It's not like those Bisleri bottles of yours which you can crush and throw. No, leather is stiff. It's very tough. You can't squeeze that bottle. So the stomach has become very tough. Why? Because there's a cancer inside it. Which cancer? Excellent. There is going to be diffuse gastric cancer. Diffuse word only tells me the cancer is all over. If you look carefully in the wall, cancer is everywhere. This white color wall. This is the entire diffuse gastric cancer. क्यों होता है? What is the genetics? It is because of a decrease in which molecule? It is because of a decrease in E-cadherin. I will tell you a little bit more about E-cadherin gradually. So it is a decrease in E-cadherin. Now coming to ठीक है कि ये तो हमारा genetic problem हो गया. By the way, in the exam, they will not write E-cadherin. They will write the gene for E-cadherin, and that is the CDH gene. So please don't think that oh हमने कभी पढ़ा नहीं है. E-cadherin is nothing but the CDH gene. It's the same thing. Now coming further, that when I look at this under this microscope, all of you are right, signet ring cells. Before you start describing signet ring to me, can you tell me one ovarian tumor where signet ring cells are seen? Then we will do the description. One ovarian tumor, jaldi bata do, where signet ring cells are seen. They are also seen in Prukenberg tumor. Yes, Prukenberg tumor सुना है ना, metastatic tumor of the ovary. Ovary also shows you this signet ring cell. The stomach also shows you the signet ring cells. तो signet ring मतलब it's going to look like a ring. तो ring में क्या होता है? Ring में of course there is one diamond popping out, one stone coming out. So I can see the nucleus. The nucleus is going to be pushed to the periphery. Why is the nucleus been pushed like a ring to the periphery? Can anyone tell me what is inside? Because someone has come and sit inside the cell, and that is mucin. जैसा जैसा पढ़ा, you will look at it in the photo. If you look carefully, the blue color nucleus has been shifted to the periphery. Everywhere the blue color nucleus is at the periphery. Blue color nucleus is at the periphery. And what is filling the entire cell? Filling of it is caused by mucin. तो अगर ये वाला photo, now be very cautious, ये वाला photo if they give it to you in the stomach, It is Linitis plastica. ये वाला photo, if they give it to you in the ovary, it is going to be Krukenberg tumor. Is that okay with everyone? The first part is done. Now I want to teach you one more thing, and that you will tell me. Whenever they say there is a person with a CDH gene problem or a CDH gene mutation, you will say, oh, CDH means what? Very good. It is E-cadherin. So you will say in simple words, there is a loss of E-cadherin. First, tell me guys, what is E-cadherin? Normally, anatomy में पढ़ते हो, what is E-cadherin? E-cadherin is something which combines all the cells together. It is going to be a cell to cell adhesion molecule. I call it glue, Fevicol. E-cadherin is nothing but cells को जोड़ता है in normally in all of us. I am saying that E-cadherin has been lost. E-cadherin has been lost means the glue is gone. Very good. So now you know, okay ma'am, जब glue चला जाएगा, patient is going to have GO-LU tumors. When the glue goes away, patient has GO-LU tumors. What is the GO? The gastric cancer, अभी पढ़ा था. And what is the LU? In breast, you know there is invasive lobular cancer. One more question for invasive lobular cancer. Can you tell me what is that appearance of the cells? For invasive lobular cancer of the breast, what is that appearance of the cell? It is the cells are like the Indian army. They are very, very disciplined, standing in a straight line. तो कैसा दिखता है cells? It is known as the Indian file pattern. It is known as the Indian file pattern. Perfect. You are right, guys. Amazing. Coming back, so all this is done. Stomach की सारी चीजें हो गई. Now, obviously, we move on to the next organ. Here you go. There is a 5-year-old child who was admitted in the hospital with history of prolapsing rectal mass and painless rectal bleeding. 5 साल का बच्चा, 5-year kid, rectum is the problem. Which of the following genetic alterations would you consider in your primary diagnosis? Everyone saying A, but okay, let's see some more answers. STK11, सब लोग बनाया क्या? Okay, oh my god, नहीं रुक जाओ, don't copy others, don't copy others, tell me. Okay, I've got one answer, SMAD4. Now the D's are coming. Okay, the D's are coming. Yes, see, our problem is that whenever we say a polyp का question है, Peutz Jeghers होगा, Peutz Jeghers होगा, STK11 होगा. We've assumed कि examiner और कुछ पूछेगा ही नहीं. Don't be in that kind of a hurry. See, when you were talking about Peutz Jeghers, it could have been STK11. Here you are talking about a 5-year-old बच्चा and there is something to do with rectum. तो खुद सोचो, why will a 5-year-old kid have rectal bleeding? Can a 5-year-old kid have rectal cancer? Of course not. 5-year-old kid having something like piles or hemorrhoids? Unlikely. 5-year-old bachcha having rectal bleeding, the first thing I will think of is juvenile rectal polyp only. So that is exactly what you had to think of. Juvenile rectal polyposis. Juvenile tells me that it occurs as roughly around that 5-year wala age, and the child will come to you with bleeding PR. Everything in juvenile rectal polyp is less than 5. Age kya hai? Less than 5. What is the genetic defect? The genetic defect is going to be SMAD4 mutation, SMAD2 mutation, या फिर BMPR1 mutation. For example, you forget the genes in the exam. Chalo, मान लिया. It happens, na? Sometimes you go blank. You forgot the genes in the exam. Can you still attempt? You will say that, ma'am, इसमें ना everything is less than 5. Age of the बच्चा less than 5. Numbers in the genes, if you look carefully, the numbers are going to be less than 5. SMAD2, SMAD4, BMPR1. Would you want to select something like STK11? वैसे भी नहीं select करना चाहोगे. याद रहेगा SMAD4 for juvenile rectal polyp. Then बाकी सब कहाँ select करना चाहोगे? Many of you said STK11. वो क्या होता? That would have been Peutz Jeghers. That would have been the next one that I'm talking about. So let's talk about it. When I say Peutz Jeghers, here everything is 11-11. If I ask you what is the age of onset is going to be after 11 years. If I ask you what is the genetic mutation, you will say, oh, over there, ma'am, it is STK11 gene. याद रहेगा, Peutz is 11-11. 11 years of age के बाद, and STK11 is the gene. So 11-11 for Peutz. Now let's look further. P for Peutz and J for Jeghers. P for Peutz matlab P for patient is going to have pigmentation. Patient is going to have pigmentation. And by the way, we joke about this, that this girl is our examiner's crush, because it has been so many years, and the examiner has, of all exams, the examiner is very loyal towards her. It is always her photo of pigmentation that is given in the exam. So we've always joked about it that the examiner loves her and he always gives her photo. If you see this picture, you don't read much. It is a pigmentation. They are talking about Peutz Jeghers polyp. So P for pigmentation समझ आ गया. J for JE for jejunum. Where are the polyps seen? Most commonly we see jejunal polyps. Most commonly, they are going to be seen jejunal polyps. And can you see the appearance of the polyp? Everyone, this is like staring at you, shouting out. It looks like a gobi cauliflower tree, but they have called it Christmas tree polyp. This is going to be Christmas tree. Now, anything similar to tree, they write. They write only tree, they write Christmas tree, or like you are saying arborizing polyp, chalega na? Kuch bhi. Anything that reminds me of a tree is fitting over here. Now let me go back and let me see if I can solve a question based on this information of mine. This is a question that is given. There is a 17-year-old child which was admitted in the hospital with intussusception. So now this is the clinical aspect that I want to introduce. ये तो हमने देख लिया कि ट्री की तरह पॉलिप निकल रहा है मैम. I didn't even read it. I know it is a case of Peutz-Jeghers. But you know what that polyp does? That polyp tends to pull the intestine down, and this polyp tends to cause intussusception. This, acha, before I move forward and ask you other things, go back to the question. Intussusception micro में PSM में पढ़ते हैं. There is one vaccine. The side effect of that vaccine can cause intussusception. Can you remind me? Intussusception can be caused, number one, by PJ polyp, and intussusception can also be caused by which vaccine? रोटावायरस का तो नहीं, रोटावायरस नहीं कराता, रोटावायरस का वैक्सीन का साइड इफेक्ट होता है. तो रोटावायरस इन्फेक्शन डजंट कॉज इंटरसेप्शन, बट आई वुड से रोटाटेक, रोटारिक्स और रोटावायरस जो वैक्सीन्स का जो भी नाम आएगा ना, याद होते राइट, रोटाटेक or they write rotarix, any kind of rotavirus vaccine that will be mentioned, that can have a side effect of intussusception. Coming back, now more than 11-year-old and Christmas tree polyp, pakka Peutz-Jeghers, they have said which of the following are likely associated, and they have given you multiple correct. Most of you said A and B. Bilkul. 11-year ka bacha, 11-year, 11 STK, 11 correct. Pigmentation has to be there. Others are obviously not seen. So the correct answers were multiple over here. That is going to be A and B. Okay, Khushi says, हाँ. So now, of course, Khushi, there are, I mean, intussusception has many causes. I was just enumerating the ones जो exam में ज़्यादा पूछे जाते हैं. ठीक है? Very good. Now coming back, ये भी हो गया. अब ये दोनों बताओ. Cow-Den syndrome and Benayl-Ruvalcaba-Relay syndrome. Both of them are caused because of the P10 gene. How are we going to cause this? So please remember P10, Cow-Den, chromosome 10. Remember that song that we have done always? P10 chromosome 10 cow-den. P10 chromosome 10 cow-den. क्या क्या होता है? Cow-den is a syndrome. What all does it have? So it is going to have the same mnemonic. That is P10. First you will tell me gynae का कौन सा tumor? It is going to have endometrial carcinomas. Next you will tell me which is the tumor that you have in thyroid. Now let me complete what I started with. Let me complete it. It can show you follicular thyroid cancer. So now I have finally completed all of my thyroid cancer genetics. Which was the most common mutation in thyroid cancer? Follicular. Most common I told you was RAS mutation, right? So RAS was the most common, but other than RAS mutation, P10 gene mutation can also be seen in follicular thyroid. Medullary में नहीं, medullary में तो red gene पड़ा था. Medullary was red gene. Now you have right now studied dermatology also, na? So T से एक और one derma tumor can also occur, that is tricholemoma. Very good. Derma tumor is tricholemoma. And finally P for जो table पढ़ रहे हो, we are reading the table of polyps. So of course it causes polyps. And now I just want to complete the table. So I will have to make this mnemonic. From that P, I will make a B, and which cancer it is? Breast cancer. That is what occurs in a patient of Cowden syndrome. Coming to the next, Benayl-Ruvalcaba-Relay syndrome. By the time I learn this name, students don't learn it only. They say BRR or relay or something because it's very tough to learn. So by the time you learn this, you will become mentally retarded, and patient also becomes mentally retarded. Just a very brutal way of learning it. That in this also, it occurs because of the same P10 gene. But what is extra? Other than polyps, what is extra? We also go mad learning the name. Patient also goes retarded. It is mental retardation. Khatam. Coming to the last one, Cronkhite-Canada syndrome. This is the only one which I don't have to learn any gene for. Non-hereditary means this is not running in the families. This is not running in the families. I'll tell you about the screening also in a while. Coming back, सबका gene बता दो मुझे. Juvenile का तो less than 5 वाले genes होते हैं. Peutz-Jeghers का सब कुछ 11 cow den is P10, 10, 10 wala story. BRR, benign rubalcaba, also P10. Cronchite Canada is non-hereditary. Means how we learnt it. You remember that story of rapid revision, that if you want to go to Canada now, you will have to go on your own because your family hasn't given you any PR or residency. Family se kuch nahi mila, so now you have to go to Canada on your own. So by the time you will go to Canada and you will study, give exams, Canada, MLE and all those, you will be so old in life. You will be above 50 years. So this disease starts manifesting at old age. And old age tak, what will happen to your skin? Ma'am, my skin will be pigmented. I will be old by then. My hair will be gone. My hair will fall off. Hair will be lost. My nails will be broken and atrophied. So all old age problems start occurring in these. Imagine you have to go to Canada. Your family has not given you a residency or PR. So now you're going to go on your own, and that will take you many years to go. Above 50, all above 50 changes that you see in skin, hair, nails, derma, you will add under this. Coming back, someone said that which of them, ma'am, will I need screening for? See, Hamartomatous polyps are classically said to be non-neoplastic. So इनके लिए screening नहीं चाहिए. The ones that you have to do screening for are going to be any polyp that has the word adenoma into it. I'll give you example. If they say patient has something called tubular adenoma, or they say patient has something called villous adenoma, or what is that condition where there are more than 100 adenomas? Familial adenomatous polyposis, adenoma. Wherever the word adenoma comes, adenoma is the one that is precancerous. That is where you will have to need routine screening. And of course, very, very important for familial adenomatous polyposis, because if you don't do screening, you know what you're missing out. The patient has 100% risk of cancer. There is not, he will have, pakka he will have cancer. So you have to not just screen him, but you have to screen his family members also. For what gene will you screen him? Very good. Khushi has told us, Ujjwal has also told us that in familial adenomatous polyposis, it is the APC gene on chromosome. Don't mess out on that because it is very important. On chromosome 5q21, इसका नंबर याद करना पड़ेगा. Chromosome 5q21 APC gene causes FAP. I have to follow it up because risk of cancer in the family is पक्का 100% होगा. I hope your question is settled. We are done with all of these also. Let's move on again. Let's switch a little. थोड़ा कुछ और पढ़ने की कोशिश करते हैं. There is a known case of neurodegenerative disease, which is the most common cause of dementia in humans. Only on the basis of that I know neurodegenerative dementia in humans. क्या पहला चीज क्या याद आता है? I think Alzheimer's comes to everyone's mind. Let's read. There is a histopathology that has been shown biopsy. Which of the best describes the composition of these findings? Everyone is saying tau protein. Okay, that is good. But tell me, what is this, if I may ask you? Because Alzheimer's and tau protein तो वैसे भी सबको याद है, but have you been able to solve it from the pathology point of view? क्या है ये? Alzheimer's, very good. What are these cells? Ma'am, they're looking like a flame. So can I call them flame cells? Yes, you can. No, these are not Hiranobodies. If they would have been Hiranobodies, then your answer wouldn't have been tau protein. Hiranobodies ka to answer is, yes, these are neurofibrillary tangles. So what we are going to do, when they talk about neurodegenerative diseases, these are the two photos that they give you in the exam, which you have to settle with me. Sabse pehle, we are talking about Alzheimer's disease. Before I come to Alzheimer's disease, you will tell me the genetics of Alzheimer's disease. There are 4 things of Alzheimer genetics that you have to tell me for INI-CET. Number 1, it is going to be the chromosome. Which one? 21. Chromosome 21 has which gene? It has Alzheimer's ka precursor protein gene, amyloid precursor protein. Full form nahi bhi yaad, but remember chromosome. This I'll correlate for you. Have you all read in pediatrics, Downs, and even in pathology? Trisomy 21 के patient में there is always premature Alzheimer's. Those Downs के patients have Alzheimer's by the age of 30 years only. We guys in normal human beings, we have Alzheimer's by the age of 70, na, if at all. But these people in Downs have Alzheimer's at the age of 30 years. Why is that so? Because there is trisomy 21, extra 21 chromosome means more of APP gene. That is why they will land up with this Alzheimer's at the age of 30. Very good. Other than that, there are 2 more genes. There is PS1 gene, PS2 gene. PS1 is not PlayStation. PS is going to be the what? It is going to be the, very good. It is presenilin. It is going to be presenilin. Okay, coming to the next one. Okay, anyone? There's an ApoE4 gene mutation also that is going to be settling over there. Perfect. There is ApoE4 gene mutation as well. Acha, someone said presenile. Presenile नहीं है, it's presenilin, but नहीं भी चलेगा, PS भी होगा. So these four, unfortunately, you will have to do a little bit of ratta over there. So chromosome 21, PS1, PS2 and ApoE4 genes. These are the four genes that we are going to have for Alzheimer's. Now come back to this. You called it flame cells. Flame cells are nothing but neurofibrillary tangles. Flame cells are nothing but neurofibrillary tangles. And what are they made up of? You are right, tangles are made up of tau protein. We have always learned Alzheimer's shows you tau because Alzheimer's is tau G ka age, 70 years and above. So Alzheimer's shows you tau G wala thing. And tau G in the family always tries to act like a hero also, right? So what else does Alzheimer's show you? It shows you hirano bodies, these long bodies. Now hero kya karega? Hero acting karega. So what is the composition of hirano bodies? It is going to be the actin. So don't mess up on this. If I give you this photo, you will say, oh, these are neurofibrillary tangles, that is tau protein. If I say this photo, that is going to be hirano bodies, that is going to be actin. Coming to Alzheimer's ho gaya. What if they would have asked me a question of Parkinson's disease? Can you all tell me what is the mutation in Parkinson's disease? Yes, what is the mutation in Parkinson's disease? It is alpha-synuclein mutation. It is alpha-synuclein mutation, and that is why I say कि जो mutation है वही bodies है. What are these round bodies? Lewy bodies. What are Lewy bodies made up of? They are made up of alpha-synuclein. So how simple? The composition of Lewy bodies is alpha-synuclein. The mutation is alpha-synuclein. But what happens in Parkinson's? I'm not asking you about the tremors, that you know. Is there a difference between? Yeah, Khushi, there is. The clinical difference is there, but Khushi, Parkinson's and Lewy body dementia, both of them can show you Lewy bodies. Lewy body is not specific for Parkinson's disease. It can be seen in Lewy body dementia also. So the difference then lies in the clinical symptomatology. Coming back, yes, you are right. Everyone, Parkinson's disease mein there is basically a decrease of, yes, there is a decrease of DOPA that is going to occur in that situation. Less of DOPA means what? Less of melanin. And when I say less of melanin, which part of the brain do you think will get affected? Dekho dono photos for your comparison. This is substantia nigra. Substantia nigra normal. If you look carefully, substantia nigra normally is brown in color because it has melanin. Melanin kam ho gaya, to can I say now the substantia nigra is going to become pale? There is pale substantia nigra. Can we all see the difference? Normal substantia nigra brown hai because melanin hai. Ab pale ho gaya because melanin kam ho chuka hai. These are the only set of photos or theory parts that you can get from Alzheimer's and Parkinson's. So coming back, if I would have asked you other questions, alpha-synuclein kiske liye hota? Alpha-synuclein would have been regarding Lewy body, and Lewy body matlab it would have been regarding Parkinson disease. Next, talking about where do you think A beta amyloid comes? Anyone on that? A beta amyloid, that also comes in Alzheimer's disease. Alzheimer's disease shows you A beta kind of amyloid. Before I start, A beta से related कोई भी number लिखा होगा, A beta 40, A beta 42. जब तक single beta is written, I'm like, अच्छा, this is Alzheimer's. In amyloid, if they write A beta 2 kind of amyloid, which disease is A beta 2 amyloid seen in? It is seen in patients who are undergoing hemodialysis. Guys, amyloidosis is a very, very important topic. I will be talking about immunology tomorrow, day after, because all immunodeficiency and amyloidosis, but mota questions are these only. If they write a single beta, it is amyloid beta, A beta, that is Alzheimer's. If they write A beta 2, then that is going to be for 2 kidneys. That is how we learned it, that we have one brain, one beta for Alzheimer's. We have 2 kidneys, so 2 beta is going to come for A beta 2, that is for hemodialysis. Very good. All of this is done. Can we move forward to the next one? Perfect. Now let's move on to again something which I have been waiting since a very long time to tell you guys. What is the fixation technique employed to examine fat stat in histopathology? This is a very important question that we have. So now basically for the next whatever time is left, we are going to now start with the techniques wala portion, that is INI-CET special, right? So we will, can I also take it a little faster from here? Ab tak sabko thoda sa aadat ho gaya hai, 1.5 hour you have gotten used to studying with me. So now I think we can pace up 0.25, thoda speed badha sakte hain. Very good. So now what are we talking about? Cryostat. This is the cryostat machine. See, cryo means what? Cryo means something that you are going to freeze, and stat means ASAP. एकदम से diagnosis मिलेगा. So actually when I say frozen, if you look very carefully, this is, let's say you are dealing with an ovarian biopsy or a breast cancer patient. ऐसा कोई कैंसर का पेशेंट है, मैम देखो कैंसर का सर्जरी चल रहा है, they sent me that biopsy right now. What have I done? I put it in this machine. This machine has freezer, -20 से कम का temperature. Immediately the tissue has been frozen. I can give immediate diagnosis. This is going to help in immediate diagnosis. Means that your patient is still on the OT table. The patient has not been closed. The surgeon has not closed the patient yet. वो opened है, surgery करा, tumor was removed, tumor was sent to the path lab. Within 15 minutes, you have told the surgeon, is it a cancer? Is it not a cancer? So now the surgeon knows that do I have to extend the surgery or do I have to stop the surgery? That is exactly what is going to be done. Now moving forward is that where am I going? This is cancer. So number one use is, it is used for cancer diagnosis. Number two use, it is also used for fat examination. Any reason that why can't I do fat examination by the usual procedure? Why do I need to look at this? I've got you a zoom in photo. देखो machine के अंदर क्या हो रहा है? This was your tissue. Can you all see ice around it because you have frozen the tissue? Now with this blade you will cut it. So now you will cut it. Within 15 minutes you will tell the surgeon कि अच्छा cancer है या नहीं है. So it's a stat, cryo stat, frozen section. But why am I using fat? Like say I have a case of lipoma, ma'am, you can examine fat otherwise also. The problem is that fat has a problem. If I put alcohol, fat will dissolve. If I put some chemical, fat will dissolve. In this machine, anywhere have I put any chemical? No. All that I have done is freezing it. At -20, I froze it. So when I will not use any chemicals, there is no chemical usage that has been done over here. So will fat dissolve or wash away? It will not. It will stay there, and I will be able to examine fat very easily using this technique. If I use any other technique, I add some alcohol to it, I add some chemicals to it, वो fat घुल जाता है, dissolve हो जाता है, and it vanishes. Then I can't see it. If you want to see, then you will have to use cryostat. So what are the two uses of cryostat? One, cancer diagnosis. Second is going to be fat getting washed away otherwise. So fat can be seen here. But now my question is, why does fat get washed away with others? For that you will answer this. Routine histopathology processing में क्या problem होता है that fat gets washed away? So can you answer this first and then we will settle it? Yes? Let me know. Okay, so I'm waiting for some answers, but meanwhile, you should know this is something they will ask you in the INI-CET exam. How does routine histopathology processing occur? I have got some answers over here, but let's see. See, next time you get this, the first thing going on in your mind should be fix the concept in your brain. That is exactly what all of you are going to do right now. You are going to fix the concept in your brain. What is fix? Fix for fixation. Just imagine you are dealing with a say a breast cancer patient. Breast cancer ka tissue, the entire breast was taken out and the breast cancer was actually sent to you. Now as soon as it has been sent to you, what will you put it in? I will put it in which solution? Fixation किसमें करते हैं? 10% neutral buffered formalin. The surgeon will take out the breast tissue and will send it in neutral buffered formalin. As soon as he will send it in neutral buffered formalin, what will you do? Now I have received it. I am the pathologist. So fix matlab I got it in NBF. I will now take out all the water from that tissue. Dehydration. How do I do dehydration? Give one dehydrating agent. Alcohol is dehydrating. Acetone is dehydrating. Now I will add some alcohol and acetone so that I can take out all the water. So fix the for dehydration. Ma'am, you have taken out all the water, dehydration, but you have added so many chemicals. Na? You have added alcohol, formalin, उन सबको साफ कर दो. You don't need chemicals. So now what is the next thing that you will do? Now the next thing will be clearing. You will clear all the chemicals. How will you clear the chemicals? By adding xylene. How I've learnt it? To clean the tissue, I will add xylene. to clean, I will add xylene. They ask you, अच्छा क्या क्या होता है in a path lab? You should know this is the machine. See, you don't have to do it with your hand or with a dropper. These are the machines. वो अपने आप करते हैं. But they ask you that what is happening inside a machine. So first the tissue is put, fix मतलब fixation with formalin. Fix the next one is going to be dehydration with alcohol or acetone. Fix the concept, that is going to be clearing, that is going to be with xylene. Okay, after that you're like ठीक है मैम, clean हो गया, tissue पूरा clean है, now let's prepare it. Now you are going to do impregnation. What will you add? You will add paraffin wax. So you know what I'm trying to do basically, before you ratta lagao this, I am first trying to take out all the water from the tissue. Do you agree? If this, for example, is a tissue and I have taken out from these places, I have taken out water. Have I created holes and gaps in the tissue? Pani pani sab nikal liya, dehydration kar diya. Have I created holes? What am I going to fill the holes with? I am now going to fill the holes with this, that is paraffin wax. That is known as impregnation. When you are adding something, pehle pani nikal lo, remove the water, create holes, then you add some wax to it. Okay, after that you're like theek hai, now the tissue is ready. Because if you've added wax, like wax statues you see in the museums, they go on for years and years and decades. Same way, now this tissue I can keep for 5 years, 10 years. Otherwise, can you keep human tissue for 5 or 10 years? It will get rotten, it will start smelling. But now I have added paraffin. Now I can preserve this tissue for 5 years, 10 years, or however many years I require. So what will I do? I will now create something called in matlab embedding, brain matlab there's going to be bedding and blocking. There is going to be bedding and blocking, means now you have created a block. This block you can keep with you for 5 years, 10 years. Uske andar tissue hai. Now it will not get rotten. So now what wax serves for, I think Khushi, that question came in late. I hope now you got it. Wax is like preservation, like a wax studio or a wax museum, so that the tissue doesn't get spoiled even for 5 years. 5 years later also, if you ask me na, ma'am, patient named ABC, uska wo breast cancer biopsy ka report tha, can you give me the patient's tissue? After 5 years also I can give you the tissue, because it is well preserved inside paraffin. So now coming back, if I say fix the concept in your brain, which is the first step? Fixation. So which is the first step that you have? It is going to be fixation. Fix the, that is dehydration. So the second step is going to be dehydration. Third one is going to be clearing. Okay, so the third one is going to be clearing. I for impregnation, impregnation tha nahi. Then B for bedding and blocking. So abhi tak I think it is obviously 1, 4, 2. So someone who told me 1, 4, 2, 3 in the beginning is correct. But abhi khatam nahi hua. आपने ब्लॉक तो बना लिया मैम, यू हैव प्रिजर्व्ड द टिश्यू फॉर 10 years. यहाँ तक क्लियर हो गया सबको? फिक्स द कॉन्सेप्ट इन योर ब्रेन. जल्दी जल्दी रिपीट कर लो. फिक्स से फिक्सेशन वॉज विद फॉर्मलिन, डिहाइड्रेशन वॉज विद अल्कोहल और एसीटोन, क्लीन और क्लियरिंग इज गोइंग टू बी xylene. Impregnation means adding something, impregnate करना, wax लगा दिया. Now you have created a block. Now you're like, okay, preserved. But is creating the block the final destination, or do you have to look at it under the microscope? That is what a pathologist has to do. So what will you do? You will cut one part of this block. Chota sa paraffin you will cut, and then you will apply that pink and blue of pathology. Okay, so that is what you did. Ma'am, you cut it out. This was your glass slide. That is what you do. And you have cut out your tissue and you have added all that pink and blue that you wanted to add. Now tell me, can I look at this under the microscope? What will you look under the microscope? The block or the slide? Obviously slide dekhoge na. So from this block, you cut a section, you add the pink and blue, but the problem is that imagine if this slide is kept raat ko bana. You came in the morning. By that time in the morning, all this pink and blue will get dried off. It's a stain, it's a liquid. Liquid will evaporate, it will get dried off. You see it in the morning, the slide will look khali. It will look empty. You're like, oh my god, I had put pink and blue last night, now I can't see it. Where has it gone? So what you do, you add one cover slip on top of it. On top of this, you add one patla sa cover slip. That is known as mounting of the slide. There is adding of something known as a cover slip. And imagine on top of a glass you are adding a chota sa patla glass to protect the pink and blue. So for that you will have to use a chemical called DPX. DPX is like a chota sa fevicol. That okay, this is a glass slide, on top of that I'm adding one cover slip, so I will stick it with what? I will stick it with a fevicol called DPX, and that is the last step, which is known as mounting. So now listen to the entire story once again. What happens? You are a surgeon, you send a breast cancer patient ka surgery, MRM kara, you send it to me. First you will send it to me in what? Formalin. I will do dehydration, take out all the water. Then I will do all the cleaning part. Cleaning is done by xylene. After that, I will fill in the blanks with paraffin bags. Impregnation ho gaya. I have one block that is known as blocking. Then I will cut that block and I will get a slide ready. I will add the pink and blue. To preserve pink and blue, I will add a cover slip on it. How will I stick the cover slip? How is mounting done? Mounting is done by the help of DPX. Now comes the next set of questions. You will tell me all the fixatives that we tend to use, although they are all written, but you will now revise with me ye kaun se fixatives hain that we have. Right now you told me for light microscopy, what is the fixative? NBF, 10% NBF. We all know NBF is neutral buffered formalin. For electron microscopy क्या होता है? It is going to be 2 to 2.5% of glutaraldehyde. पहले तो ये दोनों questions of your path and micro you will finish off. Repeat with me. Light microscopy का it is going to be neutral buffered formalin. Electron microscopy का it is going to be what? It is going to be glutaraldehyde. Now let's move on further, which I expect in INI-CET, which you will tell me. Testicular biopsy के लिए all of you end up marking Bowen's fixative and you don't read the question, so read carefully. Why was the testicular biopsy done? Please ask the examiner that. Because if the testicular biopsy was done for a case of infertility, you want to see spermatozoa, spermatids, primary spermatocyte, infertility ka case hai, you want to examine that, then you will put the biopsy inside Bowen's fixative. But if you are doing testicular biopsy for cancer, you think it is a seminoma or a choriocarcinoma or a teratoma, some cancer, then you put it in your routine 10% neutral buffered formalin. So please in the exam read carefully why is a testicular biopsy being done. If it is being done for infertility case, then you put it in Bowen's fixative. If it is being done for any seminoma or cancer, then you put it in a routine 10% neutral buffered formalin. Let's finish off hemat and gynae and genetics also. What is the fixative for bone marrow biopsy? Usually for BMBs, for bone marrow biopsies, we use B5 fixative and Zenker's fixative. What is for pap smear? This you will tell me. Acha, this is a very controversial question. Pathologists say that for pap smear, 95% ethanol should be used. Gynecologists say that for pap smear, ethanol and ether should be used as a combination. But this is a core pathology topic. Whom do you think you would want to take as a reference? If it would have been more of a gynae, I mean if it would have been something to do with the clinical part, I would have gone for the gynae textbooks. This is a very pathology topic. So obviously I will tell you that the best answer will be 95% ethanol. And agar wo nahi hai, then you go for ethanol and ether. Finally, coming to the last one, what is the fixative for karyotyping? Karyo, remember car. For karyotyping, the fixative's name is Carnoy fixative. So now what all of you are going to do, you are going to give me a fill in the blank test, which I will take so that I know if you were listening or you had dozed off. What is the, and write short forms. What is the fixative for light microscope? It is 10% neutral buffered formalin. What is the fixative for electron microscope? It is 2 to 2.5% glutaraldehyde. Now let's take you into a trick question. I have a patient for testicular biopsy, and in that I am doing it to find out whether there is a spermatic arrest or an infertility case. This biopsy will now be put under what? It will be put into Bowen's fixative. But if I have a 20-year-old person in whom I am suspecting seminoma or a testicular cancer, then I will put it in neutral buffered formalin. If I have a female who's coming to me for pap smear, the fixative for pap smear, best one will be 95% ethanol. If I have a person coming to me for Down syndrome karyotyping, so for karyotyping, the best thing that I'm going to do, the fixative is going to be Carnoy's fixative. Karyo, for Carnoy's. If I have a patient coming to me for a bone marrow biopsy, it is either B, biopsy ka B5 fixative, or Zenker's fixative. Very good, excellent. Abhi you told me the fixative for pap smear. So let me just take you next to that question only. All of the following are benefits of pap smear technique shown below. There is some technique shown below of pap smear. All are benefits except. अब pap smear पढ़ा तो उसका details पढ़ लो. Tell me pap smear technique except. Yes. Okay. So A, B, C, D. The answer to this is option C. So, pehle to, how many types of pap smear? Have you read pap smears in gynae? You recently had the gynae LRR, and pap smear is something which is very important. So, what I'm going to do in quickly say 5 to 10 minutes, all pap smear photos and techniques we are going to revise. In 10 minutes का एक time block बनाते हैं and pap smear खत्म करते हैं. I will come back to this. Pap smear is of two types. If I am using this pap smear instrument, what is this instrument known as? I believe everyone knows. This is the INICET spatula. So if I'm using the INICET spatula, then the kind of pap smear that I'm going to do is a conventional pap smear. But if I'm using this kind of a brush and a bottle, a brush which you can see over here, and there's a liquid, some liquid in the bottle, then the kind of pap smear that I'm doing is going to be the liquid based cytology, right? So एक हो गया conventional pap smear और एक हो गया liquid based cytology. Liquid based cytology is of two types. There are two machines in the market. One is a SurePath LBC and one is a thin prep LBC. These are two machines, manufacturers make them and send it to us. SurePath LBC, thin prep LBC. अब मुझे बताओ इन दोनों में से which one is considered better? So obviously LBC, the recent one, the SurePath thin prep, ये recent वाला is considered better. Why? Which you will only test and you will only see the slide and tell me. एक बार slide देखो. Look at this as the slide. What did you do? When you did INICET spatula, patient का sample लिया, you put it on the slide like this. You just started painting the sample on the slide like this. In the sense that, look at, just imagine from my point of view, I'm a pathologist. I will have to examine every corner of this slide. It's going to take me 30 minutes for one slide. And it's all messy and dirty. Whereas, what have I done in LBC? In LBC, I have put all the patient sample in one circle. Do I save time? I only have to look at one circle. I save time. Is the slide cleaner? Yes. So please remember, LBC is going to be better because number one, it is going to help in easy reporting. No, nothing will be wasted. कुछ भी ऐसे इधर उधर पेंटिंग नहीं कर रहे हो. Easy reporting, it's going to be easier to report for the pathologist. Patient का sample waste नहीं होगा. And of course, you could see the slide was so nice and clean. The background is going to be cleaner. But what is not a benefit? Manual processing? नहीं. LBC is something which is machine based. It is automated. That is why you're getting such a nice gola, circle and all clean, because a machine is making that. So now in the exam, will you be able to identify which slide looks like conventional pap and which slides look at LBC? But दोनों LBC में से which is SurePath and which is thin prep? So which is the smaller circle that is going to be SurePath? Which is the smaller circle that is going to be SurePath? And the larger circle that you have over here, it is going to be thin prep. Will you be able to identify those? ऐसा small or large नहीं लिखा होगा. They will say there is a 13 mm circle slide and a 20 mm circle slide. So 13 mm smaller circle, that is going to be SurePath. 20 mm larger circle, that is going to be thin prep. Why does the gynae take both samples, brush and INICET? Because I'll tell you why. INICET spatula is good alone also, but many a times it tends to only take out ectocervix. Brush is usually something which is used for endocervical sampling. That is why the gynecologists prefer that we should do both. But nowadays, they are only doing LBC, and this LBC is good enough to take ecto and endocervical sampling. ठीक है, अब यहाँ तक तो आपने गायनी पढ़ा. After that, now you will tell me, right, Khushi was asking me ectocervix, endocervix. Now you will tell me what are all the cells. First, you will tell me all the cells of ectocervix. Ectocervix matlab there are going to be how many types of cells on the ectocervix? Jaldi jaldi bata do how many types of cells before I start with this. Let's just quickly make, this is the, let's make a diagram. This is the ectocervix and this is going to be the endocervix. Ectocervix has three cells, PIS, मतलब base पे क्या होगा? Parabasal, बीच में intermediate, ऊपर superficial. Three types of cells, basal मतलब parabasal, intermediate and superficial. That is what I have written over here. There are going to be parabasal, then intermediate and then superficial. So let's identify. Let me ask you in this picture, what is this pink wale cells कौन से? Are they PIS, parabasal, intermediate or superficial? What are these pink wala cells? Superficial cells are going to be the pink wala cells. Please remember, the cells which are going to look pink in color are going to be superficial. Very good. So that means that the cells which are other ones, the blue ones that we have, they are going to be intermediate cells. तो ये वाले कौन से हो जाएंगे? They are going to be the intermediate cells. Pink वाले कौन से हो जाएंगे? They will be the superficial. याद रहेगा, superficial is pink, intermediate is blue. Then ma'am, what about parabasal? Parabasal are always going to be like round clusters. Parabasal are always going to be round like this. So parabasal is going to be a, you can call it a cluster, a collection of cells. And when I see so many parabasal cells, tell me one thing. Let's ask you a little bit of gynae. If I'm seeing too much of superficial cells, right? If I see, what about the light bluish green? Okay, ये वाला same. Okay, Dr. Day has a valid question. See, Dr. Day, it's very simple. Any shade of pink that you see over here, all these pink ones are superficial. Any shade of bluish, lightish, greenish, bluish, these are all intermediate. These are all intermediate cell. It could be blue, it could be light green, chalega, they are all intermediate. And when you see a cluster of round cells like this, those are parabasal. All doubts cleared? Now coming back, imagine if a female is showing you excessive superficial cells. Too many superficial cells, मतलब pink बहुत दिख रहा है. Ma'am, pink will mean that there is too much of estrogen in her. That is why it is looking very pink over here. There is too much of estrogen happening over here. Okay, what about the next one that is going to be parabasal? Parabasal दिख रहा है, मतलब अब estrogen बहुत कम हो चुका है. Estrogen बहुत कम हो चुका है. This means it is going to be a post-menopausal smear, or it is something to do with atrophy. So they might give you a smear and they say, can you tell which age or which phase of her menstrual cycle is she in? So if you're seeing too many pink cells, that is more of estrogen. If you're seeing more of parabasal cells, means she's probably 50-55 post-menopausal atrophic smear. So ectocervix ho gaya. What about the endocervical cells? Endocervical cells, it depends on how you're looking at it. Endocervical cells can look columnar like this also, right? Because they are columnar cells. Imagine you're looking at this pencil like this. So endocervical cell is looking columnar. That is one appearance. This appearance is known as butterfly on fence appearance. This is referred to as butterfly on fence appearance. Some people like to call it picket fence appearance also. Butterfly on fence appearance or picket fence appearance both. Just imagine if I turn this and I now show it to you like this. Now you will say, ma'am, earlier the pencil was looking straight, now it's looking like a dot. Now the pencil has started looking like a dot. So imagine now you just look at it from the top. From the top, what is it looking like? It's looking like a honeycomb appearance. So same endocervical cell can look like butterfly on fence appearance also. If you look at it like this, if you look at it like this, it can look like honeycomb also. Before I proceed forward, can you tell me where all in pathology do you see butterfly on fence appearance? Number one is going to be the endocervical cells, of course. Apart from that, ek to pad liya, endocervical cells on pap smear look like butterfly. Any lung tumor, there is a lipidic pattern. There is a lipidic pattern of lung cancer, and that can also show you cancer cells are sitting like this, butterfly on fence. Two things. Very good. Dr. Chaudhary is saying that, ma'am, that is the other name for adenocarcinoma in situ of the lung. Exactly. So now two things. Number one, if you see endocervical cells, butterfly on fence appearance. If you see the lung cancer, it is adenocarcinoma in situ. That also show you these lipidic pattern. Coming back, you are only focusing on ectocervix, endocervix. Pap smear पे सिर्फ cervix थोड़ी आता है. Endometrial cells can also come na. So if I try to draw this as the uterus, abhi tak what are all of you focusing on? You are saying that ma'am bahar wala ho jayega ectocervix, uske baad andar wala ho jayega endocervix. Dekh liya. But what about this endometrial lining? When endometrial lining will shed off, how will it look like? It will look like 3D ball clusters. Endometrial cells look like an entire ball of clusters. This is how it looks like. So when do you think endometrium will shed off? Between which day of the menstrual cycle? Between day 1 to day 5, है ना? It is going to shed off between day 1 to day 5 of the endometrial cycle, because that is the bleeding phase. Woman will bleed. You will see this on the pap smear. Day 5, woman will stop bleeding. From day 6 to day 10, you still continue to see. You're saying, ma'am, female is saying कि bleeding nahi ho raha, bleeding has stopped. But on pap smear, I'm seeing this. Can you see the center is darker and the periphery is a little lighter? These are also endometrial cells only. These are nothing but degenerated endometrial cells which continue to shed off. Imagine, woman stops bleeding at 5th day, but from day 6 to day 10, endometrial cells keep shedding off, and that is referred to as exodus. Now let me take a quick test. If I ask you in this picture, let's say, let me take a quick test. Test, what is this? Cell number 1. Isse kya banaoge? What is this pink color cell that you have over here? This is pink wala matlab, ma'am, this is superficial. Okay, coming to the next, what is this blue color wala cell? Blue color wala cell must be intermediate. Okay, and what is this ball like 3D ball like cluster that I see over here? This 3D ball like cluster, this must be the endometrial cell. That is what we were seeing. Anything that comes as 3D ball, that is going to be endometrial. Very good. So this is all done for us. And if this endometrium is between 1 to 5 days, it is normal. Ignore it because wo to bleeding ho raha hai. If it is between 6 to 10 days, that is also normal because that is exodus and that also happens in every female. Now you will tell me, if I talk about a quick review of gynae, सारे gynae के discharges बता दो and photos बता दो. So number one, when I talk about the first one, that is strawberry cervix. Do we all know how strawberry cervix looks like? It is that angry looking cervix with those red color dots. It is a case of trichomonas, right? And now what you have to know, okay, if this is for example a strawberry, on top of the strawberry we always have a green color leaf. So how does the patient come to you with which color discharge? Patient comes to you with a greenish color discharge. Now you have to identify, ये तो पता है मैम, trichomonas दिखता कैसे है? Trichomonas tends to be some people call it pear shaped, some people call it kite shaped. So this is what it appears. Some people call it pear shaped and some people call it kite shaped. Yes, but I know in the exam, abhi jo zoom in karke dikh gaya, in the exam you will not be able to see. So in the exam, look out for hints like strawberry cervix, greenish discharge, and sometimes imagine if I give you this much of magnification, I've not zoomed in, can you identify trichomonas? You can't. But can you identify one very important thing are these long lines and these long threads. What are these long lines and long threads that I have? That is going to be leptothrix. Leptothrix and trichomonas tend to be best friends. Sometimes chota wala trichomonas you won't see, but if you're seeing long leptothrix, you should know that if leptothrix hai to trichomonas hoga, because these long leptothrix, they are referred to as the spaghetti, and the chota trichomonas, they are referred to as the meatball. Yes, they tend to coexist. This is known as the spaghetti and meatball appearance. What is spaghetti and meatball appearance? Leptothrix and the trichomonas ka combination. So now if you are seeing these long fibers, that is leptothrix, then as a pathologist I get to know कि अच्छा ये दिख रहे हैं तो मतलब there will be some kite shaped, pear shaped trichomonas also moving around with them. So this is what they ask you in the exam, and this is a hint for you also that नहीं दिख रहा तो look at those leptothrix, है तो अच्छा होगा, trichomonas will be there. Before I proceed forward, where in microbiology do you see where in micro do you see the spaghetti and meatball appearance? Any fungus in microbiology which I will teach you after 2-3 days, which shows you the spaghetti and meatball appearance? Anyone? Yes, there is something called Malassezia furfur. Remember, Malassezia furfur shows you the spaghetti and meatball appearance. Very important. Okay, coming back, this was trichomonas. Now let's go to Candida. How does Candida present? Candida comes to us with a curdy white discharge, which all of us can easily see over here. This is settled. But what does Candida show you? Candida, curve for Candida, curve for curdy white, curve for shish kebab effect. Yes, this is going to be shish kebab effect that you see. What is shish kebab? I'm sorry if you like shish kebab from today, you might not be able to eat it, and lunchtime I'm teaching you something like this, but I can't, not my fault. And what do you see in shish kebab? There is one, obviously there's one that's stick or that's skew, and that is the Candida over here. This skew over here, जिसपे kebabs होते हैं, that is the pseudohyphae of the Candida. That is referred to as pseudohyphae of Candida. On top of that, all the kebab pieces are put. All the kebab pieces over here are what? These are the cervical cells, ectocervix के जो cells हैं. So now look carefully. Imagine all the cells are in a line. Who must have made that line? That pseudohyphae of the Candida. On top of that, who is the pieces of kebab? These are all the cervical cells, those squamous cells that you were talking about, parabasal, intermediate, superficial, वो थे. So now will you learn that Candida, curdy white, kebab effect याद रहेगा. Let's move on to the next one. Where do you see clue cells? I think as soon as I say clue cells, all of you will jump to the diagnosis and the answer of bacterial vaginosis. Can you tell me bacterial vaginosis is caused by what? It is caused by which bacteria? Gardnerella vaginalis. Gardnerella vaginalis causes. There is one criteria. जल्दी से बता दो bacterial vaginosis का कौन सा criteria होता है? There is something called Amsel's criteria, right? Can you tell me? थोड़ा गाइनी हो जाएगा, but चलो कर लो now that you are sitting. There are 4 criteria that come under Amsel's criteria, and they say any 3 out of 4 if they are present, the bacterial vaginosis is there. So what is Amsel's criteria? Number 1, there is going to be a homogeneous white discharge. Okay, there is a homogeneous white discharge, that is correct. What else? Okay, pH क्या होता है? Okay, very good. pH going to be more than 4.5. एक टेस्ट होता है. If you add KOH, there is a foul smell that is known as whiff test. Fishy odor, very good. Fishy odor on adding KOH. And comes the pathology. More than 20% clue cells should be seen. Now, what is clue cell? देखो, सबसे पहले patient will come to you with a homogeneous white discharge. pH of that will be more than 4.5. On adding KOH, you will get a bad fishy odor that is known as the whiff test. And remember, the clue cells are going to be more than 20%. So now what are clue cells? Clue cells means it's going to be one of by अपना squamous cell, जो भी parabasal, intermediate, superficial, some of those squamous cell. And on this is the nucleus. On top of that squamous cell, these are the bacteria which are sticking over here. This Gardnerella vaginalis. This is the bacteria which has stuck. So can you see this is a cell, उसके ऊपर वो dot पड़ा है. That is giving me a clue that oh, this is a bacterial vaginosis. That is why we call it clue cell. How many should I see? More than 20% of my slide should have clue cells. Now you will say, ma'am, why are bacteria only sticking over here? Won't they stick on the background also? Yes. देखो, background maybe it's not completely white. It's giving me as if someone is covering the background. It is known as a filmy background. So when I say filmy background and clue cells, we are talking about bacterial vaginosis. Khatam. Now coming to the last one. When I talk about actinomyces, what is it that the gynecologist will tell me? There will always be a history of an intrauterine contraceptive device user. If they say long-term usage of some Mirena or some copper T or some intrauterine contraceptive device, which is the infection that can occur is actinomyces. Actinomyces कैसा दिखता है? If you look, it looks filamentous. It looks like a cotton ball, woolly ball, right? So you call it woolly ball appearance, cotton ball appearance. Some people say it looks like the rays of the sun, so they call it sun ray appearance. अपना imagination, na? Cotton fibers, wool fibers, sun ray fibers. But what you have to know from scientist point of view, these are also known as the Gupta bodies. So now what all of you will do a very rapid revision. If I see a strawberry cervix with green discharge, pear-shaped trichomonas, it comes with its partner leptothrix, together known as spaghetti and meatball. Candida, curdy white discharge, shish kebab effect. Clue cells more than 20% with a filmy background, bacterial vaginosis. IUCD user with this cotton, woolly, furry ball, Gupta bodies, that is actinomyces. Now coming on further, if I say that there is a patient who is showing you this, what is this very characteristic finding? अच्छा, पहले यहाँ से start करते हैं. आदि superficial cells, intermediate cells, parabasal cells. क्या बनाओगे? आदि superficial, intermediate और parabasal. They are not superficial. Pink तो है नहीं. Parabasal तो ऐसे गोल 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 थे, वो भी नहीं है. I think these are going to be intermediate cells. Do you all agree with me on this? That these are intermediate cells? Perfect. Normal पता लग गया. Now look at the change that has happened in the next photo. Ma'am, these are also intermediate. But can you see that if this is the nucleus, around the nucleus I can see there is little whitening happening. Around the nucleus I can see there is little bit of whitening happening. So please note, this is referred to as a coelocytic change. Coelocyte कैसे identify करते हो? Around the nucleus there is a halo, white area, perinuclear halo. This is a coelocyte that I saw on a pap smear. This is a coelocyte that I am going to see on a biopsy. तो biopsy पे भी ध्यान से देखो. Biopsy पे भी you will see that oh, there is a nucleus and there is a white area around it. There is a nucleus and a white area around it. Nucleus and white area around it. So please remember, that is known as a coelocyte. Which infection does it tell me about? Very good. HPV. Not necessarily cancer. When I say HPV, all of you start thinking of cervical cancer. No. HPV comes into the body. HPV can cause warts also. Na? So whether it is warts or whether it is cancer, all kinds of HPV will show you what change in pathology? Coelocyte. So more about HPV I will teach you when we go to microbiology, because it's a virus and it's very important. Abhi ke liye pap smear shows you coelocyte. Coming to one more virus, herpes virus. Herpes virus shows you 3 M's. Try to look at the 3 M's and correlate it. 3 M's means that the cells are going to be multinucleated. M for multinucleation. Next, the cells are molding. Molding means, देखो दोनों में difference देखो. One multinucleation is looking like this. One multinucleation is that the nuclei are trying to take each other's shape. 1 and 2 दोनों में से मोल्डिंग कौन सा लग रहा है मैम? जिसमें न्यूक्लिया एक दूसरे से जुड़े हुए हैं. द न्यूक्लिया आर फिटेड इनटू ईच अदर. सो ऑफ कोर्स दैट इज गोइंग टू बी द सेकंड वन. द मोल्डिंग इज गोइंग टू बी सीन. दैट इज व्हाट आई नोटिस नेक्स्ट. एंड द थर्ड एम इज मार्जिनेशन. तो ध्यान से देखो. नाउ इफ आई जूम इन, यू टेल मी, इज दिस अ सिंगल न्यूक्लियाई और मल्टीपल न्यूक्लियाई? नंबर 1 मल्टी न्यूक्लिएशन. ठीक है. नेक्स्ट, आर दे ऑल stuck to each other and molding into each other? तो M for molding. And number 3 is margination. Margination का क्या मतलब होता है? This you will identify best with this single nucleus. You tell me yourself, पूरा nucleus blue लग रहा है? Is the entire nucleus blue or margin is looking more blue and the center is looking a little white? I think, in my opinion, the margin over here is looking slightly more blue. If I look everywhere, the margin of the nuclei are looking more blue. So now you understand the third M also. As soon as they say pap smear pe 3 M's are seen, multinucleation, molding and margination, you know you are talking about herpes simplex virus, right? Micro LRR date someone was asking just after patho. Patho is 4th and 6th and micro is 7th and 8th. Okay, coming back. So now left with this last. Can anyone tell me what is the diagnosis? Pap smear. Pap smear, what is the diagnosis? I've zoomed in a little for your ease. क्या लग रहा है? Something new. It's not an infection. Something weird and big you can see over here. Brown color is IHC? No, we've not reached IHC as of now. We've not reached it. This is all pap smear going on. Okay, coming back. What is this? Can you see what is unusual in these cells? These cells have a very big head and a very narrow tail. A very big head and then a narrow tail. It's looking like a tadpole. It has a very big head like this, and outside of it, it has a very narrow tail. This is known as a tadpole cell. Whenever I see a tadpole cell, it is a case of squamous cell carcinoma. Now your pap smear story is done. It is done and dusted. If I see, and I'll just give you a 10-second recap. Pear shape dikha to trichomonas, shish kebab effect dikha to candida. If I see clue cells and filmy background, bacterial vaginosis. If I see those woolly gupta bodies, those are actinomyces. If I see coilocyte, it is human papilloma virus. If I see the MMM, that is herpes simplex virus. And if I see tadpole cell, it is squamous cell carcinoma. Last day के लिए बस इतना photos you have to go and revise and go. 1 minute में बस photo देख लेना. Your INI-CET pap smear questions will be settled. Now someone was asking me brown color. So since you asked me, that is exactly what we have to study next. You will tell me there is a 70-year-old patient presented with liver metastasis. Immunohistochemistry done to diagnose the unknown primary. Liver met say you want to find out where is it coming from. So you did immunohistochemistry, CK7 negative, CK20 positive profile. What is the diagnosis of the primary tumor? Chalo, let's assume you forgot to read immunohistochemistry one day before the exam. Bhool gaye, nahi yaad raha, so much to study, right? Liver mets most commonly occurs from where? You had to take a guess. You have to be a little aggressive in INI-CET in answering questions. You don't leave too many questions. You try, but we know that most commonly colon se aata hai. So if I have to take a safe guess, I will anyway mark colon cancer, and that is the answer also over here. So sometimes if the answer is not coming by the seedha wala route, don't give up. There will be something in the question that you have read in some other chapter with which you can take a safe guess. If I would have taken a safe guess, I would have still marked colon cancer. So now, what is the CK7? Firstly, what do you understand by CK, guys? CK stands for cytokeratin. CK stands for cytokeratin, and I am talking about a technique called immunohistochemistry. Now comes the deal. Whenever I talk about immunohistochemistry stain, it always gives what color? It always gives a brown color. Till 2 years ago, only this question was asked. But last year, thankfully, in last session, we had discussed it in LRR, and we had an LRR very close to the exam. 1 week before the exam, we had LRR, and 1 week later, and luckily we ended up discussing कि अच्छा brown color क्यों होता है. And 1 week later it was there, and everyone was very happy that copy paste और कहीं नहीं पढ़ा था. Luckily we ended up discussing gut feeling sometimes work. So the brown color is because we add what chemical? The name of the chemical is DAB. That is going to be diaminobenzidine. Diaminobenzidine, and that is why it is so important to analyze the paper. We know INI-CET is not a paper which will give you NEET like questions of more of questions which are to do with clinical clinical side. They emphasize a lot on first and second year subjects, and in that also they like to ask you what is happening inside the laboratory. That is their favorite. So the reason for this is going to be diamino benzidine. DAB भी याद करके जाओगे for brown color चलेगा. Now coming back, immunohistochemistry पे which markers have you put? CK720. This is the next deadly table that you have in pathology. Vikalp says they must have watched LRR, possibly, because that time LRR was on YouTube, so you never know that they watched it. But coming back, that is CK7, but very kind of them. Otherwise, if they would have watched it, they shouldn't have given it, but very kind of them to have thought of us in that manner. So coming back, when we talk about CK720 profile, this is another deadly table. What are the possibilities? Both can be positive, both can come out negative, only 7 can be positive, or only 20 can be positive. And this is really tough. It can make your brain go for a toss. So let's now try to simplify it. When I say both are positive, and एक और चीज एग्जाम में ना CK को कई बार स्टूडेंट रीड इट एज CD. गाइस CD मार्कर्स अलग होता है. वो CD 20, 25 which you study in HIMAT, which I will teach you in the next class, वो अलग है. CD is different. I am talking about CK over here, that is going to be साइटोकेरेटिन. ठीक है, अलग चल रहा है अभी. CK7, CK20. When I say both CK7 and CK20 are positive, can you see B for bladder cancer and O for ovarian mucinous cancer? जितना जितना I'm telling you, उतना उतना table you have to learn. If you learn the entire table, you will definitely go mad, and I don't want you to have that. So B for what? B is going to be bladder cancer, and O is going to be what? It is going to be ovarian mucinous cancer. Is that okay with everyone to begin with CK7, CK20? अब चलते हैं which are always negative. All the CC tumors are always going to be negative. मतलब hepatocellular carcinoma, renal cell carcinoma, squamous cell carcinoma, small cell carcinoma. जितना जितना बोला सिर्फ उतना. Hepatocellular carcinoma, renal cell carcinoma, squamous cell carcinoma, small cell carcinoma, RCC, HCC, SCC, SCC. All the CC वाले tumors are negative, negative. Negative, negative याद हो गए. Positive क्या होता है? Both positive में B for bladder cancer and O for ovarian mucinous. 2 columns okay with everyone? Can I move on to the other 2? Now let's consider lucky number 7. Lucky number 7, like they say lady luck, females के लिए lady luck बोलते हैं, and numbers में lucky number 7 बोलते हैं. तो lady luck और 7 luck मिला दो. 7 ones are always seen in those tumors which are to do more with females. Now look carefully. Breast cancer, females of course, more common. Thyroid cancer, more common in female. Endometrial cancer, females of course. Cervical cancer, female of course. Otherwise, apart from females, anything that is above the colon, we've made a line in the body that is colon. Colon से ऊपर. Lung of course comes much above the colon. Salivary gland comes much above the colon. Pancreatic above the colon. Bile duct above the colon. So you don't have to learn. Simple learn करो. Female वाले cancers and above the colon वाले cancers are lady luck 7 positive. Whereas below the colon, colorectal and Merkel cell, CM20. CM20 मतलब colorectal cancer and Merkel cell cancer are what positive? 20 positive. It is a tough table, but this is the easiest way of how you could simplify it. Now you will tell me, when I say both positive, CK7 positive, 20 positive, तो क्या दो चीजें सोचोगे? Both positive में one is a bladder cancer, urinary bladder cancer, and O for ovarian mucinous tumors. Ovarian mucinous tumors. When I say both are negative, 7 negative, 20 negative, you will say all the tumors with CCCC, HCC, RCC, squamous cell SCC, small cell SCC, done. When I say only CK7 positive, you will say all female wale endometrium, cervical, thyroid, breast, and anything that is above the colon is going to be the same. Coming to the next is what? 20 positive, only 20 positive, CM20 मतलब colorectal cancer and Merkel cell cancer. Now read your question. This was a case of liver metastasis and the primary tumor CK7 negative, only 20 positive. When only 20 positive comes, what do you have to think of? CM20, colorectal, Merkel. What is your answer over here? Colorectal. Ho gaya solve. Do you want to solve another question for your confidence boosting? Let's take it up. Before that, I want to ask you, ये Merkel cell carcinoma क्या होता है? Have you read it somewhere in gynae or in derma or anywhere else? What is this Merkel cell carcinoma? Yes, जल्दी बता दो. We have 2 more techniques left after this, hence. Okay, so when I talk about Merkel cell carcinoma, it happens to be a neuroendocrine tumor. So before I start making you read about it, you will tell me neuroendocrine tumor from head to toe in the body. Name all the neuroendocrine tumors. So if I ask you, which is the neuroendocrine tumor in the thyroid gland? The neuroendocrine tumor in the thyroid gland is which one? Did you know everything that you studied about medullary carcinoma thyroid today? Remember, it came from the parafollicular C cells, calcitonin release karta tha. It is actually a neuroendocrine tumor. Okay, in the lungs, the small cell cancer is a neuroendocrine tumor. Lungs and GIT में common cancer कौन सा है which is neuroendocrine tumor? Carcinoid tumor of lungs and GIT is neuroendocrine. Adrenal gland में तो I think everyone knows pheochromocytoma is neuroendocrine. And skin में Merkel cell carcinoma. So for those who were wondering what is Merkel cell carcinoma, it is a neuroendocrine tumor of the skin. Now why did I make this list for you? Because once you know it's a neuroendocrine tumor, everything about it remains the same. Pink and blue सेम रहेगा सबका, ब्लैक एंड व्हाइट माइक्रोस्कोपी सेम रहेगा, IHC मार्कर सेम रहेगा. सो एवरीवन, एंड दिस वाज योर एग्जैक्टली अभी मे वाला एग्जाम का क्वेश्चन यही था. सो लिसन टू मी केयरफुली. इफ आई लुक एट द पिंक एंड ब्लू, दिस इज द न्यूक्लियस. इज द न्यूक्लियस लुकिंग completely blue, or is it looking blue at some places and then white at some places? Is it looking like salt and pepper appearance? Yes, neuroendocrine tumor is basically a tumor of the neuroendocrine cells, Khushi. Like for example, parafollicular C cells are neuroendocrine cells. Neuroendocrine cells से जो tumor arise होता है, that is the neuroendocrine tumor. So somewhere all these are arising from neuroendocrine cells only. All the neuroendocrine tumors will have which kind of a nucleus? White and black, salt and pepper nucleus. Then you will look at it under electron microscope. सबको याद है electron microscope looks what in color? Black and white photo कौन सा होता है? Electron microscope का होता है. So all the neuroendocrine tumors will show you these black colored dots, and these are known as neurosecretory granules. So all these will show you neurosecretory granules. And now all neuroendocrine tumors will have the same immunohistochemistry. May exam question was this, so please be very vigilant over here. पहले कैसे याद रखें? In synaptophysin, chromogranin, bombesin. क्या बोलोगे? In synaptophysin, chromogranin, bombesin. Then you have 3 short forms: NSC, CD56, CD57. जल्दी से repeat कर दो. पहले you have 3 things, that is in synaptophysin, chromogranin and bombesin. Then you have 3 short forms, that is NSC, CD56, CD57. Who will tell me May exam का क्या question था? They asked you a new question, nothing out of this. This was the googly question in that exam. The nuclear marker of neuroendocrine tumors, that is what was asked. The nuclear marker of neuroendocrine tumor is INSM. You don't have to know the full form. Trust me, ये किसी को आता भी नहीं था और ये आना होना भी नहीं चाहिए. You're not supposed to know this question, but because it is INI-CET, there will always be one question which no one on this planet knows, and which you just have to learn for the next exam and learn to move forward with it. This was that question of the May 2024 paper. So now tell me, इनमें से कुछ भी आया? What nucleus? Salt and pepper. कोई भी tumor आया? Neurosecretory granules. कोई भी tumor आया? These are the markers. And now tell me, Merkel cell carcinoma is what? CK7 positive or CK20 positive? Anyone who can give me a quick review of it? CM20 था, तो Merkel cell carcinoma was only CK20 positive. Try solving a question now. There is a 70-year-old lady who presents with a rapidly growing nodule as shown. They've shown you some black and white photo of it. On histopathology, there is a tumor with salt and pepper nucleus. As soon as you say salt and pepper nucleus, you're like, acha, they are talking about a neuroendocrine tumor. And after that, let me see, electron microscopic image is shown below. Are these the neurosecretory granules? Yes, this is the neurosecretory granules. Pakka, this is a neuroendocrine tumor. On immunohistochemistry, it is positive for in synaptophysin, chromogranin. Red violaceous nodules. Skin पे कौन सा neuroendocrine tumor होता है? It is a Merkel cell carcinoma, and Merkel cell carcinoma is going to be 7 negative, 20 positive. Just if you know how to pick up salt and pepper, neurosecretory granules and immunohistochemical markers, you are settled with it. Can we move forward? Because now that you have done this, you will tell me the answer to this question also. Let's see if you lengthy question है, बहुत integration है, but बहुत अच्छा question है. There is a 60-year-old man who presents with a 4-month history of increasing weight loss, wheezing, and shortness of breath. So some lung related problem. Smoking history is 40 years says smoking. Past medical history has emphysema and chronic bronchitis. So he's a COPD patient. Chest X-ray shows a 10 centimeter mass in the lungs. Left lung, there is obstruction of the left main stem bronchus. Abhi tak the classical history that I've got is a very important smoker history. Biopsy has been shown below and the specimen has a strong expression of synaptophysin. Can you tell me, are you suspecting a neuroendocrine tumor in the lung? Which is the neuroendocrine tumor in the lung that I made you write? It was small cell carcinoma. What is the Purana name of small cell carcinoma? It is, the old name is going to be oat cell cancer. So now what all of you will do, you will give me in one table all the lung tumors and all their immunohistochemical markers. So सबसे पहले, which is the most common lung malignancy? A quick answer, a quick review. The most common lung malignancy is what? Jaldi, this I will not answer. I will wait for that lag to finish and to see your answers. Which is the most common lung malignancy? It is metastasis. I hope you didn't answer no. See, you didn't have to fall for that trap. I didn't ask you from here. I asked you overall. Most common lung malignancy is metastasis. यहीं पे गलती होती है. But हाँ, if these would have been the options, then all of you are right that the most common is going to be adenocarcinoma. But ये trap के में exam में नहीं फंसना. If metastasis is there, answer will always be metastasis. Remember we made a list. Brain के लिए, heart के लिए, lungs के लिए, liver के लिए, bone के लिए, सबका answer metastasis. Now let's go back. Coming to your 3 lung cancers. Now, how did you identify this to be a squamous cell carcinoma? Because what can you see over here? I can see the formation of keratin pearls. These pink color pearls are referred to as the keratin pearls. So that is why it's a squamous cell carcinoma. P for pearls, P for Conce markers, it is P40 positive and it is P63 positive. P40 positive and P63 positive. This was INI-CET exam question, which is the best marker out of these? P40. So P for pearls, P for P40 and P for P63. Coming to the next one, adenocarcinoma. Ye kaise identify kara, which all of you were calling as the most common? Whenever I see glands, that is always going to mean adenocarcinoma. So whenever you see the presence of glands, that is adenocarcinoma. A for adenocarcinoma, what are the markers? The markers are going to be A for napsin A. This is again a question, napsin A. A is the first alphabet, so all 1-1 wali cheezein, TTF1, MUC1, these are all 1-1 and AA wale markers are going to come under adenocarcinoma. Coming to small cell is also referred to as oat cell carcinoma. How did you identify this is an oat cell carcinoma? ये blood vessel blue color का क्यों है? What is this blue blood vessel known as? Imagine, if I wouldn't have told you, you wouldn't have even realized कि अच्छा मैम ये blood vessel था. ये blood vessel तो blood होता है, red होता है. Why is the blood vessel looking blue over here? Because over here it is referred to as the Azopardi effect. Over here it is referred to as the Azopardi effect. Is that okay with everyone? So now let me know something out here, that what are the markers of small cell? You will say, oh, it's a neuroendocrine tumor. Markers हमें टिक पाक आते हैं. In. Repeat with me. Synaptophysin, chromogranin, bombesin. In. And then 3 short forms. NSC, CD56, CD57. So like I said, if you know it's a neuroendocrine tumor, your list is the same. And apart from that, if they ask you, acha, out of these in and 3 short forms, which is the new wala marker? Another in, that is INSM, that is the new nuclear marker for all neuroendocrine tumors. So now coming back over here, actually, did you notice why did I make this small cell carcinoma? Because this was red color ka blood and the blood vessel has started looking very blue. वो भी नहीं अगर दिखा तो they said there was impression or positivity for synaptophysin. पक्का ही small cell या oat cell cancer बनता है. This is settled. But now if I move forward, so before I go, everyone is clear with this, because now I'm going to take you to the last lung cancer tumor table. Before that, you will tell me this. Apart from lung cancer, what is the cancer of the lining or the pleura known as? What is the cancer of the pleura known as? Yes. Perfect. Pleural tumor कौन सा होता है? Mesothelioma, and mesothelioma का marker is calretinin. So this time I'm expecting, because देखो अभी तक ना they've asked you a lot of questions on lung tumors. They've not gone on to the outside of the lung. They've not gone to mesothelioma so much. So this time I've got you all the updates of Robbins that have been asked and that can be asked in INI exam. Pleural tumor कौन सा होता है? Mesothelioma. And because it's on the outside pleura, can you see that the tumor is also on the outside? They always say, radiologist को हमेशा क्या appearance दिखता है कि अच्छा on radiology there is a cage that is being made around. There is a cage that is present. So that is the radiologist का description that he gives you. Apart from that, the clinician will say that there is a patient who's having massive pleural effusion. Okay, so that is how you describe mesothelioma. But can you tell me which industry workers are going to have mesothelioma? That is going to be asbestosis workers, people who work in the asbestos industry. Who are the people who are exposed to asbestos? Which industries? या तो shipyard industry का history होगा या cement industry का history होगा. So a worker working for 40 years in shipyard industry or cement industry has landed up with massive pleural effusion. Radiologist is saying that there is a tumor which is like a cage around the lungs. You are thinking of mesothelioma. So asbestosis तो हो गया. But what if someone is not a shipyard worker? He is working in a corporate sector. He lands up with mesothelioma. Then why is he having? Because most common. These are the two questions I am expecting. सिर्फ INI के लिए याद रखना है. Either there is a chromosome 9 problem, or there is a virus SV40. It is a DNA virus. Till many years they used to say SV40 does not cause anything in human beings. Have you ever heard anyone suffering from SV40 disease? I haven't, because till many years it was not known. But now they are saying that SV40 DNA virus can cause something in humans, and that is mesothelioma. So now they will either ask you a chromosome 9 का problem हो सकता है या फिर SV40 का problem हो सकता है. Asbestosis तो I think everyone knows. I'm just taking a deviation from immunohistochemistry. I want to finish off asbestosis. So if they want to ask you questions of asbestosis, question number 1, you have already told me that this person will either be working in the shipyard industry or will be working in the cement industry. But if I ask you, someone's working in the shipyard industry for 10 years, what is the first lesion that will form in the lungs? The first lesion will be something on the pleura. एकदम से तो कैंसर नहीं होगा ना. First there will be something else that is known as a pleural plaque. Okay, after this, which if they will ask you, acha, what is the second lesion that will form in the lungs? This plaque will become thoda bada. So now it will become what? It will become a pleural nodule. Okay, and then lastly, what is the last thing that is going to occur? The last is going to be cancer. So step number 1, there is a chota sa plaque. Dhire dhire that plaque is going to become a big nodule. Dhire dhire that nodule is going to become a cancer. So if they ask you, which is the most common carcinoma that can occur in the lungs, that is not mesothelioma. The most common carcinoma that occurs with asbestosis is adenocarcinoma. And if they ask you which is the most specific cancer is going to be mesothelioma. So repeating, the most common carcinoma, most common is going to be adenocarcinoma, and most specific is going to be mesothelioma. One more thing, दिखता कैसा है? How does asbestos looks like? It look like, if I ask you how does asbestos fiber look like, you will say, ma'am, asbestos fiber looks like a dumbbell. That is how. So if you look carefully to it, it will look like a brown color dumbbell. And anyone who can tell me a reason why is this photo showing me brown color dumbbells and why is then this photo showing me blue color dumbbells? कोई reason है? कोई any difference? Khushi was saying something, or if I'm correct, I'm sorry if I got the name. Someone told me in the beginning कि मैम stains नहीं याद होते. तो अभी 2 दिन पढ़ो मेरे साथ, stains अपने आप धीरे धीरे याद होंगे. Why is one side dumbbell looking brown and one side dumbbell looking blue? Because originally this is the brown color asbestos fiber. Originally तो वो brown color का ही होता है. But when it comes in your body, when you inhale it, do you know what you deposit around it? You deposit iron around it. This is what we do when we inhale it in our lungs. We deposit iron around it. Now tell me, what is the special stain for iron? It is going to be Prussian blue or the pearl stain. Yes, it is the Prussian blue or the pearl stain. And now Prussian blue, तो अब बताओ, why is it looking blue नीचे? Because I have added that Prussian blue or pearl stain. So can I say that this dumbbell shaped body, some people call it an asbestos body, some people call it asbestos body, but then some people also like to call it ferruginous bodies. Some people also like to call it as the ferruginous body. and that is exactly what has resulted in this story. So khatam, dumbbell shaped body. Before I proceed further, there's one more thing, मतलब immunohistochemistry से थोड़ा बड़ा reroute हो चुका है, but it's very important. Asbestosis, plaque बनेगा, then nodule बनेगा, then cancer होगा. Most common is adenocarcinoma and most specific is mesothelioma. This story started because I asked you which of them is the most important marker of mesothelioma. तो marker पूछा, your answer is going to be calretinine. Chromosome पूछा, your answer is going to be 9. Virus पूछा, your answer is going to be SV40. Now finally coming all the way back, we were studying a topic called immunohistochemistry, that brown color staining, and this is the entire table that you have to know for immunohistochemistry markers. Now we can wrap up the last table of IHC. अभी तक का एक random question, immunohistochemistry always gives a brown color. What is the reason for the brown color? Quick revision guys, the reason for the brown color is going to be DAB, diaminobenzidine is going to give a brown color. Acha, before that someone in between for iron had mentioned Mason Fontana. Mason Fontana iron का नहीं होता. M for Mason Fontana, M for melanin, M for Mason Fontana, M for melanin. वो melanin का stain होता है, not for iron. Coming back, now you say that ma'am, if all this is okay, I have done immunohistochemistry में to give you a review, क्या क्या कर लिया. Number 1, you did the entire table of CK7, CK20, that is done. Number 2, you have done the entire table of the lung cancers. Number 3, you have done the table of outside the lung cancer, that is mesothelioma also. Now you are coming to general, where all in the body can you apply immunohistochemistry. So any carcinoma, please remember, will be positive for cytokeratin. Any carcinoma on this planet, whether you are talking about carcinoma of the lung or carcinoma of the colon or carcinoma of the breast, or carcinomas are cytokeratin positive. All sarcomas are going to be vimentin positive. So please remember, carcinoma cytokeratin positive, sarcomas vimentin positive. So let's take a test, INI-CET test लेते हैं. If I say leiomyosarcoma or rhabdomyosarcoma, you will say, ma'am, you have just told us all sarcomas are vimentin positive. Agreed? Can anyone tell me what is the difference? What is myo? Myo matlab muscle. What is leiomyo? Leiomyo refers to smooth muscle. And what is rhabdomyo? Rhabdomyo refers to skeletal muscle. So how do I differentiate? And this was what was asked. For smooth muscle, the tumor, the marker is going to be smooth muscle actin. It's in the name itself. Smooth muscle tumors will be smooth muscle actin positive, whereas skeletal muscle will be desmin positive and myo D1 positive. So listen to how the question is going to come. There is a patient, he has had a big tumor, 10 centimeter big tumor on the right thigh. Right thigh, of course, which muscle are you thinking of? Put your common sense. Right thigh, you are thinking of the skeletal muscle only. But then they are saying that right now you don't know what is the tumor, so you have applied immunohistochemistry. On immunohistochemistry, the tumor is positive for vimentin. You're like, acha, vimentin, sarcoma to pakka hai. Now next they write it is positive for desmin and myo D1. You're like, okay, fine, desmin and myo D1 matlab pakka it is a rhabdomyosarcoma. Next question, there is a female, she's having uterine bleeding. There is a big tumor mass in her uterus that is found. The tumor mass is positive for vimentin and SMA. What is your diagnosis? Tumor mass is positive for vimentin, matlab sarcoma, and SMA, matlab smooth muscle sarcoma, means in her uterus, what is she having? She is having leiomyosarcoma. So ultimately it comes down to this. Now let me see others. कोई लिम्फोमा हुआ, हॉजकिन्स लिम्फोमा, नॉन हॉजकिन्स लिम्फोमा, सो ऑल लिम्फोमास आर LCA पॉजिटिव. L फॉर लिम्फोमा, L फॉर LCA और CD45. LCA क्या है? ल्यूकोसाइट कॉमन एंटीजन. कॉमन मतलब ऑल ल्यूकीमियाज, ऑल लिम्फोमास कॉमन, LCA पॉजिटिव. Melanoma, this is what Khushi answered a few minutes back. Melanoma is positive for what stain? Mason Fontana and HMB45 and melan A. All MMM will come over here. Okay, so Khushi, Mason does not go for iron. Mason comes for melanin. So melanoma के लिए Mason, Fontana and HMB45 and melan A, ये सब melanin का हो जाएगा. अब बचता है हमारा last, Langerhans cell histiocytosis. This I've kept as blank. Can you tell me from medicine, from derma, Langerhans cell histiocytosis के लिए most important CD marker, that is CD1A. मेसन ट्राइक्रोम पढ़ेंगे बट इधर नहीं पढ़ेंगे, बाद में पढ़ेंगे, ठीक है. CD1A, okay. Then there's another CD that is CD207, CD1A, CD207, and it is thoda sa tough list, S100 and HLA-DR. Unfortunately, you will have to learn CD1A to sabko yaad rehta hai. Langerhans cell histiocytosis, CD1A, CD207, HLA-DR and S100. But now comes the next question. Is immunohistochemistry the gold standard of Langerhans cell histiocytosis? Yes or no? Answer is no. Langerhans cell histiocytosis का gold standard is not immunohistochemistry. It is this black and white microscope, that is electron microscope. And what appearance do you see over here? We see the tennis racket appearance. The electron microscope shows you the tennis racket appearance. There are a lot of tennis rackets that I will teach you in microbiology. I will give you an entire list. Abhi ke liye tennis racket appearance is seen on Langerhans cell histiocytosis. Very good. ये क्या है मैम? Langerhans cell ही होगा. Langerhans cell histiocytosis का Langerhans cell होगा, but inside the Langerhans cell, these are actually which granules? All of you are right. These are going to be the Birbeck granules. Perfect, guys. So now comes a very important question. कि Langerhans cell histiocytosis का IHC markers हो गया, उसका gold standard is not immunohistochemistry, is electron microscopy, tennis racket appearance, वो भी हो गया. But what is the mutation? Langerhans cell histiocytosis shows you what mutation? All derma questions. It shows you BRAF mutations. कहीं और पढ़ा था BRAF V600E mutation. Did we study somewhere else today right in the beginning? Did we study for papillary carcinoma thyroid? The most common mutation was BRAF. Now, where else can you see BRAF? So, BRAF you can see in a total of 6 places in medicine and pathology. Please listen carefully. Number 1, Langerhans cell histiocytosis. Isko ulta padho. HCL, hairy cell leukemia. LCH, Langerhans cell histiocytosis. HCL, hairy cell leukemia. P for what? Papillary carcinoma thyroid. And P for what? One brain tumor that is going to be pilocytic astrocytoma. It is going to be pilocytic astrocytoma. So P for papillary and P for pilocytic astrocytoma. बस दो और याद करने हैं. One is colon cancer and one is melanoma. These are the 6 tumors which in pathology show you BRAF V600E. Repeating LCH, HCL आगे पीछे, P and P, papillary and pilocytic, and colon and melanoma. Okay, coming back, BAF is done, IHC के markers are done. Are you ready for one test so that I know that you are listening and not slept off? Because we've completed 2.5 hours, but we've not completed all of what we had to study. What could be the likely diagnosis for a 5-year-old child who has proptosis in one eye and the test positive for desmin in a tumor? Desmin, ma'am, desmin you had told us is for skeletal muscle. इसमें से skeletal muscle वाली जो चीज दिख रही है, that is rhabdomyosarcoma. Yes, embryonal, because look at the बच्चे का age also ना, it's occurring in a 5-year-old बच्चा. That is exactly how questions come. Exactly how questions will come over here. Your answer will be settled from somewhere in this table. So cytokeratin हुआ carcinoma, vimentin हुआ तो sarcoma, desmin myo-D1 तो skeletal muscle, smooth muscle actin तो smooth muscle, LCH का CD1A very important, LCA is going to be lymphoma, and all the M's are going to be for melanoma. But now let me ask you another question on the similar lines. There is a 3-year-old child with a vaginal mass that has been shown below, image number 1. The histopathology assessment has been shown below in image number 2. Which of the immunohistochemical markers will aid in the diagnosis of this? It's a twisted, much twisted, typical INI-CET का twisted question है. Yes, I think we are just left with 3-4 more slides, so don't worry. I think in another 10 to 15 minutes we'll be done. So alertness level, next level होना चाहिए, so that when we have to wrap up, we must wrap up well. Okay, what did you think of this? कुछ बन पाया? Because when I say a 3-year-old child with a vaginal mass, now vaginal masses in bachas are so rare that you have to know only 1 and 2. It's rare also and good for you that you don't have to know 10, 20 of those differentials. There is something known as, अभी जो पढ़ के आए थे, अभी तो all of you marked the answer so well. Embryonal rhabdomyosarcoma, ma'am, desmin positive होता है, but embryonal rhabdomyosarcoma होता क्या है? That you messed up. So now I'll tell you what is embryonal rhabdomyosarcoma. This you will study in gynae, in pediatrics also. Embryonal matlab ek to this will occur in bachas. Other name of embryonal rhabdomyosarcoma is sarcoma botryoides. Botryoids matlab this is going to be a bunch of grapes. This tumor can, now look at the tumor again, you will start visualizing that yes, this is looking like a bunch of grapes only. That is exactly how the tumor looks like, isn't it? Now you will know that this tends to occur on mucosal surfaces, especially like vagina. So you don't have to know any other location. Chota bacha with a vaginal mass showing you this bunch of grapes appearance, this is embryonal rhabdomyosarcoma. Now if you know it is embryonal rhabdomyosarcoma, तो sarcoma के लिए क्या लगाओगे? Vimentin. और skeletal muscle के लिए what will you put? You will put desmin. Can I say option A seems to be the best answer over here? On the basis of this much, have you answered option A? All those who were answering B and D and others, I hope this is settled for the time being. Yes, अभी के लिए समझ आया that this bunch of grapes is always an embryonal rhabdomyosarcoma. तो ये क्या फोटो है? Maybe this you've seen in INI-CET questions, but you can't recall. This tumor, embryonal rhabdomyosarcoma, shows you something called cambium layer. Now please go back to your INI-CET PYQs. You will see a question, cambium layer is seen in which tumor? It is seen in embryonal rhabdomyosarcoma or sarcoma botryoids. क्या होता है? All the cells, if you look carefully, ऊपर, and don't just say yes for the heck of saying it, genuinely if you feel दिख रहा है तो बताना. Can you see the upper part is looking denser? It looks as if all the cells have gotten accumulated there, and then the lower part is looking, has cells but they are thoda white. There are some spaces that are seen in between. Doesn't it seem so that the upper part is very dense and the lower part is a little less dense? So this upper layer of dense cells, that is referred to as the cambium layer. Do you all agree with me? I hope it is not too overwhelming. समझ आ रहा है that the upper layer has all the cells, that is cambium layer. Let us zoom in. कैसे cells दिख रहे हैं? They are looking like long. Some people call them strap cells, some people call them tennis racket cells. तो जिसका जैसा imagination वैसा वो बोल सकता है. Long cells, some people say strap cells, some say tennis. Where did we just study tennis racket? For that electron microscopy, Bird-Beck granules. कौन सा disease में पढ़ा था tennis racket? That was seen in Langerhans cell histiocytosis. So let's finish it off, guys. When they say tennis racket cells on a छोटा सा बच्चा, vaginal mass, it is embryonal rhabdomyosarcoma. When they say electron microscopy के Bird-Beck granules, you will say, oh, this is Langerhans cell histiocytosis. This was the pathology का tennis racket. Tell me the micro also today only, then we are finishing off a micro work prematurely. Let's finish it off. If they say in the stool you are seeing tennis racket kind of, which is this? This looks like that angry old man. Who is that angry old man of the intestine? Yes, angry old man also looks like tennis racket. That is Giardia looks like this. And which bacteria looks tennis racket? So some of you, I'll give you an example. It is some species of Clostridium which looks. Clostridium कौन सा वाला? Clostridium tetani और Clostridium tertium? No, बस यही तो confusion हुआ. Everyone says tetani, हर बार यही होता है. See, look at this. When I say Clostridium tetani, it's a very tiny little difference. That also looks like this, but look at the spore. The spore, ये जो गोला होता है इसमें, this is the spore. This is round. So Clostridium tetani is said to be the drumstick appearance. It is not tennis racket. Clostridium tertium is going to be the tennis racket appearance, because over here the spore is looking lamba like this, like a tennis racket. So please note Clostridium, even if you forget, tertium, tennis racket, tertium में दिखता है, not in Clostridium tetani. Clostridium tetani shows you the drumstick appearance. Okay with everyone? All the tennis rackets are done. Immunohistochemistry का last question which I'm going to wrap up the class with is, before I go to that, I hope everyone identified. There was a 3-year-old bacha with vaginal mass. I can only think of sarcoma botryoids. What is this layer of histopathology that they tried to show you in the second picture? They were trying to show you the cambium layer. So ये भी हमने पता कर लिया. Now finally the last immunohistochemistry that you have to know of the day and we wrap up is this. Which of the following HER2 immunohistochemical studies will be further evaluated using fish? HER2, so I assume that you have understood that we are dealing with something to do with breast biopsy. Which of them will you evaluate with fish? Options are A, B, C, D. Fish किस में करोगे आगे जाके? जल्दी से A, B, C, D. Give the best answer is the last answer. Okay, so I can see C, many of you are answering. Okay. Perfect. So C matlab your HER2 new was 2+. Very good. So firstly, did you all identify, seeing the photo, immunohistochemistry, because ma'am brown color दिख रहा था. So now the routine, I'll tell you what we do as a pathologist. Whenever a surgeon sends a breast biopsy to me, the basic thing is that I want to divide it into, I want to do three things. I want to do ER, PR and HER2 new. Anyone who knows what is the name of this classification? Yes, anyone who can tell me what is the name of this classification, ER, PR, HER2 new wala? This is known as the molecular classification of breast cancer. I'm teaching you entire breast cancer. That's why I said it will take 5 minutes, but we'll be done with breast cancer plus IHC ek saath. Whenever the surgeon sends me a breast cancer biopsy, molecular mein, ma'am, you are doing immunohistochemistry. I am doing immunohistochemistry, yes. Which immunohistochemistry? ER, PR, HER2 new. But was that the original basis of this classification? No, the original basis of this classification was genetics. How did they make this classification? They did the study of a lot of genes and then they ended up making this classification. However, if you ask me that, ma'am, are you doing genetics nowadays? It's very expensive. I can't do genetics of every patient. Every patient cannot afford thousands and lakhs of rupees. So I've made a surrogate classification. I've made a side jugaad wala classification and I've started doing the cheaper immunohistochemistry. But in the exam, when you are asked what is the basis of the molecular classification of breast, please don't mark immunohistochemistry. The basis of this was genetic profiling. I am doing immunohistochemistry on the basis of which there are 4 categories: luminal A, luminal B, HER2 rich and triple negative. Tell me common sense. What do you think is triple negative? When everything is negative, ER, PR, HER2 new, everything is negative. Which are the breast cancers that come under triple negative? Triple negative में जो breast cancers आते हैं are the breast cancers which start with ME. All the negative वाले are NE वाले are ME. मतलब medullary breast cancer is triple negative. Metaplastic breast cancer is triple negative. Okay. Coming to HER2 rich, common sense. What do you think HER2 rich will be? ER, PR will be negative. HER2 will be positive. That is why the name says HER2 rich. And if someone is HER2 positive on immunohistochemistry, which cancer type can it be? It can be apocrine carcinoma. Many people learn it as HER and rich. When is someone going to be, when she is rich, she is going to be happy, of course. They're applicable universally. Now, whenever you get rich, you become happy. So many students learn it as happycrine carcinoma. HER2 rich and happycrine carcinoma is how they learn it, so that they remember that she is rich and happy, that is apocrine carcinoma. Now let's come to luminal A and luminal B. दोनों में luminal A ER PR positive, HER2 new negative. ER, PR positive, HER2 new negative. But did I tell you there was something about Ki67? Luminal A में Ki67 is less than 14% and luminal B में Ki67 is going to be more than 14%. याद आ रहा है? Ki67 was that proliferation index which was 100% in Burkitt's lymphoma and in breast cancer less than 14, more than 14. So tell me, out of luminal A and luminal B, which is more proliferating? If you put your common sense and your concept into it, which is the more proliferating one? It is going to be luminal B because Ki67 is more than 14% there. I realize luminal A is dustbin category. Every cancer comes under luminal A. That is why I made you learn the others. Triple negative में ME आएगा, HER2 rich में happycrine, that is apocrine आएगा. Rest everything comes under luminal A. Tubular carcinoma breast, mucinous carcinoma breast, papillary carcinoma breast, lobular carcinoma breast, all of these are going to come under luminal A. But difference, जब तक low grade लिखा है luminal A, because Ki67 is less than 14%. As soon as they write high grade cancer, it comes under luminal B because now Ki67 becomes more than 14%. So repeating, less than 14% luminal A low grade, more than 14% luminal B, that is going to be high grade. Let me ask you something again with this. What did you tell me for lobular carcinoma? इसमें कौन सा genetic mutation होता था? जल्दी जल्दी बता दो. Loss of which? Remember, glue चला गया, GO-LU tumors, gastric and lobular. Which mutation did you guys tell me? It was the E-cadherin mutation. That is what you said, that invasive lobular carcinoma shows you loss of E-cadherin. And over there you also told me that cells are one behind the other. What is that pattern known as? And I've got all of that for you. All the cells, if you look carefully, वो एक line में है, they are one behind the other. That is going to be the Indian file pattern. So ये सब हो गया. Why did I teach you all of this? Coming all the way back, I taught you all of this because I want to focus on this category, HER2. What are you doing for HER2? You are doing immunohistochemistry. So now let me tell you, as a pathologist, what I do. That's the last slide of the day. As a pathologist, whenever the surgeon sends me a breast biopsy, what are the three immunohistochemistries that I put? I put ER, PR and HER2/neu. Now in ER, PR, HER2/neu, you will say, ma'am, on the basis of this, you told us ya to luminal A, ya luminal B, ya HER2 rich, ya triple negative. Inme se, please remember, for ER and PR, what the pathologist does is known as something called as all-red scoring. All-red scoring is done for which immunohistochemistry? Estrogen, progesterone, ER and PR. For HER2/neu, there is a scoring which I am going to tell you now. All-red scoring तो सिर्फ नाम जानना है. I think gut feeling says इस बार ये आएगा. All-red scoring is for which immunohistochemistry markers? It is for breast cancer का ER and PR. Then they will ask you what is the scoring that you do for HER2/neu, and all of this is being done where? It is being done on immunohistochemistry. It is 0, 1 plus, 2 plus, 3 plus. Pathology की report में ये लिखा आता है HER2/neu immunohistochemistry is like this. It is 0, 1 plus, 2 plus, 3 plus. Can you see the brown color is becoming more, है ना? So now when the pathologist says 0 or 1 plus, that is nothing. That brown color is ignored. HER2 is negative. What should you be giving this patient any drug for HER2/neu? What is the drug for HER2/neu? Trastuzumab. Should you be giving this patient trastuzumab? No, because ma'am, agar pathologist has written IHC 0 and 1 plus, HER2 is negative. Don't give trastuzumab. If the pathologist has written 3 plus, pakka positive, HER2 positive, what is the treatment of this patient going to be? Patient is going to be treated with trastuzumab. Exactly. तो ये तो clear है. But if pathologist says 2 plus, I'm like, oh, is this negative or positive? पता नहीं. Then how will I confirm? I will confirm it on FISH, and that is what they asked you. Which of the following immunohistochemical studies will be further evaluated on FISH? 0, 1 plus, 2 plus, or 3 plus? So the answer, of course, is going to be 2 plus. 0 and 1 plus तो पक्का पता है कि HER2/neu नेगेटिव है. 3 plus में पक्का पता है HER2/neu पक्का पॉजिटिव है. It is this 2 plus category which I am doubtful क्या है, is HER2/neu positive or negative? How do I confirm it? With FISH, and that is FISH, which is your last slide of the day. What is FISH that you have? Full form जल्दी जल्दी बता दो. It is a fluorescence in situ hybridization. That is what is FISH. So now you have to, this you have to know very carefully. ध्यान से सुनना. HER2 is what? I will draw one gene. See what have they done? You please ratta laga ke nahi jana. Don't learn the color coding. Color coding examiner gives you. Examiner has given you over here that chromosome 17 को क्या color दिया है? Green color. See, it's written in green. Chromosome 17 has been given a green color, and then examiner has written that HER2 gene has been given a red color. Is that okay? This examiner will write. Don't ratta lagao the color codings. So tell me common sense. If I say green color has been given to chromosome 17, how many chromosome 17s do you have? We have a pair, right? How many green colors should I get? In every cell, I should get 2. So if I get one green color and one green color, that is normal, isn't it? Everywhere first you see chromosome 17 तो ठीक है ना, कोई ट्राइजोमी तो नहीं है, ऐसा तो नहीं. 3 17s are there. Over here also I see 2 green signals, 17 is normal. Here also I see 2 green signals, 17 is normal. यहाँ तक सबको समझ आ गया? That okay ma'am, number of chromosomes तो patient में ठीक है. I have to look at HER2 being normal or not. So now if I see any, I'll zoom in for this, otherwise you won't be able to see. Can you see 2 red colors over here? 2 chromosomes पे 2 genes, normal है. If I see 2 signals, that is going to be normal. Over here, with 2 chromosome 17s, I label them as 17, 17. How many HER2 genes are you seeing? I can see at least 5. Is this normal? With 2 chromosomes, you should have 2 genes. Here with 2 chromosomes, a person is having 5 genes. That is not normal. Over here, there are 2 chromosome 17s, and I can't even count the number of HER2 copies that this person has. So it is showing me amplification, and that has a formula. They say if HER2 upon CEP17, CEP17 is nothing but chromosome 17. If it is more than 2.2, this implies that HER2 positive है. So now just imagine, this was my patient. IHC करा था पहले, IHC पे मैम वो doubtful आ रहा था, 2 plus आ रहा था. You said इसका FISH करो. When you did FISH, this is what you got. Tell me, is HER2 amplified? Will you be giving trastuzumab to this patient? Calculation कर लो. Count the number of HER2s. Can anyone count? 1, 2, 3, 4, 5. मैम 5 तो लग रहे हैं इसमें. 5 HER2s लग रहे हैं, and chromosome 17 तो हमेशा 2 ही होंगे. तो 5 divided by 2, of course 2.5. Is it more than 2.2? Yes. Is the patient having HER2 amplification? Yes, the patient is having HER2 amplification. Will you give the patient trastuzumab? I will. एक और patient देखते हैं. In my next patient, I had to do the same formula. HER2 upon Sep17. HER2 कितने? Can't even count. Let's say 10 है. I'm just giving a random number. There are 10 HER2 and how many chromosome 17s? 2. क्या बना? 5. Anything more than 2.2. Is this amplified? This is hell lot amplified. This is a high level amplification. Will you give trastuzumab to this patient? Yes. Look at this. दो chromosomes, दो genes. This is normal. Will you give trastuzumab to this patient? You will not. So now completing your story. First I do the easy, the जुगाड़ वाला technique IHC. On IHC, if the patient is 0 and 1 plus, I say पक्का negative है. So that basically means that the patient is not going to be given trastuzumab. 3 plus है तो पक्का positive है, patient is going to be given trastuzumab. 2 plus, I'm doubtful. I do a FISH. If I get a value more than 2.2, FISH means HER2 positive है, trastuzumab देना है. If I get a value less than 2.2, HER2 is negative, trastuzumab नहीं देना है. That is how the entire story of FISH works. There's a 15-year-old male who presents with typical facial profile of long face, large mandible and large ears. I think only if I read this much of information and don't read anything else, there is possibly only one thing that comes to my mind with this kind of a face, and that is Fragile X syndrome. Okay, some of you said Marfan. No, Marfan mein there is not characteristically face characteristics. Marfan mein the person will be very, very tall. It's a 7 feet or a 6.5 feet. That kind of tall person is given. Let's read further. Dropping out of school due to poor grades, they are also giving you a hint towards the IQ being low. And many of you have told me Fragile X syndrome. So now comes the deal. On physical examination, the testes are enlarged. Now, macroorchidism, large testicular size, we are definitely talking about this Fragile X syndrome only. Now they say there is also something reported in a distant cousin, so family history is there, and this is a problem in the X chromosome which they have grown in a folate deficient media. So if you look very carefully in this X chromosome, can you see it looks as if this part is breaking, fragile ho gaya, it's become weaker, it's breaking. But does it actually mean, before I start, all of you know it's Fragile X, but does it actually mean that chromosome has broken off? Can it happen that our chromosome breaks off like that, and after that how will survival? It's no chromosome is breaking. Fragile X, fragile word is just a misnomer. No chromosome is breaking. The point is that whatever technique you have used over here, you've put a stain. Karyotyping mein you put a stain. So I realize the entire chromosome takes up the color. This area does not take the color. It does not take the stain. So it looks that this area is white and something is falling off after that. Nothing is falling off and nothing is fragile. So I can just say that this is the area where the stain has not been taken up. So I hope this concept is clear. It is Fragile X syndrome, but the question was which PCR methodology will you be using for Fragile X syndrome? Amplicon length analysis. Now what does that mean? PCR every time one or the other question is coming. So listen carefully. Firstly, you need to know that why did this area not take up the stain? What has happened on chromosome X? All of us, you and me, we on chromosome X have something called FMR gene. FMR gene stands for mental retardation. So basically all the IQ that we have today and why we are able to have a normal IQ and study normally is because of this FMR gene. But just imagine in Fragile X syndrome people, this X chromosome has gone for a toss. What is the problem in the X chromosome? There are very good, there are CGG repeats that have happened in this FMR gene. CGG repeats have happened because of which this area looks weaker or this looks fragile. So that is the problem that is occurring in these patients. So when I say CGG repeats, CGG, all of you are right, ma'am. It has to be more than 200 times. Imagine how lengthy your DNA will become in this patient. And if the DNA becomes very, very lengthy, which kind of PCR will you use? You will use Amplicon length analysis, that PCR. Okay, so now coming back, this is a classical case of Fragile X syndrome. Then I'll teach you all the PCRs. For 5 minutes maybe have to finish. Today we have lots of topics. So I'm actually going to teach you time boxing, that if you assign a time to a topic, if you tell your brain and you give that signal that this is the amount of time I have to finish it in, your brain will automatically start working. So if I want, I can teach you PCR for 1 hour also. And if I want, I can teach you in 5 minutes also. That is the beauty of the human brain, and that is how you should be studying at this point of time as well. So let's keep 5 minutes minutes for this question. Let's start. When I'm talking about Fragile X syndrome, what is the IQ? Previous year question. Of course, there is mental retardation, but the IQ is between 20 to 60 is what they'll ask you. Then you can see what's happening in the face. You've already known that there is going to be a large face, there are going to be large ears, and of course, there is a large mandible also. But what is the most characteristic? It is large testicular size, which is going to be macroorchidism. That is very, very important. Now tell me, I'm only talking about men getting affected because usually it tends to show more commonly in men. So now the question in INI-CET will be, what are the female carriers going to show you? Now this is a recent question. Remember, there is premature ovarian failure. The line from Robbins 10th edition says what is premature ovarian failure? Before the age of 40 years, the ovarian reserves and the eggs tend to decline. So premature ovarian failure, POF, is seen in female carriers. That could be a very important question. Very good. Okay, what is the investigation of choice? All of you just told me it's going to be PCR, amplicon length analysis. However, if the disease is very severe, this is going on in ages, in families since many, many years and generations. If PCR fails, then what is the next technique in the lab that I can be doing? It is going to be Southern blotting. Very good. It is Southern blotting. So before I proceed to PCR, all of you will tell me all the different types of blottings that we have. So I think everyone remembers that dosa, roti, pizza story. When I talk about Southern blotting, so in South there is consumption of dosa. So what are you going to detect? In Southern blotting, we are going to detect DNA. Okay, in northern blotting, of course, in north there is consumption of roti. So in northern blotting, we are going to detect RNA. Excellent. In western blotting, in west there is consumption of pizza. So what are we going to detect? It is going to be protein. Examiner also knows this dosa, roti, pizza mnemonic of yours. So now the examiner will ask you, what are you going to do for what do you do eastern blotting? What purpose does eastern blotting solve? So did you notice, usually go back to biochemistry. Do you all remember of course you do, central dogma. What is central dogma? DNA changes to RNA, RNA changes to protein. So you've detected everything. You've detected DNA, then RNA, and then protein. But what if someone has a problem after protein formation? What is protein formation? Translation. DNA to RNA is transcription. RNA to protein is translation. What if there is a defect after this? What is for post-translational modifications? Excellent. For that you have Eastern blotting. Okay, so post-translational modifications is the INI-CET question that you can expect. Okay with everyone? Can we get going and get back? Because the main deal over here was that for lengthy DNA, I will use PCR, and the type of PCR I will use is amplicon length analysis. These are all the different types of PCR that I've got, which you have to fill in the blanks for me. So these are the types of PCR. This you have same screenshot from your rapid revision. It's a rapid review that you do. So whenever you have lengthy DNA, you are going to do amplicon length analysis. Example, Fragile X syndrome. When do you do Sanger? Sanger is what is in every lab. Once upon a time only Sanger was done, because excellent, Sanger is said to be the gold standard PCR. So this is something which you have in almost every laboratory. Let's talk about the next. This is where I expect these two, where I expect a question in INI-CET. Single base primer extension. For example, do you remember in the last class I taught you one genetic analysis, that is BRAF V600E? Do you remember? Where were we seeing it? I'll quickly write it. You see it in Langerhans cell histiocytosis. Last slide we did. If you read it opposite, it is going to become hairy cell leukemia. Then there were two more P's, if you remember. One was P for papillary carcinoma thyroid, and one was P for a brain tumor, that is pilocytic astrocytoma. And apart from that, what else? Very good, guys. There was also colon cancer and melanoma. So just imagine that there is a patient who's having, let's say, hairy cell leukemia. Now I know 100% that hairy cell leukemia will pakka have BRAF V600E mutation. I know exactly the codon that I have to test. I have to test 600 codon of my DNA. So single base, whenever I have a known locus that I know, either I don't have to test all the genes. I only have to test BRAF gene. I only have to test codon 600 and I'm settled. Let me give you one more example. I'll tell you the gene, you tell me the disease. Another example would be, let's say, JAK2V617F. In which disease do you have JAK2 mutations, which is very, very obvious? It is polycythemia vera. So if a patient of polycythemia comes to me, high hemoglobin, high hematocrit, I know that I have to focus only on codon 617, only JAK2 gene, and this patient will be done. Excellent, guys, done. So SBPE means single base. I have a known locus. On the other hand, what is pyrosequencing? Pyrosequencing is whenever I'm dealing with a contaminated sample. Contaminated sample doesn't mean that you took a breast biopsy and in that there is some bacteria virus contamination. No. Contaminated sample means that you took a breast biopsy. Why will you take a breast biopsy? Because patient has breast cancer. That is what you are assuming or you've detected. Imagine instead of the cancer cells coming in the biopsy, आसपास का इधर उधर का surrounding fat and ducts come. So basically there is going to be a low tumor yield. If there is a low tumor yield, then you will know definitively that okay, I have to do which kind of PCR? Pyrosequencing. So examiner will say you are an intern or you are a JR first year, resident first year. You did a true cut biopsy of the breast cancer, but cancer cells are only 8%. You did a true cut biopsy of prostate enlargement, but the cancer cells are only 10%. Low tumor yield, you do pyrosequencing. Okay, coming to the next. When do we do RT-PCR, reverse transcriptase PCR, whenever I have to detect RNA? So of course, the best example for me will be COVID. Coronavirus was an RNA virus, but in Corona, were you doing only RT-PCR or were you doing a combination of RRT-PCR? Okay. Screenshot क्यों नहीं होता? I'm sorry. अच्छा, Dr. Tane is saying that because that is how the app of course works. That's, you know, copyright policies that the screenshot will not be allowed in any app for that matter. Coming back, when I talk about RT-PCR, reverse transcriptase PCR, I'm adding one more R to it. That one more R is actually real-time PCR. You know what real-time PCR does? It tells me quantity. So if someone asks you for COVID, were you only doing RT-PCR or were you doing RRT-PCR? I was doing a combination of reverse transcriptase also and real-time also, because real-time was telling me how much of viral load is there. Patient is having how much of virus. I'll give you one more example. Just say there is a patient of CML, of chronic myeloid leukemia, and the chromosome, you all know, Philadelphia chromosome is what the patient is suffering from. So they will ask you, Philadelphia chromosome is which fusion? BCR-ABL fusion. They ask you how many BCR-ABL fusion copies are going to be there. How many? जब भी question आएगा ना, how many, quantity बताओ, how many. So which kind of PCR will you use? I will be using the quantitative or real-time PCR. For anything, they ask you count the number of the genes. Quantity, quantitative PCR. Okay, coming to this, genome-wide association study, GWAS. It tells me it is when pathology meets PSM, because now you want to do some association study, you want to do some population study. So that is when you are going to do, like say you one day you say that ma'am, nowadays everyone is having diabetes, India, US, everyone, it's being declared as the diabetic capitals of the world. Why are so many people having diabetes? Is it only lifestyle or is it also genetic? I want to find out. I have taken 100 million people for my study and I want to find out why they have diabetes. You're doing a population study. You are trying to find association. You use GWAS. Okay, so these are all, but now I think for INI-CET, what they will be asking you, and this I have added in your Rapid Revision 6.2 also. What is nested PCR is what they will ask you. Second, they will ask you what is going to be droplet PCR. And third, they will ask you what is multiplex PCR. In case you've not seen Rapid Revision 6.2, then this slide has been added from the previous version. So now listen very carefully. Usually, when I do pehle to any random, any normal wala PCR when I do na, I am going to add one primer. What am I trying to do in PCR? In PCR, ma'am, polymerase chain reaction. Polymerase means you are trying to grow the DNA. You add one primer and you grow the DNA. But if I decide that I am going to add two primers, then I am trying to do nested PCR. Why? Because this will be more specific. How I have learned it is that whenever you're talking about a nest, it's always a love nest. A love nest will always have two birds, male, female, or any two birds of any gender. So when I say nested PCR, so it has to have two love birds in the nest. Means the kind of primers that I will be using will be two primers that will basically make the PCR more specific. But if I use multiple primers haphazardly, multiple primers I use in a haphazard formation, that is going to be the multiplex PCR. So I'll just remind you this from your INI and NEET PG preparation. If I tell you just stick to two things, stick to your notes and your Q bank. I'm telling you to study in a nested PCR fashion because I'm telling you to do two things, notes, Q bank, khatam. But if you decide that no, I have to study from PrepLadder also, I have to study from all 500 apps in the market plus YouTube plus Telegram plus ABCD XYZ har jagah se, then in a haphazard manner if you're studying, you are doing multiplex PCR, which is a better way of studying from 1 million places or studying from two things and khatam, notes, Q bank karo, sorted raho. So obviously the specific one is nested PCR and multiplex PCR is going to be non-specific. But then you decide that no ma'am, I'm not studying for INI-CET, I'm studying for next year, I have 1 year. So now go back 1 year in life. How were you studying 1 year back? You were not planning to do a crash course. You were saying no, I will take one topic, I will keep reading it for 5 days, I will keep reading PCR only. You were breaking one PCR into chota subtopics, then you were studying it from 5 million sources because you thought that you have all the time in the world. That is when you were doing droplet PCR. Whatever is your target DNA, you are actually going to break it into multiple parts. And when you break it into multiple parts, that is when you are going to do the PCR. So say for example, you have DNA X. I have broken it into X1, X2, X3, X4, X5, multiple parts, and on every 1, 2, 3, 4, 5 part I am doing a PCR because this will help me in counting absolute quantification. It will help me in absolute quantification. Why? So just imagine, like I said, you decided, okay ma'am, PCR, I will break it into chota subtopics, then I will do questions of every topic because then I will get to know that do I know PCR in a lot of detail. So you were trying to find out your absolute score. How much do you know percentage? जैसे custom module में करते हो ना, what is my strike rate? How much have I gathered? 80% right, 90% right. That is what is going to be droplet. How I have learned, big drop is broken into small droplets, and that is going to be droplet PCR. तो repeat कर दो. Love nest, 2 PCRs or 2 primers are used. Multiplex, multiple primers are used. And in droplets, one big DNA broken into small drops, and that is when you do PCR. All PCRs okay with all of you. Now you don't even have to look at RR 6.0. I have taught you everything in this only in case you had not viewed it. So this is also done and settled. Now we are going on to the next question. I hope everyone all good. PCR clear हो गया. अब PCR question solve करोगे and fingers crossed you will get it right. Okay, which of the following anticipated clinical presentations in patients depicted with the karyotyping image? There is a certain, and this is what came in the recent NEET and FMG also, so I've got it. In the kind of karyotyping given, which is the anticipated clinical presentation. Okay, everyone is saying A. तो क्या बनाया? Because over here I can see a gender problem. There is XXY. This is 47XXY means it's a case of Klinefelter, exactly. And Klinefelter extra X chromosomes obviously means that the male is, it's actually a male, but gynecomastia will be there and there will be long limbs. Now obviously there is going to be testes only because it's a male, XY hai. But because of extra X chromosome, the testis size is going to be small. So keep these buzzwords in mind. If the testicular size is big, macroorchidism, you think of fragile X syndrome. If the testicular size is small, they write hypogonadism. In males, small testicular size, you start thinking of Klinefelter. So now coming back, what technique was this? This technique, before I go to that, thoda sa mujhe tell me a little bit of pediatrics also. Where do you see this webbing of the neck and lymphedema? I think webbing of neck, everyone thinks of only one thing, that is 45XO, that is Turner syndrome, yes. Where do you see polydactyly, in which trisomy? We've always learned P for polydactyly, P for Pettau syndrome, so trisomy 13 is going to show you the polydactyly. Perfect, we all know it. Chalo, but what is this? This is going to be karyotyping. Ye kara kaha? Which phase is it done in? This is always done in a metaphase. Metaphase arrest is going to be done. So before I go ahead, please note there are only 2 questions of arrest that are asked to you in the entire 19 subjects, for that matter, all exams. There are 2 arrests. Where do you arrest the chromosomes when you're talking about karyotyping? And remember in the last class, the last slide that I taught you was about that fish fluorescence in situ hybridization. which was, if you remember clearly, it was to do with something to do with the breast cancer, HER2 new amplification, yaad aa raha hai? So for karyotyping, the arrest that we do is best at metaphase, and in fish, the arrest that we do is best at, very good, I've got the answer, that is going to be interface. So these are the only two questions on phase arrests that you can get. Khatam ho chuka hai. Coming back, karyotyping mein you're going to do metaphase arrest. How are you going to do? What chemical are you going to add? It is going to be colchicine. That is the chemical added. Okay, after you've arrested, now you're going to fix. I told you the fixative last time. The name of the fixative was carcinoma fixative. Jaldi tell me, what is the fixative that you use for a testicular biopsy? Do you want to ask me, or you want to give me an answer, or you want to ask me something more, that ma'am, why are you doing a testicular biopsy? If I'm doing a testicular biopsy for infertility, what is the fixative that you use? Bowen's fixative. If I'm doing a testicular biopsy for cancer or any other reason, then you use the routine that is going to be 10% neutral buffered formalin. Very good. Yaad hai sabko. I'm happy. Coming back to karyotyping. First I did chromosome arrest at metaphase. After that I put a fixative and I had told you so carcinoma fixative. But now we are going to do banding. Now in case you get confused, banding is nothing but staining. You have to add some color, na? But chromosomes, if you look carefully, they become like bands. Can we all see dark and light bands? So when you put some color, chromosomes become dark, light, dark, light. So I call it banding. There are two important types of banding that you have to know. One is going to be G banding. The reason of calling it G is the stain that I use. Giemsa color is used, or Giemsa stain is used, and Giemsa stain is always looked under which microscope? Light microscope. The other one that they ask you, excellent, is Q banding. Q banding, which stain am I talking about? Quinacrine stain. And for the queen, I have always told you, you will need something fancy. So queen ke liye fancy microscope, fluorescent microscope. Giemsa I call as Garib wala microscope for a pathologist, although it's not at all inexpensive. Microscopes are very expensive, but the least expensive microscope, Garib microscope, is going to be light microscope, and fluorescent microscope is damn expensive. So it's a fancy microscope which I've kept for the queen. I hope all questions of karyotyping is done. Ab baki simple questions I'm not telling you. What if over here, let's say on chromosome 21, there would have been 3 chromosomes sitting, then you would have called it trisomy 21 Down syndrome. If over here on 18, 3 would have been sitting, you would have called it trisomy 18, that is going to be Edwards syndrome. If 3 sitting over here, you would have said, oh ma'am, trisomy 13, that is going to be Pettau syndrome. These kind of stupid questions, they can be asked. Stupid, why? Because I think everyone will be able to solve them. Over here, XXY is going to be Klinefelter. Acha, what if there would have been only single X chromosome and these two would have been missing? If it would have been 45XO, then you would have called it Turner syndrome. So as I think these are simple ones for us, and we can move forward. Let's go on to the next technique that we have. This is an integrated question of systemic and general pathology. We have a liver biopsy of a 4-year-old boy who reveals intracytoplasmic inclusions with pus stain. Ek to na, when liver and pus stain comes, aur kuch sochna hi nahi hai. There is only one thing you can practically think of, and that is liver. 3 buzzwords: liver, chota bachcha, and pus stain. It can be nothing but alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency occurs in chota bachcha's childhood onset, and pus stain is liver, cannot be used for anything else. They said which protein electrophoresis graph best correlates with it, and I'll zoom in for you. Maybe you guys will be able to first to dekh lo. So over here, you obviously, if you're thinking of alpha-1 antitrypsin deficiency, then you had to mark B, because over here I can see they've highlighted the alpha-1 area has become a little less. So for the answer point of view, the answer was this graph. But now before I get on to this, let me ask you, when I teach you alpha-1 antitrypsin deficiency, let me enumerate all the PYQs first. First tell me, alpha-1 antitrypsin gene is present on which chromosome? It is chromosome 14. Ye inka famous PYQ hai, for some reason they love asking. Alpha-1 antitrypsin gene, chromosome 14. Question number 2. What is the childhood onset? Why is alpha-1 antitrypsin deficiency childhood onset? Because it is an autosomal recessive disorder. Every autosomal recessive disorder tends to begin very early in life. Childhood onset. Look at this, 4-year-old bachcha. Sometimes they give you 18-month, 24-month-old bachcha. And in our country, bacche ka, the famous word or the pet name given to a bacha, famous pet name of our country is Lal. Every mother calls her chota bacha as Lal. So when I'm talking about a Lal of alpha 1 antitrypsin deficiency ka child, the Lal is going to have Lal, that is a problem in the liver and a problem in the lung. Simple. There will be one bacha Lal, chota bacha Lal, and he will suffer from liver and lung problems. What in the liver? There is going to be liver cirrhosis. And what in the lungs? Before I write this, you will tell me lungs में क्या होता है alpha 1 antitrypsin deficiency में? There's a kind of an emphysema that is known as pan-acinar emphysema. So whenever a mother comes to you with a chota bacha Lal in her hand and she says, my Lal is suffering from Lal, that is liver cirrhosis and pan-acinar emphysema, liver and lung problem, you're like, okay, this is alpha 1 antitrypsin deficiency. What stain will I put? I will put something Lal. Lal matlab reddish pinkish. What is that reddish pinkish stain that I have put? I am going to put pus positive, and that I can see over here, these pink colors. So reddish pinkish, again Lal. That is how I'm going to put this. So this is certain. All these are done. Now coming to what I was asking you, protein electrophoresis. Before I get into this, पहले normal पढ़ लेते हैं. It is written as SPEP. Okay, SPEE, is it the same pathology for recurrent abortions? Khushi, are you confusing? I don't know. I'm just trying to figure out. Are you confusing alpha 1 antitrypsin with APLA syndrome by any chance? Because APLA syndrome is what is antiphospholipid antibody syndrome. That is responsible for recurrent spontaneous abortions. I assume that you have kind of messed up both of those. वो अलग होता है, ठीक है? This is totally different. हाँ, so वो अलग है. We got it right. So that is separate. APLA is separate. Antiphospholipid antibody syndrome होता है. This is alpha 1 antitrypsin deficiency. Okay, coming back, chalo, never mind. See, whenever you start getting confused between random alphabets and random short forms and diseases, means ज़्यादा पढ़ाई कर ली है. That is a sign of having studied more. So never take it as a demotivation. Take it as a motivation that I've studied more, and that is why I'm getting confused. जो नहीं पढ़ेगा उसे कोई confusion तो होगा ही नहीं. Obviously, he will have a crystal clear concept in the mind of zero knowledge. Okay, coming back, why is it written as SPEP? Because this is known as serum protein electrophoresis. The first mistake that students do in the exam is they just see this graph and they start answering. वो देखते ही नहीं कि एग्जामिनर ने सैंपल क्या लिया. इज इट अ सीरम? मीन्स इज इट अ ब्लड सैंपल? ये तो ब्लड है. और sometimes they also do urine electrophoresis. Please read examiner ने क्या sample लिया है. If examiner has written SPEP, he's taken a blood sample. So if I come back, examiner had mentioned, okay, this is a blood sample. Please keep that in mind when you go in the paper. Now, if I'm talking about a normal, and how do we learn normal? We've always seen that hand diagram that is made. If you now look carefully, this will, normal proteins look like a hand. So what is the maximum protein that you've got? What is this spike that you've got in the blood? Normally, all of us have something called albumin. ठीक है, this is maximum. हमारे blood में maximum is albumin. After that, you can see 3 छोटा hills. 3 fingers की तरह, 1, 2, 3 like this. Can everyone see that? So this is alpha 1 protein, alpha 2 protein and beta protein. Khatam. So what is maximum in your blood? It is albumin, then alpha 1 protein, alpha 2 protein, beta protein, and then comes one chota sa hill. This hill over here is the gamma protein. Gamma matlab immunoglobulins. So all your antibodies come up over here. So everyone make this right now. Exam में इसको ऐसे उल्टा पुल्टा कुछ मत बनाना. Don't become जादू sitting over there. Make it with me over here so that you know exactly क्या होता है. Okay, so you have albumin, then you have alpha 1, alpha 2, beta, and then you have gamma. Let's go into detail. Albumin हमें पता है, it is albumin. Gamma, I have told you, it is immunoglobulin. What comes under alpha 1, alpha 2 and beta? Almost obviously, common sense tells me that alpha 1 antitrypsin will obviously come under the alpha 1 variety. So that is what you have to know. Next, they ask you, where does alpha 2 macroglobulin comes? So that is also common sense, alpha 2 mein aayega. And haptoglobin they ask you. So remember, haptoglobin is learnt as haptoglobin because this is which kind of protein in our body? It is an alpha 2 protein. So simple. Alpha 1 mein aayega alpha 1 antitrypsin, alpha 2 mein aayega alpha 2 macroglobulin, plus there will be haptoglobin. Now whatever is left, like transferrin, very important, that is going to come under beta, and of course beta lipoprotein will come under beta. तो वो तो नहीं याद रखना, सिर्फ transferrin comes under beta proteins. What comes under gamma? Obviously under gamma it is going to be immunoglobulins. Terminology समझ आ गया? Albumin, alpha 1 में सब कुछ alpha 1 that is alpha 1 antitrypsin, alpha 2 में सब कुछ alpha 2 that is alpha 2 macroglobulin and haptoglobin, beta में सब beta lipoprotein, all beta things, and transferrin, and gamma में globulins, immunoglobulins. Now tell me, can you give me a test? What do you think this is a case of? I can see the same, ma'am. Albumin है, then I can see 3 chota 1 2 3 fingers, but suddenly this thumb of mine has become like this. It has become a very long spike. What is this a case of? Yes, it is a case of multiple myeloma, because this is the M spike. Suddenly there has been a spike in immunoglobulins. Multiple myeloma का most common immunoglobulin कौन सा होता है? It is going to be IgG. So now you know how to read that. Okay, yeah, there is an M spike in the gamma region. Immunoglobulin must have increased. और देखते हैं. The first one, they will most of the times they give you one normal graph for reference. Usually ऐसा होता है. तो यहाँ पर they've given you a normal graph for reference. And now if you compare it with the next, can you see which of the following fingers has suddenly gone down? Alpha 1 wala finger has gone down. This is a case of alpha 1 antitrypsin deficiency. This is what was asked to you. आगे देखते हैं. Look at the next one. This one, the fourth one that is over here is the most important. इस पे focus करो. And over here they have told you that the main protein of your body has gone down. Why do you think this albumin will go down? What is that syndrome जिसमें or blood में? This is again, I'm telling you, this is in the blood. Why has the albumin gone down in the blood? Because all the albumin has gone out into the urine. There is massive proteinuria happening. This must be a case of, exactly, it must be a case of nephrotic syndrome. This is also what I'm expecting apart from alpha 1 antitrypsin deficiency. Common sense, albumin level, that's why I said na exam mein ye dekh lena, have they given you blood electrophoresis or urine electrophoresis? Imagine if it would have been a case of urine electrophoresis for nephrotic syndrome, albumin level in urine would have gone very, very high, and that would also have been nephrotic syndrome, but that would have been a urine sample because all albumin goes out into the urine. Here they've given me a blood sample, so the albumin goes very low. So this is not the question that they ask you. Listen to me. The question that they ask you is that, okay, you will say albumin goes low, but do you know your body compensates? Your body always tries to compensate for any loss. So your body says, okay, albumin come ho raha hai, it's going down. Let me release or increase something else. Your body starts making other proteins. You will see there will be an increase in alpha 2, there will be an increase in beta proteins. That is just a kind of a compensatory mechanism that your body is trying to do. Who will tell me the toughest? Look at this. This is tough. I can see that, yeah, albumin production looks a little low. Fine. Is this nephrotic syndrome? No, because alpha 1, alpha 2, beta ये बढ़े नहीं, compensatory increase नहीं हुआ, but suddenly the beta and the gamma have gotten merged. Like instead of this, suddenly I can see that these two fingers have gotten merged. So there is a beta gamma bridging that has happened. Where do you see beta gamma bridge formation? That is seen in, yes, cirrhosis, liver cirrhosis में दिखता है. Basically what happens in liver cirrhosis, you know, liver has stopped working. If liver has stopped working, तो albumin तो बनेगा नहीं, albumin production will go down. How will your body start compensating? There is going to be a beta gamma bridging that happens. So now come back and solve the question again. If you look at the first graph was everything normal. Actually, this was a normal situation given to you. If you now compare it with the second graph, I can see that the alpha 1 has gone down. So this is alpha 1 antitrypsin deficiency, which was the answer over here. In the third graph, I can see the M spike happening, gamma, multiple myeloma. And in the fourth graph, I can see that beta gamma bridging happening. So this must be a case of cirrhosis. This was the toughest thing that I had to teach you today. Electrophoresis, जो सबको सबसे ज़्यादा problem देता है, because I think it's in the main videos. It's not in your not in detail in rapid revision videos. So students find it a little tough later on. But I hope all of you are settled. वो नहीं भी था तो clinically all of you understood it was PAS and alpha 1 antitrypsin. This settlement is also done. Can we move on further and discuss one? Let's move away from techniques. बहुत हो गया. Karyotyping भी हो गया, PCR भी हो गया, electrophoresis भी हो गया. One random systemic pathology question. Let's start. Please match the cancers of column A with the genes in column B. Okay, obviously there's no option. You will do it one by one with me. Where do you want to mark pleomorphic adenoma? It's the easiest. All that you had to do was pleomorphic adenoma gene, that is PLAG gene. So pleomorphic adenoma gene. So obviously this is what you mark as D. Acha, other ones I had taught you last time. Where do you want to mark Burkitt's lymphoma? Burkitt was in a child, so that was c-MYC. Okay, where do you want to mark neuroblastoma? Ye bhi last time padha tha. Ma'am, you said N for neuroblastoma, N for NMYC. Very good, everyone's getting that also right. And this, I'm not even asking you, retinoblastoma ke liye retinoblastoma gene is going to be there. So what I actually wanted to teach you over here, this was an INI-CET PYQ. I wanted to teach you questions about pleomorphic adenoma that have been asked. Means we all know pleomorphic adenoma is the most common salivary gland tumor, parotid mein hota hai. So pehle to you have to tell me how does normal salivary gland look like. This is also something that I'm teaching you from INI-CET perspective that you tend to miss out. Normal salivary gland if you have to identify. And before I start, let's see if you've learnt your anatomy well. This is a salivary gland. इससे पहले का आंसर कौन से वाले पहले का आंसर? आई हैव टोल्ड यू द आंसर ना. इससे एंड उससे पहले का आंसर ऑल्सो वी हैव ऑलरेडी डन. ये आंसर कर लिया था अल्फा 1 एंटीट्रिप्सिन. आई थिंक वी हैव सेटल्ड दैट. डॉक्टर तनय, वी आर डन विद द आंसर्स. अभी इसके अंदर वी आर गोइंग टू स्टडी अबाउट प्लियोमॉर्फिक एडेनोमा. बट बिफोर प्लियोमॉर्फिक एडेनोमा, हाउ डज नॉर्मल सलाइवरी ग्लैंड लुक लाइक? सलाइवरी ग्लैंड का कंफ्यूजन किससे होता है? इट इज ऑलवेज कंफ्यूज्ड विद पैंक्रियाज, एंड दिस वाज 2 years ago INI-CET question. INI means tough questions, and this is the toughest part that you can have, a slide confusion. So last class, if you remember, I told you that normal kidney will be asked, normal thyroid gland हमने देख लिया था. Now I'm showing you normal salivary gland and pancreas. Now in a salivary gland, what will you see? You will see all the area. I'm not telling you to zoom in, I'm not telling you to become a pathologist, I'm telling you to find out some way of identifying it in the exam. So you can see that there are dark color. Can we all see there are some areas which are very dark, pink, purple types, and then there are some areas which are looking little whiter. Everyone can identify because the dark areas are going to be the serous acini, and the light areas, that the darker ones are serous acini, and these light areas that you have, those are going to be mucinous acini. So please remember, now let us zoom in. All these dark cells are going to be the serous acini, and all these light ones are going to be the mucinous acini. That is what a salivary gland is. It is made up of two things, serous acini, mucinous acini. I realized that when I went to pancreas देखो दोनों को zoom in करके side by side करके देखो, pancreas भी same लग रहा था. Salivary gland also has dark pink color cells, and pancreas also has dark pink color cells. तो मैम this means serous acini दोनों में होते हैं. Yes, pancreas is also going to have serous acini. That is also something that pancreas has. So how will I differentiate in the exam? They will say this is a gland. Gland will be given. Now is it a pancreas gland or is it a salivary gland? दोनों में मैम pink structures were there. But suddenly I realized salivary gland will have these totally white mucinous acini. Totally white mucinous acini. Whereas pancreas, I want you to figure out, इसमें a yes or no. I'm not telling you to be biased. I'm asking your opinion. Do you think पूरा same pink है या फिर कहीं पर मुझे थोड़ा सा एक lighter pink focus दिख रहा है? And say yes if you genuinely agree. I'm not telling you to force it on you. But do you think that there is some areas in between which are looking slightly less pink in color? Yes, because in the pancreas there is something also known as islets. Islets of Langerhans, that the cells which are going to release can see. Chalo, all of you agree. Someone asked me, ma'am, how do you identify the pink and blue? Never mind, when I was still your internship, when I was giving my NEET PG or my exams, do you think I used to identify all of this? No, I also used to think this is all pink, blue and nonsense. That was my perspective. I also learned it when I got trained in residency. So no one is expecting you to become a pathologist at an undergrad level. All of us have gone through the same and we don't identify. That is why at the first slide I told you, I don't want you to become a pathologist right now. I just want you to find out some tricks of how to solve it in the exam. So दोनों pink दिखेंगे because दोनों में there is going to be serous acini. One is going to have total white areas because salivary gland also has mucinous acini, but one is going to have light pink areas, not white, थोड़ा light pink है because those are the islets of Langerhans which are going to release all the insulin and everything, etc. Okay with this? And Khushi, for you, your question is valid कि मैम मुझे तो ये समझ ही नहीं आएगा कि do I have to get confused between salivary gland and pancreas? So the question will not be a spotter. They will always say that there is a gland in the body which has been shown as histopathology below. Gland word लिखा होगा. चलो अगर नहीं भी लिखा, you will read the options. Options में option A will be thyroid. Is it looking like thyroid? No. You will start ruling out. Option B will be glomerulus. Is this looking like the kidney? No. Option C will be salivary gland. Option D will be pancreas. Then you will automatically start thinking कि अच्छा हाँ मैम ने कहा था salivary gland and pancreas are two differentials. Now let me start thinking on those terms. So if history is not given, you have options. You don't have to write a short note now. You have options to help you, and options really help you in narrowing down the subject and the topic. Okay, coming back. Why were we reading all of this? Because I want to teach you pleomorphic adenoma. Pleomorphic adenoma in surgery, what is the other name? It is also known as benign mixed tumor. Benign I understand because anything with the word oma is benign, but why do I call it mixed? Because it has two components. Mixed means it has two components. One is epithelial, one is mesenchymal. तो पहले epithelium ढूंढते हैं. Whenever I say epithelium, I mean cells, and I can see lots of these goal cells over here, so I will label it as E, that is epithelium. When I say mesenchymal, you know mesenchymal always means other than epithelium, of course. Mesenchymal means fat or muscle or cartilage or bone. So over here you see a lot of cartilage. You see chondromyxoid areas. Everyone knows chondro means cartilage, and cartilage looks blue in color in normal anatomy. So this is the mesenchymal area. Ye cells wala area ban gaya epithelial. The cartilage wala area is going to become this bluish mesenchymal, and because both are seen, it is a benign mixed tumor. Now tell me the gene, PLA gene. So this is going to be PLA gene, plague gene mutation. Pleomorphic adenoma ho gaya. Can I also teach you two more salivary gland tumors and wrap it up? For that you will answer one question for me over here. One more salivary gland coming your way. Very famous INI question. There's a 40-year-old chronic smoker who presents with bilateral swellings of the parotid gland. On examination, the swellings are soft, cystic in consistency. Right jaw ka alag measurement 3/2, left jaw ka basically bilateral hai. Okay, the FNAC shows murky fluid in the syringe. Some murky turbid fluid has come, and you can see the biopsy has been shown below. Everyone is saying that the answer is Warden's tumor. So for that, you are right. Warden's is also a benign tumor. Pleomorphic adenoma was the most common benign tumor. Warden's is also a benign tumor. You will tell me what is the other name of Warden's. Then in surgery, ये सब surgery चल रहा है. Patho तो I'm just teaching you because INI tends to integrate. So can you let me know what is the other name of this? Yes, very, very good. It is going to be papillary. Okay, so don't get too, don't get too overwhelmed by this name, but Warden's tumor is also known as papillary cyst adenoma lymphomatosum. Ma'am, what a tough name. But now if you focus on every name part of the word, you will be settled. Number one, why do I call it papillary? Because somewhere in the photo they will always show me that ऐसे ऐसे कुछ papillae बन रहे. They will always show me that there are some kind of papillae that are forming like this. So papillary word, finger like papillary, मुझे समझ आ गया. Next, they will say cyst. Cyst means, in my question, was the word cyst mentioned? Yes. The swellings are soft cystic. Cystic मतलब उसमें कुछ fluid होगा. What fluid is coming out of it? Murky fluid is coming out of it. So on FNAC there is going to be murky fluid that will come out from the cyst. Okay, cyst adenoma, oma tells me it is a benign tumor, so this confusion is also done. And lymphomatosum, it is going to have lots and lots of lymphocytes. Was this written in the question, ma'am? हमने तो देखा नहीं. चलो दोबारा ढूंढ लेते हैं. On FNAC, when they said there was murky fluid in the syringe, the smears prepared showed lymphocytes scattered in the fluid background. देखो सब कुछ लिखा था. Everything was written. What else will be written now? On clinical features, it tends to be I'm not saying always, but usually bilateral. And history of smoking ke bina Warden mat banana. This is the most important point of Wardens that you have to know. See, smoking history for two places in INI-CET point of view बहुत important है. One, for Wardens, they love to give you smoking history. Second, can you tell me one vasculitis which is because of smoking? Just telling you some random questions, then I'll come back to this page. अगर smoking से related question आया, salivary gland में पूछा, you will write Wardens. But if they ask you from point of, see, I had told you smoking, B for BD, B for Berger's. Berger's disease is always given as a history of BD smoking. This is their favorite vasculitis to give. So I hope everyone was aware of this also. Second, one more pointer I want to tell you, whenever they talk about bilateral parotid gland involvement. So can you all let me know कि अगर ये बच्चा होता, बच्चा तो chronic smoker नहीं होगा ना? बच्चा विल नॉट बी अ क्रॉनिक स्मोकर। तो बच्चे में तो मैम वॉर्डन्स नहीं सोचेंगे। फिर बायलैटरल बच्चे में कौन सा वायरस इन्फेक्शन, आई विल थिंक ऑफ मम्प्स, यस। एंड इफ इट इज एन अडल्ट एंड इन द अडल्ट दे आर टेलिंग मी देर इज अ हिस्ट्री ऑफ स्मोकिंग, देन आई विल बी थिंकिंग ऑफ वॉर्डन्स ट्यूमर। जस्ट वन थिंग, ऑल ऑफ यू न्यू दिस, आई एम वेरी हैप्पी, यू गाइज आर ऑन ट्रैक। एक छोटा सा गलती, आई नो यू नो इट, वो लिखने में हो गया होगा। द बर्जर्स दैट आई हैव रिटन एंड द बर्जर्स दैट मेनी ऑफ यू वर टेलिंग me are different. So one more pointer that I want to write over here, there is something known as this BER Burgers, and then there is something known as BUER Burgers. Both will be written in the exam. The Burger that I am talking about, vasculitis, is the U wala Burger, which all of you were writing as thromboangiitis obliterans, angiitis, vasculitis. Ma'am, U wala Burgers is the V wala Burgers, that is the vasculitis. The other Burgers that you have written is a kidney disease, that is going to be IgA nephropathy. Very good. So this is going to be IgA nephropathy. Okay with everyone? So U wala Burgers is V wala Burgers. Excellent. Perfect. Coming back, why was I teaching you? Because Warden's occurs in bilateral parotid gland, Warden occurs in a chronic smoker, cyst banega, उसमें से fluid निकलेगा, lymphomatosum will tell me lymphocytes. Now the only thing that I'm left with is, ma'am, now I've understood in this, ये blue color तो सारा lymphocyte ही होगा. All of you have told me it is lymphocyte. But other than that, what are these pink color cells? This I will ask you. These pink color cells on histopath, there are two rows of yes, oncocytic cells. Can anyone tell me what is the meaning of oncocyte? Last class I taught you that whenever I say the word oncocyte, which organelle is going to be much present, common in it? It is going to be the mitochondria. Yes, these are two rows of mitochondria wala cells, oncocytic cells, and there are going to be lymphocytes. Go back to your question. Was this given anywhere? Yes, I could see all these blue color areas which were the lymphocytes, and all these pink color cells were oncocytic cells. This was pakka a case of वॉर्डन्स ट्यूमर. ध्यान से पढ़ो. देखो, क्रॉनिक स्मोकर भी लिखा था, बायलैटरल भी था, सिस्टिक भी था, मर्की फ्लूइड भी था, लिम्फोसाइट भी था, पूरा शॉर्ट नोट लिखा था. एवरीथिंग वाज गिवन. नाउ वन लास्ट क्वेश्चन. कैन यू टेल मी विच इज, ऑल्दो इट्स given, but this is a previous year INI-CET question that was there. पहले तो read it. Which of the following clinical features is not observed in pleomorphic adenoma? Let's first take your question on this. Then I will teach you something new. Not observed. देखो ध्यान से mark करना. Not observed. D. Because right now, ma'am, you told me pleomorphic adenoma is a benign mixed tumor. When you say mixed, it is going to have all different kinds of cells and keratin. ये सब mixture of tissues दिखेगा. नर्व इन्वेजन ऑफ कोर्स नहीं दिखेगा. तो पेरीन्यूरल इन्वेजन दिखता कहाँ है? 3 tumors of the body where पेरीन्यूरल. and why am I wanting you to know? Nerve invade हो भी गया. Why do I want you to know? Because pereneural invasion will automatically tell me that the patient will come to me with a lot of pain in that situation. So remember, number 1, pancreatic cancer, number 2, prostate cancer, and salivary gland में पढ़ रहे हो तो with salivary gland cancer, adenoid cystic carcinoma. So does pleomorphic adenoma show me perineural invasion? It does not show me. So repeating, pancreatic cancer, prostate cancer, and salivary gland में adenoid cystic carcinoma. So now for INI-CET, they will ask you that this cancer shows you which particular translocation. सिर्फ INI के लिए याद रख लो, it is showing you translocation 6-9. That is what is important. Okay with everyone? यहाँ तक हो गया. All your salivary gland tumors are done. Can I move forward? Too much of salivary gland done. I'm asking you one essay, random question. Let's see if you can answer. It's a total switch in your subject only. Just randomly, and I'll tell you why I'm asking you this. Okay. Which type of appearance is shown by bacillus anthracis on gram staining? In the middle of path, suddenly you've got a micro in front of you. What type of appearance is seen in bacillus anthracis on gram staining? Okay, very good, ma'am. BA, bacillus anthracis shows me the bamboo stick appearance, and this is how it looks like. Why did I teach you this? Because in the last FMG exam, instead of bamboo stick appearance, it was written as box scar appearance. it means the same. Again, why am I teaching you that? Because first I will show you, look at this. This is how Bacillus anthracis looks like. It is looking exactly like a bamboo stick, or you want to call it a box car, you want to call it dabba, stick, bamboo, box, whatever. It means the same. Why did I tell you that? Because there is a pathology question that comes related to it. And this is exactly what I want you to know. I'm teaching you. There is a patient who's having some difficulty in breathing during physical activity, and on echo there is mitral stenosis and left ventricular hypertrophy. They've told you stenosis hai, hypertrophy hai. Please identify the histopathology that has been shown. So see, mitral stenosis can occur because of many things, but over here, did you notice what has happened in the heart? The nuclei are looking like boxcar nuclei are seen in hypertrophy of the heart. So now, what are the two boxcar appearances of path and micro? If they say that there is a patient, look at this guys, this is the normal heart. I can hardly see the nucleus, patla sa nucleus hai ma'am, something bluish which is hardly visible. Suddenly you are showing me the heart and look at the nuclei, they have become like big dabbas. They have become like big boxes. When does the heart start showing me box nuclei? When it is hypertrophic case. Which bacteria can show me boxcar or bamboo stick appearance? It is Bacillus anthracis. Dr. Vikalp, HOCM per se does not show you boxcar. It is not all cardiac hypertrophies, although hypertrophic cardiomyopathy can. But Dr. Vikalp, for hypertrophic, now what is this can be seen? This is like that can wala finding. What is more prominent in HOCM is haphazard arrangement of the cardiac fibers. That is helter-skelter, which you're calling it. Yes, haphazard or helter-skelter is more predominant. These may or may not be seen. So coming back, two boxcars that I wanted to know. If they ask you, where do you see boxcar nuclei in the heart? It is a case of hypertrophy. Usually, I'm not saying always, but they like to give you a history of secondary to hypertension or secondary to say like a stenosis that has happened. So these are the kind of histories they give because of that hypertrophy hua to boxcar nucleus dikha. Secondly, boxcar bacteria dikha to Bacillus anthracis. खत्म. ये छोटा वाला टॉपिक था. एक और छोटा भी I'm break के लिए I'm giving you fillers, छोटा 1 minute topic. These are all from your Q bank, so I'm making you revise important questions from the Q bank. Okay, so let's read. There's a 57-year-old male who presents to the emergency department with severe chest pain for 20 minutes, radiates to the left arm, nausea, sweating, ECG shows you ALMI, myocardial infarction. Okay, fibrinolytic therapy had to be started. However, patient's consideration is that he deteriorates and then he expires. Perfect. They have told you a case of what have you applied? You have applied TPTC, autopsy kara, TPTC apply kara. What is the color that will be represented by the viable myocardium in the presence of this stain? Viable, matlab living heart will show you a brick red color. Okay, so everything about TPTC you will be telling me. So when I tell you TPTC, triphenyl tetrazolium chloride, principle क्या है? It stains which enzyme? It stains lactate dehydrogenase type 1 because heart में सबसे ज़्यादा. Tell me quickly biochemistry, which LDH is more in the heart? In the heart it is always LDH1, but if I take LDH blood sample of you and me, normal people, normal लोगों के blood में it is always LDH2. So when I take a normal blood sample, which is the LDH that is going to come more in the blood, it is always LDH2. But if I take the blood sample of a heart attack ka patient, then of course LDH1 will start coming out because heart se kya nikalta hai? LDH1 nikalta hai. Is this in medicine known as flipping of the LDH ratio? A very important question that they ask you. कि normal blood में LDH2 होता है, MI वाले blood में LDH1 आता है, तो the ratio flips, flipping, reversal, whatever you want to call it, चलेगा. Coming back, अभी I'm not talking about blood. अभी I'm talking about a stain which is being put on the heart, and I realized that this is going to either result in a brick red color. So brick red color will signify that the heart is totally normal. But if I get a pale color, like over here, this area, the pale color will signify कि अच्छा वहाँ पे the blood supply was gone and that is the area which has died. But this is useful in how many hours of death, how many hours of MI? Within 4 hours of MI. After 4 hours, like say for example, someone had a heart attack at 12 o'clock in the night. Okay, chest pain started at 12 o'clock. The person has died before 4 o'clock in the morning. Within 4 hours of chest pain, if a person dies, then to this stain is useful. If a person started having heart attack at 12 o'clock and died after 4 o'clock, means he's died at 5 o'clock, 6 o'clock, or 8 o'clock in the morning, then I don't want to do TPTC. Why? Because then I can see without TPTC only the heart will show me mottling, the heart will show me color change. I don't have to use all these stains after that. These stains are only used because within 4 hours, the heart looks like a fresh, normal heart. You look at the heart and you will be wondering, why did this patient die? Within 4 hours, the heart shows no change. So you put TPTC, suddenly this area pops out as white and you're like, oh, the person died because he was having a myocardial infarction. So coming back is what they ask you, TPTC and viable. Living wala heart pucha tha, that is why I marked brick red. Dead pucha hota, I would have marked something close to pale white. Okay, coming to the next question, another INI-CET from your hashtag INI-CET from your QBank. Which histological finding is seen in reperfusion injury during autopsy? A very important one. You've seen this in your QBank. Reperfusion injury में क्या दिखता है? Okay, very good. Everyone is writing CBN, contraction band necrosis. So let me show you that image of contraction band necrosis. They will always tell you this is the heart. ऐसा कोई आपसे hidden नहीं रखेंगे. They will tell you this is a cardiac biopsy or this is a heart attack patient. Can you all see there are these pink color bands that have formed in the heart? These are all referred to as contraction bands. So now tell me, why did this happen? Microscopically, it will be written as CBN, contraction band necrosis. But हुआ क्यों? Ma'am, it has happened on reperfusion. I'll tell you why. See, coming all the way back to the previous MI question, did you notice when the patient came to you with chest pain and MI, what therapy did you start? You had started a fibrinolytic therapy. Okay, so let me draw that. For example, let me draw a very baby wala, bachcho wala heart. This is, I made a blue heart because this is a heart which is currently undergoing myocardial infarction. Why is this undergoing myocardial infarction? Because we will draw the coronary artery. Ma'am, coronary artery mein na itna bada, there is an atherosclerotic plaque or there is a thrombus or there is a blood clot. 95% blockage ho gaya coronary artery mein, the patient is going to have MI. So now just imagine, when the patient had this big blockage, did everything stop over here? All the calcium was getting accumulated over here. All the free radicals were getting accumulated over here because I had created an obstruction that calcium can't go further, free radicals can't go further. Now this patient goes to the hospital. Hospital people say what? They say, chalo, let's give fibrinolytic therapy. Let us dissolve the clot. क्लॉट को हटा देते हैं. सडनली द कैल्शियम सेज भागो, लेट्स रन टू द हार्ट. फ्री रेडिकल से भागो, लेट्स रन टू द हार्ट. इमेजिन सो मच ऑफ कैल्शियम कम्स इनटू द हार्ट मसल विल गेट एक्साइटेड, वो एकदम से कॉन्ट्रैक्ट करेगा. एंड व्हाट इज इट गोइंग टू बी? It is going to be contraction band necrosis. Suddenly the heart says, wow, so much of calcium, chalo contract karo. Then this is the wrong thing. Like you always say, that like all of you want, 1 hour mein ma'am pathology khatam kar do. In that, will you ever be able to complete entire pathology? No, you will end up dying in your Q bank. है ना? So this is what the heart did. The heart said कि जल्दी से सारा calcium लो, contract करो, but in the end the heart ended up dying. So this is what is contraction band necrosis. It is primarily due to calcium and it is due to free radicals. Now coming back, you will tell me which are the 3 places where contraction band necrosis can be seen. Do you know? Number 1, it is seen in MI. MI के बाद it is going to be reperfusion injury. It is going to be reperfusion injury. And the third one is also going to be one more place. Tacot-Subo-cardiomyopathy. What do you know about Tacot-Subo-cardiomyopathy? We know that it is a case of broken heart syndrome. Pata hai na, everyone's read this in medicine. Tacot-Subo is broken heart syndrome. You read everything about broken heart, that there will be a person who's had a severe heart break or some family issue or some monetary problem, emotional stress, बहुत problem चल रहा है. That is Tacot-Subo. But what does it show under the microscope? It shows you contraction band necrosis. Is that okay with everyone? Settled? Can we move on further and go and okay, very good. I can see some people are answering epinephrine की वजह से होता है. Catecholamines. Basically, whenever we have any broken heart or any stressful emotional condition, catecholamines increase. When catecholamines increase, that is why the result of Tacot-Subo cardiomyopathy occurs. Very good. Someone just told me अभी कि ma'am okay, जल्दी क्लास करा देना. See, that's what I said, jaldi. That is when I read that message and I give you that, jaldi, if I contract and if I give you too much of calcium, तो jaldi में we will not land up with good output. ठीक है? I know many of you might be fasting, including myself. So I am also fasting, but थोड़ा let us, अभी तो 1 hour ही हुआ, I can't finish the class in 1 hour. And I will also have my food after that in the evening only. So today let's fast together, okay? Anyway, coming back, now we are done with this. Now we move on to little lengthier questions, hoping that थोड़ा सा हम let's go on to tougher things. Easy काम हो गया. चलो यहाँ से शुरू करते हैं. The toughest 10 minutes are coming your way. Time boxing, next 10 minutes is all about these kind of immunity disorders. Let's start. Which of the following genetic defects is most likely associated with X-linked SCID? X-linked SCID, ध्यान से पढ़ो. You are saying A, but maybe you want to read all the other options. Guys, don't be in a hurry to say कि SCID मतलब adenosine deaminase हमने पढ़ा है, बस वही होगा. थोड़ा आगे कुछ पढ़ लो. Some of you are saying C, and that is the correct answer. Now the problem, all answers are correct. A, B, C, D तीनों correct है. The problem is that over here they asked you X-linked. XLR type of SCID is because of gamma chain problem, and all the others that were mentioned, they were responsible for AR kind of SCID. So now you will tell me what is the meaning of SCID. पहले तो full form बता दो. Severe combined immunodeficiency means what? Immunodeficiency means that the immunity is going to go down. Severe मतलब patient comes to you in a severe condition, it's a severe immunodeficiency. Combined का क्या मतलब है? B cells are going to be a problem, or T cells are going to be a problem, or NK cells are going to be a problem. Everything is going to go combined, सब उड़ गया. B cell gone, T cell gone, NK cell gone. That is why it's a severe infection. And the बच्चा is usually born with what? The बच्चा is born with a morbilliform rash. Morbilliform rash basically means that there is going to be a red rash that is going to be present on the face. बच्चा will be born with red rash वाला face. Now you will tell me what are the two types of SCID. There is going to be X-linked recessive SCID and autosomal recessive SCID. X-linked, जैसे X लिखते हो ना, X में से गामा बना दो. So what is the problem? It is the gamma subunit of the cytokine receptors. The gamma cytokine receptors are going to be a problem. That is what was given. If the gamma chain is going to be a problem, gamma looks like XLR. Whereas autosomal recessive SCID कब होगा? जब सारा AAA आएगा. मतलब if they say there is adenosine deaminase deficiency, जैसे यहाँ पे लिखा था, that was autosomal recessive. If they say there is a problem in RAG gene, then RAG also has A in it, so this means it is autosomal recessive. If they say there is a problem in JAK3 gene, that is also having A in it, that is also autosomal recessive. तो याद हो गया ना, JAK, RAG and ADA, ये सारे AA वाली चीजें are autosomal recessive SCID, whereas the gamma subunit वाला problem is going to be the X-linked recessive SCID. ये पूछा था यहाँ पे, so you had to mark gamma subunit. बच्चा will come to you with morbilliform rash. Is this okay? Can we move forward? Can I go on to the next question, which is an also one of their अच्छा sorry before that इनमें से अच्छा let's say if these are the 4 options, they ask you not X वाला, in general ये 4 options and they say which is the most common out of these, which is the most common SCID that you have. So XLR overall is the most common SCID, gamma chain XLR is most common. But if these 3 are the options and they say अच्छा autosomal में बताओ which is the most common, autosomal recessive में the most common is going to be ADA deficiency. ठीक है, overall most common is XLR and autosomal में most common is going to be ADA deficiency. Coming to the next question, which of the following is the characteristic feature of Wiskott-Aldrich syndrome? That is also an immunodeficiency disorder. Wiskott-Aldrich syndrome, which is the characteristic feature? Yes, I can see D answer coming up. Very, very good. So all points about WAS, Wiskott-Aldrich syndrome. So WAS is, yes, okay, it is going to be a presence of what gene? It is the presence of WAS का gene भी WAS जैसा ही है. Wiskott-Aldrich का gene is WAS gene and it is on chromosome X. So this is an X-linked recessive disorder. This is not an autosomal recessive disorder. Okay, WAS मतलब past tense, is was past tense. Past को क्या बोलना है? Past को bye bye बोलना है. तो patient में भी क्या बोलोगे? Bye bye to your past. All your bad GT scores, your bad incorrect questions, सबको क्या बोलते जाना? Bye bye बोलते जाना. तो ठीक है, number Number one, the patient is going to come to you with bleeding. Why does the patient come to you with bleeding? Not because the platelet count has gone up, because the platelet count has gone down, and also the platelet size has gone down. This is the only disease in pathology where they will say there are small sized platelets. Very, very important point for you to note. Second, the patient is of course immunodeficiency disease है, देखो तो infection तो होगा. And next there is going to be eczema, which was the answer over here. So now they will say अच्छा infection हो रहा है, eczema हो रहा है. तो if I want to do a blood test of this patient, what is the immunoglobulin profile of Wiskott-Aldrich syndrome? So think common sense. Infection क्यों हो रहा है? Whenever a bacteria virus comes into my body, which is the first antibody, acute infection में क्या rise होना चाहिए? IgM. This तो we know ना, IgM पहले increase होता है, later on IgG increase होता है ना. तो starting में मैम IgM should increase. That is what is missing in these people. These people have a decrease in IgM. Okay, next these patients have eczema, and if you go back to dermatology, what is increased in eczema patients? IgE can be increased, IgA can be increased. So please remember, when they say there is high serum IgM, nahi, IgM ज़्यादा होता तो कभी infection होता ही नहीं ना, in most cases. So there is going to be a decrease in, someone said you got it wrong in NEET PG, never mind, now you will not get this wrong in INI. But this is a question that comes in every exam, INI, FMG, NEET PG, सब में आया. It's a repeat question है ये. So coming back, IgM is low, IgA and E are elevated. Very good. Wiskott-Aldrich syndrome done. Now we move on to the next question. All immunodeficiencies. BAF genetic defect associated with germinal center hyperplasia leading to hyperplasia of all lymphoid tissues. Peyer's patches का भी hyperplasia हो गया. Tonsils का भी hyperplasia हो गया. That is seen in which disease? Even if I start ruling out now, so you will say, ma'am, skid तो होगा नहीं. हाँ ठीक है. So Brutons. Okay, are you guys saying पक्का guys? सोचो दोबारा सोचो, सब कुछ पढ़ लो. Read everything. It is a case of common variable immunodeficiency, and everyone thinks, because Bruton is a more catchy name, everyone tries to go for Bruton. So what I'll do, exactly my next slide, I was anticipating this. So I have got you the difference between Brutons versus CVID over here. So firstly, the name of the entire disease is, Bruton is the name of the scientist. The name of the entire disease is Bruton's hypogammaglobulinemia. And everything is going to help you actually decode its name. And what is the full form of CVID? CVID is going to be common variable immunodeficiency. Common variable immunodeficiency. तो अब ध्यान से सुनो. For 30 seconds, forget everything and just talk about basic lymph node in your body. First, you will say there is something called an immature B cell. Ma'am, sabse pehle to there is going to be an immature B cell in my body, baby B cell. After few days, that immature B cell will become mature B cell. Anyone knows how does this happen? Normal socho, abhi disease nahi socho. Which gene causes this conversion? It is the BTK gene which causes this conversion. Okay, and ye mature ban gaya. Mature B cell goes and sits where in the lymph node? Mature B cell always goes and sits in the center. That is going to be the germinal center. ठीक है. After this, the mature B cell decides, अब थोड़ा और super speciality कर लेते हैं. Super speciality is what? That let me become plasma cell so that I can then make antibodies and IgG and everything. And who helps in the formation of this? It is going to be the BAF gene. तो पहले तो ये देखो, there is a baby B cell, it becomes adult B cell by BTK gene. That adult B cell says I want to become elderly, super specialization करना है, plasma cell बनना है. That is going to be by BAF gene. Now just split out each. If BTK gene is not there, B for BTK is nothing but Bruton tyrosine kinase, which is the disease that the patient is going to have. Bruton's hypogammaglobulinemia hoga. And if BAF gene stops working, patient is going to have CVID. Ab iske look at the consequences. You tell me, if BTK gene is not working, will the mature B cells form? Yes or no? Common sense, no ma'am. If BTK gene is not working, mature B cells will not form. Will anyone be sitting in the germinal center? कोई नहीं बैठा होगा. तो क्या germinal center will be hyperplastic or will they become hypoplastic? Ma'am, when no one is sitting in the germinal center will not be seen only, it will be hypoplastic. So can I say in Bruton's hypogammaglobulinemia, number one, the gene defect is going to be the BTK gene defect, and the next thing is going to be hypoplastic germinal centers. Now go back to your question. Why did all of you write Bruton's in the previous question? Was it a BTK gene defect? No. Was there germinal center hypoplasia? No. जब कुछ भी fit नहीं हो रहा था, why did you all settle for Bruton's? It is a case of CVID. Now let me tell you what is CVID. What is the full form of CVID? Common variable immunodeficiency. Firstly, कॉमन का क्या मतलब होता है मैम? कॉमन ऑलवेज मीन्स बी सेल्स ऑल्सो, टी सेल्स ऑल्सो. तो यस, इट इज अ प्रॉब्लम इन बी सेल्स. नाउ लिसन टू मी केयरफुली, वेरी केयरफुली. बेबी बी सेल बीटी के नॉर्मल था, मेच्योर बी सेल बन गया, जर्मिनल सेंटर में बैठा है. What if the BAF gene is not there? Now tell me, the mature B cell has formed, it is sitting in the germinal center, but then it is stuck over there. Germinal center is there, it is stuck over there. Can it do super specialization? It cannot. That is a case of CVID. It is going to be a BAF gene defect. So now tell me, here are the germinal centers going to be hyperplastic or hypoplastic? Obviously, there is going to be germinal center hyperplasia, because there are so many B cells which are sitting in the germinal center. They can't do super specialization. This I have understood. But ma'am, why did you call it common? Common because this is just one defect. B cell का problem जो आप पढ़ रहे हो ना is only one defect in CVID. It is also a problem in the T cell. T cell का problem is because of ICOS gene defect. Okay, ICOS gene defect. Khushi, I'm coming to the symptoms. This is going to result in ICOS gene defect. So now tell me differences. Bruton's is a problem only in which cells? Bruton's is a problem only in the B for Bruton's, B cells. CVID, common variable immunodeficiency, is a problem in the B cells as well as the T cells. Is that okay with everyone? Bruton is only going to be a problem in the B cells. CVID is going to be a problem in the B cells as well as the T cells. Bruton's में कुछ भी नहीं बनेगा, hypoplastic germinal center. CVID में there is going to be hyperplastic germinal centers. Now talking about what Khushi asked me, ma'am, clinically तो बात तो वही हुई ना. You stop it over here or you stop it over here, the ultimate result is that in both cases the antibodies will not form. You are right, Khushi, you are right. In both cases the antibody will not form. But then what is important for me to know is that Bruton's is going to occur more commonly in boys, first point, and CVID is going to occur equally in boys and men and women. In boys and girls it is going to occur equally. T cell में क्या defect होगा? ये T cell maturation नहीं होगा, Khushi. So now obviously when I look from severity point of view, it is common sense that CVID is going to be more severe, because it is not even having B cells, it is not even having T cells. So this is going to be more severe when it comes to symptomatology. But मोटा मोटा देखो, end result is that दोनों में plasma cell नहीं बनेगा and IgG will not form or immunoglobulin will not form. Now come back, BAF gene defect with hyperplasia. What do you want to mark the answer, guys? It is a case of CVID. Everyone who marked Bruton's, and now I hope you will not make this error in the exam. I have taught you, I think, 4 immunodeficiencies. The first that I taught you was SCID. The second that I taught you was Wiskott-Aldrich. The third and the fourth I have taught you are Bruton's and CVID. Other ones I have just got you from point of view कि जल्दी जल्दी मुझे बता दो, rather than questions. Start doing fill in the blanks. Quickly tell me, what is Bair lymphocyte syndrome, ma'am? Lymphocyte, which is Bair. Actually, it is like that only. Lymphocyte which has become bare. What normally every lymphocyte is going to have something called MHC2. When I say MHC2 गायब हो गया, when I say MHC2 has gone missing, the lymphocyte has become naked, it has become bare. So bare lymphocyte syndrome is known as MHC2 absence. Khatam. This was your INI-CET question. The next immunodeficiency is Digeorge syndrome, which I kept as fill in the blanks because I thought you guys will only tell me you are better at it in pediatrics. Catch-22 mnemonic सबको आता है. Catch-22 is what? It is deletion chromosome 22q11. So if they will always write deletion 22q11, deletion 11q22, तो 22 will tell you 22 पहले. It is deletion 22q11. अच्छा, 22 नहीं बना तो which are the 2 glands that will not form? Thymus will not form And excellent. Parathyroid will not form. So अब now tell me, if thymus will not form and parathyroid will not form, तो क्या नहीं बनेगा मैम? पैराथायरॉयड हार्मोन नहीं बनेगा. पैराथायरॉयड हार्मोन नहीं बनेगा तो there is going to be hypocalcemia. Obviously, if parathyroid hormone goes down, calcium goes down, पता है. Next, thymus नहीं बनेगा. तो अगर thymus नहीं बनेगा तो T for T, the T cell defect will happen. So now tell me, if I ask you overall, severe combined immunodeficiency was a B cell problem, T cell problem, or both? You will say severe combined immunodeficiency was both combined. If I ask you common variable immunodeficiency, you will say that also had the word common, ma'am. That was also B cell and T cell both. If I ask you Bruton's hypogammaglobulinemia, you will say B for Bruton's, B for B cells. उसमें सिर्फ B cells का problem था. And if I ask you Di-George syndrome, it is only and only a thymus का, मतलब it is only T cell problem. B cell बढ़िया over here. B cell is going to be all good. So SCID is both, CVID is both, Bruton's is only B cell problem, Di-George is only thymus and T cell problem. What else these patients are going to have? They say A for abnormal facies. Abnormal facies क्यों होगा? Because these patients have cleft lip and cleft palate. Acha, which is that trisomy that has cleft lip and cleft palate? It is P for palate, P for polydactyly, P for Petau. Petau syndrome, trisomy 13 also has. So I'm giving you some buzzwords that okay, cleft lip, cleft palate hoga, so you have to think of one is Di-George syndrome. Cleft lip, cleft palate hoga, you also have to think of Petau syndrome. Very good. Apart from that, the last one of course is cardiac. There are a lot of cardiac abnormalities. Examiner का जो favorite जो वो आपको देता है, that is going to be tetralogy of Fallot. That is segment. Done. So Di-George syndrome is also done for you. Abhi do last. What is hyper IgM syndrome and hyper IgE syndrome? Then all your immunodeficiencies are over. Can you tell me what is hyper IgM syndrome? Acha, before that, sorry. Yeah, Dr. Ripunjoy is saying, dear ma'am, this is also known as velocardiofacial. Yes, because very simple. Velo का क्या मतलब होता है? Velo मतलब palate. Okay, the palate is a problem. Velocardial, cardial I can see. Yes, there is a cardial problem that we have seen over here. And facial, because of course this is a facial problem that I am seeing. So this is also known as velocardiofacial disease. One more INI-CET question now that you have given me that trigger, so I will ask you one more thing. जब ये deletion 22QX हुआ, what is the gene that actually got deleted? It is a defect in which gene? It is the TBX1 gene that got deleted. Actually, this has not been asked in INI-CET, but I think it can. That catch 22 तो सबको आता है, 22 chromosome deleted, but TBX1 gene is actually deleted. And now when you correlate it with psychiatry, ये disease भूल जाओ, but tell me in psychiatry, if someone has TBX gene mutation, it can be associated with schizophrenia. So you can just add it. I'm not saying Di-George people have schizophrenia. No, I'm saying TBX gene mutation can also cause which other disease? It can cause schizophrenia. Very good. All of you know that. Coming back. Meanwhile, talking about the next, hyper IgM. इसमें देखो IgM is more. Why is IgM more? There is a problem in a CD marker. Either CD40 receptor is a defect or CD40 ligand is a defect. Basically, there is a problem in CD40, and these patients are at a risk of obviously all infections, but very commonly they are at a risk of pneumocystis jirovecii infection. Pneumocystis jirovecii bolo ya pneumocystis carinii bolo, kuch bhi chalega. I will teach you pneumocystis carinii when it's a fungus. I will teach you this when we go to microbiology after this class. नेक्स्ट क्लास. एंड उसके अंदर एक और क्वेश्चन आता है, न्यूमोसिस्टिस जेरोवेशाई दो कंडीशंस में होगा, या तो हाइपर आईजीएम सिंड्रोम दिया होगा, या फिर इट विल बी एन HIV पॉजिटिव पेशेंट विद द CD4 काउंट लेस देन, who will tell me this? HIV positive patient with a CD4 count less than 200. Other than these two stories, there is no question of pneumocystis jirovecii possible for you guys. Remember, either it's going to be a hyper IgM CD40 problem, or it is going to be an HIV positive patient with a CD4 count less than 200. Coming to the next, hyper IgE syndrome. Hyper IgE syndrome is also known as the job syndrome. And right now, all of you might not have a job, so you're very desperate to get a job. But the day you get a job, you will be very desperate to leave it. And you will say, ma'am, the job is, you'll be calling me that day and saying, ma'am, we missed that padhai wala time where we used to sit in front of the screen and only study. There was no point, no one telling us to work for 36 hours and so on and so forth. So you will say, oh, ma'am, I want to leave my job, stat. Why do you, these are the kind of expressions that you will be giving me. Yeah, so what is the leaving the job stat? It is a STAT3 gene defect that is seen and you want to leave the job. So remember, it is hyper IgE syndrome, leaving the job stat, so STAT3 gene defect. Okay. Okay. Now for those who are having job and पढ़ाई दोनों साथ साथ, may God be with you. All of us have been through that time. We know it's a time where you don't understand. कुछ समझ ही नहीं आता when your day starts, when your day ends. On one side you are doing your work and then on the other side you have your phone open and you are trying to fake it that you are studying also. But then it happens. It's happened with all of us. चल जाता है. Trust me, from right now you might feel very messed up, but the actual reality and the outcome of it is that you will not even realize that how there will be some structure that you will make out of that mess and you will sail through it. All of us have, and with that confidence I can tell you that you will also sail through that mess. Coming to the next, what happens in the teeth? Very good. The primary teeth are retained. And secondly, these kids are going to have cold abscesses. These are the two questions that you get. Cold abscesses and primary retained teeth. E, hyper IgE, leaving the job stat, so STAT3 gene defect. All of you have finished your immunodeficiency disorders. I hope that is okay. So maybe you can answer one last question and I can move forward. There is a male patient who presented with an eczematous rash over the body along with bleeding episode. Patient also gives history of repeatedly getting infected. On peripheral smear examination, there is small sized platelets. I can see a bye-bye happening over here. I can see a patient who's having bleeding episodes, patient having infections and patient having eczema. And the only disease to have small sized platelets was a case of Wiskott-Aldrich syndrome. Excellent. Let's see if you can attempt the next question also. Which of the following is not used for detecting abnormal gene sequences? Which of the following is ये वाले questions? Please ध्यान से पढ़ना exam में. Not, true, false, except, multiple choice. Please don't mess up here. Not used. Obviously, right now you told me, ma'am, ये सारे PCR तो you had taught us, they are for gene sequencing. What is not used is going to be flow cytometry. Flow cytometry is actually used for figuring out the CD markers. When you say T cells have CD1, CD2, B cells have CD19, CD20, तो ये CD markers पता कैसे लगे? What test do I do in the path lab? I do a flow cytometry. That tells me, before that, what is reverse transcriptase PCR for? It was for coronavirus. What was pyrosequencing PCR for? It was for contaminated sample. And what is nested PCR for? Nested is going to be, remember, love nest birds. So it is going to be having 2 primers. So this is what we are settling over here. But now what we have is going to be flow cytometry nahi kiya jata. Flow cytometry is for CD markers. And now this is what a flow cytometer machine looks like. So now for the next, let's keep a target of say 15 minutes or 20 minutes. Because इसमें बहुत कुछ करना है. We have to do everything about flow cytometry. We have to do that one mega jumbo table of all the CD markers. And with the CD markers, we will also finish off all the genetics and origins of the lymphomas. So the next 20 minutes are damn toxic, but they are very, very, very important. So even if you had fallen asleep, please वापस जाग जाओ, because this is where the real deal lies. So now we are going to have an order. We will do all of hemat. Flow cytometry के साथ ये सब खत्म करेंगे. Then we have 2 more techniques coming our way, that is platelet aggregometry and TEG, and we will wrap it up with vacutainus. So now you know your countdown, reverse countdown has begun of how the next, let's say 45 minutes or max 1 hour, and then that is when we'll wrap it. Are you ready for the next 45 minutes? Because CD markers क्या होते हैं अभी बस वही पढ़ेंगे. Before that, let us talk about ये machine क्या है. This machine is a flow cytometer. I've got you all questions one bullet after the other. So when I talk about a flow cytometer, the first thing I can see, I have placed some sample over it. I have put some sample. Now what sample do I put on it? I put a sample that could be anything fluid. Anything fluid means it could be a blood sample, it could be a CSF sample, it could be a urine sample, it could be FNAC sample, ma'am pleural fluid, ascitic fluid, चलेगा. कुछ भी fluid होना चाहिए वो चलेगा. Fluid will have cells, right? Can it be a bone marrow sample, bone marrow aspirate? बिल्कुल हो सकता है. Fluid है तो I can put it in a flow cytometry machine. Okay, so now you put, say for example, you put 5 ml of your blood. Your blood will have thousands and lakhs of cells. But why is it, ma'am, that the blood is falling like this? वन सेल क्यों ऐसे आ रहा है? वो एकदम से 1 million cells एक साथ क्यों नहीं ग्रेविटी से नीचे गिर रहे? आई पुट द फुल सोल्यूशन. व्हाई इजंट इट फॉलिंग धड़म लाइक दैट नीचे? व्हाई इज इट गोइंग one cell at a time? Because please note that there is a concept known as hydrodynamic focusing. Now, hydrodynamic focusing tells me that when you had put this sample, whatever sample you had put, apart from the sample, you also added something called sheath fluid. And this sheath fluid will make sure that there is hydrodynamic focusing. Hydrodynamic focusing is a very big word for the fact that every cell is going to fall one cell at a time. Is that okay with everyone? Now you will tell me that, okay, what all have you added, ma'am? You've added the blood sample, you have added one sheath fluid that will make sure कि वो 1 1 1 1 करके drop करे. And after that, how are these colors coming? Red, blue, green, yellow, ये सब क्यों आ रहा है? Because you have added some dyes. Do you have to learn all the dyes? No, you only have to learn the green color dye. This green color dye is what? This is FITC. What is the full form of FITC? It is fluoroisothiocyanate. Fluoroisothiocyanate, that is the, and even if you learn the word fluoro, you will know that it is going to be something greenish, fluorescent green. Now coming back, so I'm going to just erase a little bit of this and teach you once again that you have put the sample. Did you notice as the blood is falling down, you have put a blue color light from here? There is a blue color light and they ask you what is the wavelength. It is 488 nanometer wavelength. I can see one blue color light coming from here, and this is my cell. Let's take one cell. For example, if this is the light that is coming like this, and this hand of mine is the cell, or this fist of mine is the cell, इस पे एक blue color का ऐसे light आया. As soon as the light hits this cell, some light will travel forward like this, and some light will get scattered towards you. So there is light going forward, forward scatter बोल देंगे उसको, the light which goes forward. The light which goes on the side, that is known as the side scatter. So see, the light which has gone forward, that is known as forward scatter. Then I can see the light has gone towards the side, and that is side scatter. Let's take it once again. This was a cell. I can see the light has gone forward. This was a slightly bigger cell. The light has further gone forward. This was an even bigger cell. Light has further gone forward. So can I say forward scatter is directly proportional to size of the cell? If the cell was chota, the scatter is chota. If the cell is big, the scatter is going to be big. So forward scatter correlates with size of the cell. Versus look at this. When the light went, suddenly now the light has gone in all directions. What is this known as? This is known as side scatter. Why? Because inside there is a lot of complexity. Every granule is scattering it here and there. So can I say that side scatter is directly proportional to the complexity or the granularity of the cell? Very good. Any complexity or granularity is going to be the reason for side scatter. These are all your previous year questions. So please revise the previous year questions with me once. When I say flow cytometry, why do cells fall one at a time? Because of something known as hydrodynamic focusing. What is the light, laser light used? It's a blue color light which has a wavelength of 488 nanometers. What is the forward scatter indicative of? Directly proportional to size of the cell. Side scatter is directly proportional to the complexity or the granularity of the cell. All this happened inside a machine. All this I let it happen. I had to ultimately as a pathologist read the report, and these are the two reports that I get, and this was also an INI-CET question, that flow cytometry can have two report patterns which are shown in front of you. Either on the machine, ये computer screen पे होगा. On the computer screen, every cell will be displayed like a dot. One dot equals one cell. So one type of analysis is the dot plot analysis. Or every cell will come to you like a peak over here, and this is known as the histogram. So what are the two graphs that I can get on the computer screen? Either as dots, so I call them dot plot analysis, or they can come as peaks, so that is referred to as the histogram. Now what you have to know in the exam is, no one will tell you to read histograms, they will tell you to read dot plot analysis. Before I go to dot plot analysis, you will have to first revise with me an entire table of CD markers, so that I can then build up on this and teach you the dot plot analysis. So this is a fill in the blanks for all of you. Before that, Khushi had asked us that, ma'am, what are CD markers? So whenever I talk about a cell in general, CD ka full form, although it won't be asked you, CD stands for cluster of differentiation. It is a marker. Like for example, if I want to identify you, then I identify you by your name, that is Khushi, and everyone else will also identify you like that. So that is your ID card. Similarly, every cell also has an ID card, and that is going to be CD. Like CD1 will tell me that, okay, it is a T cell lineage. CD3 will tell me T cell lineage. CD19 will tell me, oh, it's a B cell lineage. So every cell has been given, there are multiple CD markers that it can have. So let me start, not just CD markers, but a lot of other markers also that I'm going to tell you. Okay, so first you have to know about blasts. Whenever they write three things, HLA-DR, TDT and CD34, they are talking about blasts. Please everyone learn this with me. HLA-DR, CD34 and TDT, these are referred to as blasts. Okay, whenever they write LCA, leukocyte common antigen, that is the other name for CD45. And now you know leukocyte common word tells me that this is going to be a part of every WBC or every leukocyte. Coming to the next, can you all, this is fill in the blanks out, want answers coming from your end, very good. What are the T cell CD markers? Anything between CD1 to 8 and 28. So it's like a song and a rhyme that I've learned. T cells are CD1 to 8 and 28. Let's move forward. Out of them, if you are asked which is the hero of the story, the pan T cell marker out of all of these is going to be CD3. That's the pan T cell, means every stage of T cell is going to have CD3. Now let's talk about B cell markers. B cell markers are going to go in double, 10, 20, 40, doubling karna hai. So first I start with 10. 10 is also referred to as Cala. 10 ka double is 20. So I go by 19, 20, 21, 22, 23, the entire 20s range, and 20 ka double is 40. So these are the three things you have to know, 10 and then 20s range and then 40s range. But in this, if they ask you who is the hero, who is the pan B cell marker, that is going to be CD19. Why am I making you learn that pan T, pan B? Because heroes are important to diagnose cancers, which I will tell you. Now coming to natural killer cells. Natural killer cells, we call them as the Bahubali cells, and now, or basically natural killer, they are the wrestlers, the bodybuilders. So now just think of all the statistics that a bodybuilder has. When it comes to biceps, the most famous 16-inch bicep. When it comes to chest, it's a very famous meme, that is 56 inch. And then of course the latest INI-CET question, such a person, his weight will also 16-inch bicep, 56-inch chest, his muscle mass will be so much that his weight will also be 94. So 16, 56 and 94 is our Bahubali natural killer cell. Now we come to myeloid cells. Myeloid ke liye MPO, myeloperoxidase, common sense na, myeloperoxidase, myeloid cells. Apart from that, it is going to be CD133. CD13 and 33 are for myeloid cells. But in this, if they ask you which is the most important, यहाँ का hero कौन है myeloid lineage का, myeloid lineage का hero is going to be MPO. Okay, now coming to monocytic or monocyte, monoblast, all these monocyte lineage. Mono means one, forever single. So forever single will mean 1, 1, 11, right? Forever single, 1, 1. And when is a single person the most unhappy is going to be on 14th of February, Valentine's Day. So CD14 is also for single. And then unfortunately single till he dies. So that is a very bad thing, but yes, it can also be CD64. So it is going to be 1, 1 for single, 14th Feb ko be single till he dies, that is 64, and all our sympathy with monocyte on that. Now coming to megakaryocytic. Mega sounds only dangerous. Mega, it's a precursor of platelet, so we are talking about the platelet lineage now. Now over here, mega, I have to think of how many PUBG fans in the house. So in PUBG there's a very famous and a deadly gun that is known as the M416 gun. वो एक mega gun होता है which is used for killing. In case you've ever played PUBG, and if I have, then I'm assuming that you've heard of it or played at least. Okay, so coming back, just read this gun. 4161, that is the deadly gun that you have to know. So mega gun, it is going to be 4, 1 and 6, 1. It can also be 42 in between if you can learn. If you can't, chalega. 41, 61 is also good enough. Okay, coming back now, all these are settled. In these, what will they ask you? And all the others I'm not going into right now. I'll go to that after a while. Out of these, I realized there are 3 heroes that you've learnt, ma'am. First, you said whenever you go in the exam, ye dhundo, are there blasts present? This is the first thing that you have to go and search. I'll tell you why. So for blasts, what is it? Repeat with me: HLA-DR, TDT and CD34. Your next step will be which blast? If it is a myeloblast, then which is the hero that you will be searching for? Obviously, you will have MPO CD1333, but the hero will be myeloperoxidase. Myeloperoxidase hoga, you will say, oh ma'am, then it is a myeloblast. If they say CD3, then you will say, oh, it is a T lymphoblast. If they say CD19, you will say, oh, it is a B lymphoblast. So let me make you solve such questions. Question number 1, if they say that this is the patient profile, CD34 positive, HLA-DR positive, 13, 33 and MPO positive. So you say, ma'am, you had told us 34 HLA-DR TDT, ये तो होते हैं blast. So this is a leukemia, blasts are there. And 1333 MPO, these are which kind of lineage? This is the myeloid lineage, and the hero should always be there. Bina hero ke nahi banana. If only 1333 would have been there, I would have been doubtful. When hero has come, I'm very certain that acha, this is a case of myeloblast. Myeloblast means what? It is a case of AML. Let's practice more questions. Next question number 2 says that there is CD34, 19 and 10 positive. CD34 positive tells me अच्छा blast तो है. Blast का क्या क्या था? It was TDT, HLA-DR and CD34. Blast है. Okay, CD19 and CD10 are the B cell lineage. Remember 10, then 20s, then 40s, and the hero of that was CD19, pan B cell marker. So this is a B lymphoblast. This is a B lymphoblast means, can I say this is a case of BALL? This is a case of BALL. Okay. What am I trying to tell you? Search for the hero. Who is the hero of myeloid lineage? Myeloperoxidase. Who is the hero of B cells? CD19. Similarly, who was the hero of T cells? It was CD3. अगर यहाँ पे blast के साथ CD3 होता, I would have called it T lymphoblast. I would have called it TALL. Who will solve the next one for me? CD34, HLA-DR and TDT. What is this? This is going to be blast. This I know. CD19 tells me, ma'am, ये B lymphoblast होगा. And myeloperoxidase tells me that this is myeloblast. How is it possible that there is lymphoblast also? There is myeloblast also. Yes, there can be mixed leukemias as well. There can be certain biphenotypic and mixed leukemias that you have. Very rare to get, but yes, you will have an option of a mixed leukemia. So go exactly. That is why I am telling you, search for the heroes. So can you all repeat the 3 heroes for me? If you are talking about myeloblast, which hero do you search for? You have to search for myeloperoxidase. For B, you have to search for CD19, and for T, you have to search for CD3. And agar mixture hai, then you call it as a mixed leukemia. You are going to call it as a biphenotypic leukemia. Is that okay with everyone? It can be mixed. Coming back, our story is not done. What about these other things? Now I'm going on to, have you all heard of a leukemia called, have you all heard of an anemia called paroxysmal nocturnal hemoglobinuria? PNH, paroxysmal nocturnal hemoglobinuria, is the absence of which CD markers? CD55 and CD59 are going to be absent. That is PNH. So CD markers again. Okay. Have you all heard of normal plasma cells? Of course. Normal plasma cells versus cancer of the plasma cell is referred to as multiple myeloma. What is their CD marker profile like? So tell me, whether I say plasma cell or any other white blood cell, every white blood cell has CD45 positive. Okay, so I will write CD45 is going to be positive. Plasma cells, right now all of you told me, come from what? Do they come from B cells or T cells? They are the super specialization of B cells. What was the pan B cell marker? Pan B cell marker was CD19. So plasma cell kahan se aaya hai? First, I am going back to the family history of plasma cell. Plasma cell is a white blood cell. That is why it is CD45 positive. Plasma cell comes from B cell. That is why it is CD19 positive. But khud kya hai? What is its own identity? Own identity is that it is CD38 and 138 positive. It is CD38 and 138 positive that we have. Is that okay with everyone? Normal plasma cell. This is the good boy normal plasma cell. Now this good boy, good girl becomes a bad boy, bad girl. That is going to be cancer wala plasma cell. That is multiple myeloma. When I say a good child versus a bad child, a good child will be the one who will take care of his parents also, where he comes from, and he or she will take care of himself also. So a good child will take care of everyone in the family. But a bad child is cancer. Will a bad child think of anyone in the family? No, bad child will say to hell with parents. Will forget his parents. CD45 negative, CD19 negative, will only think about himself. 38 positive, 138 positive. That is how you learn that if a normal plasma cell, good child, parents को भी याद रखो, खुद को भी याद रखो. Cancer वाला plasma cell, bad child, forgotten the parents, 45, 19 are negative. Yes, they lose its CD marker. They stop showing that CD marker, Kushi. They stop showing that expression. So normal plasma cell on the machine will be positive for all 4 of these, whereas cancerous plasma cells or multiple myeloma cells will only be positive for 38 and 138. They will stop showing the expression of 45 and 19. Now coming back to the 3 leukemia lymphomas, and then you are ready to, after this, then my work is done. Then you solve 5-6 questions after that. Tell me, there are 3 lymphomas: CLL, SLL, the small lymphoma, mantle cell lymphoma, and marginal zone lymphoma. This is when I'm talking about lymphomas in the lymph node. By chance, they want to tell you about a lymphoma in the stomach. Marginal zone lymphoma in the stomach is known as maltoma, and I hope you remember the only bacteria that can cause this maltoma. Stomach में तो एक ही bacteria होता है ना, that is going to be H. pylori. That only causes all the cancers of the stomach, whether it is adenocarcinoma stomach or it is maltoma of the stomach. So remember, when they talk about lymphoma, they will write marginal zone lymphoma in a lymph node, say some lymph node of the body. But when they want to signify it in the stomach or the intestine, they will now call it maltoma. So can I say marginal zone lymphoma and maltoma is the same thing? अब इन तीनों में the question that they ask you, there are 3 CD markers that you have to know: CD5, CD23 and CD200, and this is one of their favorite questions nowadays. Please note, CLL और SLL सब कुछ positive. CLL, SLL सब कुछ positive. Margin को ignore करो, everything is ignore, everything is going to be negative. So सब कुछ positive is CLL, SLL. Margin को ignore करो, that is going to be everything negative. And mantle cell is only CD5 positive. Mantle cell is only CD5. याद हो गया, CLL, SLL सब कुछ positive, margin ignore it, everything is negative, and mantle cell is only CD5 positive. So now all of you are going to tell me something, that out of these 3, which of them is cyclin D1 positive? Cyclin D1 positive is the new marker. Please remember, I'm writing it chota over here. When I talk about mantle cell lymphoma, it has 2 new markers that they ask you in the exam. One is cyclin D1 and one more, SOX11. ये इसके 2 new markers हैं which they ask you, cyclin D1 and SOX11. Very important. So now your list is done. We will repeat it. If I just ask you, everything is positive: 5, 23, 200, CLL, SLL. Everything negative, ignore the margin, marginal zone lymphoma. Only 5 is positive, mantle cell lymphoma. But if you want to confirm mantle cell, you will be doing cyclin D1 and SOX11 also. ये तो रटने वाला था. Application begins now. How do I learn to read this chart, ma'am, with all these CD markers? Ratta is okay, but application is more important in the exam. So now what you'll do, as soon as you'll go in the exam, you will see 4 quadrants like this will be drawn. This will be made by the examiner. There will be one marker written over here, that is M1 on the y-axis, one marker written over here, M2 on the x-axis. So let's assume CD3 is written over here and CD33 is written over here. So any CD markers will be written. So put your common sense, जैसे स्कूल में पढ़ते थे, ग्राफ बनाओ यहाँ पर and tell me this quadrant. Just look at the value on the x-axis and the y-axis, very low. This is known as double negative quadrant. Double negative means M1 is also negative, M2 is also negative. खुद देखो ना, if a cell is over here, ma'am, it's very close to 0 on the x-axis also. It's very close to 0 on the y-axis also, means both the markers are going to be negative. Now look at this quadrant. This is the double positive quadrant, means both the markers are positive in these cells. यहाँ पर जो cells होंगे, they will be positives. Look na, M1, it is so high on the y-axis. Then M2, it is so high on the x-axis. So this is double positive quadrant. Then what about the cells here? Over here, can you tell me? I can see x-axis तो बहुत ज़्यादा है. It is closer to x-axis, so M2 expression is more. But if I trace it, this on the y-axis is very less. M1 is going to be negative. And if I look at cells over here, the M1 expression is more, but the M2 expression is coming very, very less. So M2 is going to be negative. How I have learnt, exam में इतना graph करने का तो time ही नहीं होता ना. We have to solve questions in 40 seconds. This is the double negative quadrant. This is the double positive quadrant. This one is closer to x-axis, so it is going to be M2 positive. This one is closer to y-axis, so that is going to be M1 positive. Try solving some questions so that you know that you got what you were trying to read since such a long time. As soon as you go in the exam, read the markers. यहाँ लिखा है CD10, I'll write it highlight karke so that you can see. And over here it is written TDT. Can you tell me TDT was a marker of what? TDT was a marker of blast. Just think of that first. And 10, 20, 40 was a marker of B cells. Then they have put an arrow in which quadrant, guys? Which quadrant is this? Ma'am, this was the double positive quadrant. All the cells are in the double positive quadrant. They are positive for TDT, matlab it is going to be a blast, and it is going to be a B lymphoblast, means this is a case of BALL. Very good. Okay, don't be overconfident. Solve more questions and analyze. I have CD59 written over here and I have CD55 written over here. Look, majority kahan par hai? Where is the majority cell cluster? Majority cell cluster is in the double negative quadrant, means CD55 negative, CD59 negative. That is a case of paroxysmal nocturnal hemoglobinuria. Very, very good. Now let's solve something which is tough. Let's see. And I think I think you guys might not be able to read the markers, so this I will do for you. 5, 23, 20 and 10 and 5 and 200. Obviously in the exam it will be written better. Ab mujhe bata do, what do you think is the overall? Analyze one by one. You can see the cells. Look at this first one. All the cells are in the double positive quadrant, DP quadrant. So this means CD5 is also positive, CD23 is also positive. If I look at the last graph, that is also in the double positive quadrant. Ma'am, 5 is positive, ye to mujhe pata hi hai. 200 is also positive. When sab kuch comes positive, what is that a case of? That is a case of CLL. Imagine if everything would have been negative. Everything would have come here in the double negative quadrant. When everything would have been negative, you would have made it into marginal zone lymphoma. Why didn't I read the second graph? Because there is no proper classification. Half the cells are on this quadrant, half are in this quadrant. I don't read that population. I will only read where I can see majority. Majority pe focus karna, don't focus on those overlapping zones in between. Are we okay with this? Can we move on to this question also? Please let me know. You have to analyze for everyone. This is 38 written over here, 138 written over here, 19 written over here and 38 written over here. Yeah, these are the CD markers. You can let me know your answer. What is this? Again, what you have to do, ma'am, majority kahan hai? Majority double positive quadrant mein dikh raha hai. Matlab CD38 is positive, 138 is positive. Ye to plasma cell wala story hai. Now I just have to know, is it a good child or a bad child? Uska apne parents ko yaad rakha ya nahi rakha? So I looked at the next graph. The next graph, CD19 and CD38, this is where it's there. Means ye closer to y-axis. 38 is positive, I know. CD19 is not positive. CD19 is negative. Oh, he's a bad child. He's forgotten his parents. If he has forgotten his parents, is it a normal wala, reactive wala plasma cell, or is it a cancer? No. Yes, many of you have given me answer as multiple myeloma, but multiple myeloma to yahan pe likha hi nahi hai. The options are, is it ALL? No. Are they B cells? No. Are they reactive plasma cells, means normal plasma cells which you see in fungal infection and some other infection, or are they cancerous wala plasma cells? They are cancerous, multiple myeloma. So the correct answer over here is option C. Excellent, excellent guys, very, very good. So now that you've done so many leukemias, lymphomas, why don't you also tell me the answer to this? Which of the following lymphoma does not take origin from the area marked, and the area marked over here is this? Which of the following lymphoma does not take origin from the area marked in this picture? This is a very famous INI-CET question that they ask you. So quick answer to that, and A, B, C, D. Some of you are saying A. Okay, not really. Now I've got marginal zone lymphoma. That seems to be a correct answer. So, ye kya hai, ma'am? We never understand a lymph node. Today you will understand lymph node. This is a screenshot from your rapid revision again, and we need to settle this once and for all. Okay, so this is what a lymph node looks like. Forget lymphomas for 1 minute and look at a normal lymph node and a normal lymphocyte. This is your normal lymphocyte, which is going to be a naive B cell. A naive B cell means he has never been exposed to any antigen. He has never entered the lymph node. He is that fresher bacha who's now going to enter into MBBS. That is a naive B cell. And this lymph node over here is that entire MBBS in front of him. So first when he goes, tell me, your first month of MBBS is what? Orientation, when you feel that life is so nice, chill, happy, and MBBS is going to be a cakewalk. Your first month is the best part of MBBS, where you don't even have to study. So that is exactly known as what? That is known as the Mantle zone. Yes, you're right, Khushi. It travels from the bone marrow to the lymph node. So can I say this is the mantle zone? And in your orientation, do you face any challenges? No, you feel life is the best. So can I say these are the unchallenged cells? Okay, these are the unchallenged cells. Okay, ragging time. We can't say that, it's not allowed. Okay, so this is referred to as the unchallenged zone because there are no challenges of studies right now, if I can put it correctly. Okay, after that comes the real MBBS. When you enter the center, your first prof, second prof, university exam, so on and so forth, that is referred to as the germinal center. And this in the center, of course, will be referred to as the GC, the germinal center. Okay, after the germinal center, that's your MBBS. Germinal center is where all the antigens and exams are exposed. Now B cell is exposed to all exams. He can handle any adversity in life because उसने अपना MBBS कर लिया. After MBBS, now there are 2-3 options that life has for you. One option is that you are so sick of it that you say, I am done. मुझे अब आगे NEET PG नहीं करना. I don't want to study in life. I am so sick of it. You go and sit in the margin. So after this, one option is that the B cell decides to go and sit in the marginal zone. Okay. Second option is after MBBS, you're like, okay, let me wait for a while. I want a sabbatical. I want to explore other passions of my life. So right now you have completed MBBS, but nothing more. You are a post-germinal center B cell. Okay. Then after that you say, because right now you want to see whether you want to be an author or a painter or a vlogger or a traveler, you are doing on that journey of God, so you're waiting. Other is that you say that नहीं रहना तो मुझे MBBS में ही है, but MBBS में what do I want to do? After that I want to do NEET, or I want to go to a central institute, or I want to go into health administration. So you have something in your memory about MBBS only, but right now you don't know which path of MBBS to choose after that. And the next student who's very sure, all of you who have said कि मैम निकलते ही B cell को हमें NEET PG में convert करना है. We want to become plasma cells and we want to do super specialization and we want to do immunoglobulin formation. This is what a B cell goes. So this is you, first year, naive bachcha, first goes into the ragging phase, or not ragging phase, the orientation as we put it. So that is going to be in our college during our times, by the way, because like I am also saying that this word is prohibited and cannot be used, they used to call it PDP, Personality Development Program. That is what it was called in our times. I don't know what it is called now, but we can't use the word, but this is how they used to say, oh, your first month. And our PDP in our time went on for 7 months. They didn't give us a freshers party for 7 months because they just felt that we needed that personality development program for 7 months. So they were just finding kicks out of it probably. Yeah, sweet introduction. Yeah. So okay, coming back. So this is going to be what? This is the unchallenged PDP time of your life, mantle zone. After that you enter into real MBBS germinal center. After that either you become a post germinal center, or you say that okay, I have it in my memory B cell, or you go and sit in the margin and you're like, I'm done with it, I'm not studying more, marginal zone, or you enter into the rat race of NEET PG and you become a plasma cell. Ab ye kyun padha? Because now every place there is a cancer that is coming up. From the naive B cell you have CLL SLL lymphomas coming up. From mantle zone, common sense, you have mantle cell lymphoma coming up. From marginal zone, common sense, you have marginal zone lymphoma coming up. From germinal center, you have FL, BL, DLBCL, means FL for follicular lymphoma, BL for Burkitt's lymphoma, DLBSCL for diffuse large B cell lymphoma. And before I move forward, the question was, which of the following is not taking origin? It does not take origin from the area marked germinal center. Germinal center से 3 चीजें आती हैं, FL, BL, DLBCL. What does not come is going to be marginal zone lymphoma. So that is settled. Okay, let's move forward. What comes from post germinal center B cell? That is going to be Hodgkin's lymphoma. वेरी गुड. ठीक है. बी सेल मैंटल जोन में स्टोर क्यों होता है खुशी? बिकॉज लाइक फॉर PDP ना, फॉर पर्सनैलिटी डेवलपमेंट स्टोर होता है. इमीडिएटली इफ आई थ्रो यू इनटू MBBS फ्रॉम day 1 and as soon as you enter your medical college I throw you into the dissection hall and I say go and cut a cadaver, you will faint. So I have to keep you in that 1 month of orientation where I gradually introduce. So same way, if I take a B cell and I throw him in that ocean of antigens, the B cell will not know. So I'm kind of prepping up. B cell का PDP कर रहे हैं हम यहाँ पे, that we are gradually introducing him to antigens one by one. That is why mantle zone is required. Coming back, post germinal center B cell से क्या आता है? Hodgkin's lymphoma. What comes from memory B cell is hairy cell leukemia. And what comes from plasma cell is going to be common sense multiple myeloma. So I think after this you should not have a problem with any origin related question. एक जगह आएगा, mantle zone will not be written for mantle cell lymphoma. They will say there is an unchallenged zone in the lymph node which is giving rise to a lymphoma. That is going to be mantle cell lymphoma. Everyone, certain 10-star slide for INI-CET exam, origins of lymphomas. You've seen these and you've messed up a couple of times. I hope now you won't mess it up. Coming back, now what all of you will do, you will tell me all the genetics also. If I ask you, what is the genetics of Burkitt's lymphoma, can you tell me? Or what I'll do, let's take it opposite. I'm going to teach you directly. I'm going to write these 4 numbers in front of you and you tell me the combinations. Burkitt's lymphomas mein kya hai? These are numbers of chromosomes. So Burkitt looks like 8. Translocation of 8 with any even number is going to be Burkitt's lymphoma. So if they write translocation of 8 and 14, translocation of 8 and 22, translocation of 2 and 8, any 8 and even number mentioned over here is going to be Burkitt's lymphoma. If they write translocation 8 and 21, that is not Burkitt's. 8 wala sab kuch is Burkitt's. I think that is easiest. And why? Because 8 chromosome has that c-MYC that you were telling me कि Burkitt में there is c-MYC mutation. Where is c-MYC present? It is present on chromosome 8. And Burkitt shows you what? It shows you the very, very famous starry sky appearance. What is the child that is always given for Burkitt's lymphoma? It is always that African child. Any reason that why it is always going to be in Africa? Because it is always associated with Epstein-Barr virus and EBV is endemic. Africa में सबसे ज़्यादा होता है. This is like your one flashcard for Burkitt's within 10 seconds that I can give you, but chromosome 8 is what they ask you the most. After that, I've got you 3 more chromosomes which are learnt in the form of ages. I think everyone is well aware of it, and yeah. So now tell me, age of 11, just as you enter your childhood is getting over at 12. So 11 is that one margin after which your childhood will be over. 18 is the other margin when you're going to become an adult. And 14 is somewhere in between. So 11 is your childhood, 18 is your adulthood, and 14 is between. Because if I make teenagers 14, 18, if I make teenagers come together, they are going to be best of friends. Best of friends means friendly lymphoma, follicular lymphoma. Why do you call it friendly? Because it's got the best prognosis in the lymphomas. That is one thing. If I bring the margins together, the childhood and the adulthood, translocation 11 and 18, if I bring the margins together, it is going to be marginal zone lymphoma. And what am I left with is this translocation 11 and 14, and that is going to be mantle cell lymphoma. So repeating, if I put the teenagers together, they are friends, that is follicular lymphoma. If I put the margins together, it is marginal zone lymphoma, and jo option bacha, that is going to be mantle cell lymphoma. Are we clear with all of this? And if you are, then you're going to tell me the next question. There is a patient who has cervical lymphadenopathy and a positive translocation 11-14 result. Can you let me know that translocation 11-14 में क्या सोचा? Follicular सोचा नहीं, follicular was friendly, teenage, इसमें teens नहीं है, margin was 11 and 18, तो marginal भी नहीं है. This is mantle cell lymphoma. Ma'am, in mantle cell lymphoma, you had told me that there are 2 new markers that are coming up. Very good. SOX11 and cyclin D1. This is what we had studied. So SOX11 and cyclin D1. These are, ये INI का favorite question है. They love this SOX11 and cyclin D1. And mantle cell का, I don't know, they have some obsession, but they love this lymphoma. So this is something that you all have to know. Are we okay with all lymphomas, CD markers and all done? Can I move forward and go on to the next set? Before I move on, I've just got you one essay random spotter photo because I thought no exam is complete. Random spotter filler to give you a break. What is this? Just out of nowhere I'm asking you. And I think you know it. It's written also. This is the famous Gaucher's disease. This is the famous Gaucher's cell, and this is learnt by, yeah, that crumpled. I don't even want to tell you, but if I don't, then I will feel guilty that I left a session without crumpled tissue paper appearance. But everyone knows about it. Crumpled tissue paper, the cell is looking like as if I've crushed the page and it's got wrinkles, white color. This is Gaucher's cell or Gaucher's disease. The patient usually comes to me with a history of bone pain, राइट। अर्लिन-मेयर फ्लास्क डिफॉर्मिटी भी होता है उसके अंदर बोन में. वी ऑलवेज लर्न इट एज गाउचर्स डिजीज बिकॉज पेशेंट इज गोइंग टू कम, बच्चा विल कम टू मी विद आउच, दैट इज बोन पेन, इज दैट इज द हिस्ट्री, एंड इट इज गोइंग टू बी अ deficiency of which enzyme? It is glucocerebrosidase enzyme. It is going to be glucocerebrosidase enzyme deficiency. Yes, excellent, perfect. So this I just got for the heck of it. I mean, I wanted to complete it, but I think you all know it. And this is a question which has been very consistent in all exam patterns. इसका हैट्रिक भी हो चुका है, हैट्रिक के बाद भी जो होता है वो सब हो चुका है in FMG, NEET, INI, all exams every year it has been coming. So I had to teach you once. Now I'll move on to the next. It's a very simple question, but it is something that you have to know, and I'm sure you do. Can you identify the cells that are marked in the provided image? We will start from the first one. What is this cell? Right? ओके गलती से अगर गलत कर दिया था, दिस दैट गॉशर्स वाला सेल, मतलब वो गलत कराना, दैट इज द ब्लंडर विच इज गोइंग टू हॉन्ट यू forever. So crumpled tissue paper appearance for Gaucher's गलत कर ही नहीं सकते हो. The first one is not a neutrophil. Look around, don't be in a hurry. Look around and see that maybe you are seeing another neutrophil somewhere. Maybe this is a neutrophil, and if I go back and see, maybe this is looking a little orangish, so maybe this is then an eosinophil. Okay, what is this cell if I have mark over here? This is going to be a lymphocyte. What is this bluish cell that I have over here? That is going to be basophil. And what is this cell which I have with the kidney over here? That is going to be monocyte. The good news is that this is the only picture of hemat on Google and in every picture book that has all the 5 cells in one screenshot. You will not find any other photo like this. This means the examiner also won't have, and this means the same picture will come in your exam. So you need to identify all these cells by heart because you can't mess it up. Before I start with this, पहले ये मुझे answer बता दो, then I'll teach you. The identification of which type of cells is toluidine blue staining used? Lymphocyte, fibroblast, macrophage और mast cell. Toluidine blue क्यों use करते हैं? It is used for mast cell. And mast cell का cousin brother कौन होता है? Mast cell का cousin brother is basophils. So remember these two, and now let me teach you. Let me teach you, never let monkeys eat bananas. Why? Because neutrophil, lymphocyte, monocyte, eosinophil and basophil. Never let monkeys eat bananas is learned because this is going from maximum to minimum. If I ask you today, if I take your blood sample, you are a normal, healthy, touchwood adult individual, you will have maximum neutrophils, then lymphocytes, then monocytes, then eosinophils, and your basophils will be 0 or 1, almost absent. In your peripheral blood, do you have any plasma cells? No. Plasma cell blood report में नहीं होता है. Plasma cells never come out into the blood. Plasma cells are always sitting in the bone marrow. So most important, never will anyone give you a blood report saying that plasma cells are there. If by chance, before I get going with this, if by chance someone says, please remember, normally plasma cells are going to be present in the bone marrow. Ma'am, why normal? What if it is a cancer of multiple myeloma? That will also be in the bone marrow only. जहाँ plasma cell वहीं उसका cancer. Multiple myeloma, does plasma cell come out into the blood? No, it does not. But if I start seeing plasma cells in the blood, what does that mean? Suddenly, anyone? Earlier they used to say that if more than 20% plasma cells are seen in the blood, we are going to call it as a plasma cell leukemia. But recently, and here I am teaching only because बिल्कुल अभी update आया है, so new that I could not, I mean I recorded the rapid revision 6.0 just a month and a half back only, but it is so new that it came after those recordings, and that is why I am teaching you over here. Nowadays they are saying that plasma cells more than 5% should be treated as plasma cell leukemia. So this is an information you will not find in any other video because ये अभी last month ही आया है. And if an examiner is so up to date by any chance, then he might want to ask you this question. So in most cases, I'll tell you what the options are. Plasma cells in the blood are, they say they are more than, usually they give you a value of 40% or 50% or 60%, and you know कि अच्छा ये तो पक्का ही plasma cell leukemia, because anything above 20% is, since age old we know that is a plasma cell leukemia. But if the examiner is asking you as per the updated 2024, ऐसा लिखा हुआ question में, as per the updated 2024 hematology updates, what is the plasma cell leukemia cutoff? I think it's very unlikely कि कोई इतना up to date होगा because mostly examiners have made the paper by now. But just in case that wording is there and someone wants to test you, keep this extra point in mind. Coming back, normal blood report will not have plasma cells for you guys, okay? So now coming back, normal blood report will have what? It will have NLMEB. How do I identify neutrophils? Neutrophils are going to have 3 to 5 lobes. 1, 2, 3. Okay, what if it has more than 5 lobes? Where do I see hypersegmented neutrophils? That is going to be seen in megaloblastic anemia, right? That is seen in megaloblastic. Coming to the next, simple looking cell. I have nothing to teach you in this. It is going to be a lymphocyte. Simple round cell. Hamari country mein, please remember, TB ka patient lymphocyte count in the blood is more. So TB, everything you have to know. Coming to monocyte. How do you identify monocyte? It is identified by the kidney shaped nucleus. And you have just, dealt with the season of monocyte, because M for monocyte, it is increased in which infection? It is increased in malaria. Coming to the next, eosinophil, the easiest, because this is the only cell which is orange. And look at the nucleus. It's like a cell with a lot of swag if you actually look at it. It's got a vibe to it. It's got a spectacles. It's wearing goggles. So if you see, there are red color granules and there is going to be a spectacle kind of a cell, that is going to be an eosinophil. And we have entered, abhi season change ho raha hai na, to abhi a lot of people I'm seeing in my lab, they are coming to me with allergies because sudden season change has happened. Allergy increases eosinophils, and any parasitic infection is also going to increase eosinophils. Lastly, any cell that is going to look blue-black is going to be a basophil. And I just told you, basophil ka cousin brother kaun hai? Mast cell. Dono ke liye what is the special stain? That is toluidine blue. So now coming back, guys, look at this. The first cell with 3 to 5 lobes was the neutrophil. The next one, simple looking goal cell, was lymphocyte. The next one with the kidney-shaped nucleus was a monocyte. The next one with orange reddish granules was eosinophils, and the next one which is looking all this blue black is going to be basophils. This is the only picture which has all cells in one photo. So this is most likely to come in your exam, and if they ask you the special stain for toluidine blue used for, it is used for mast cells or basophils. Am I okay with this? Can I move forward to the next question? Another question which is much expected. Which of the following is going to be the interpretation of iron deficiency anemia? We have to get one question of IDA. It's like pretty obvious. What is the interpretation of iron deficiency anemia? Low ferritin, low transferrin saturation, low serum iron, increased TIBC. By the way, this is also your last year PYQ. 1, 2, 3, 1, 2, 1 or 1, 2, 3, 4, all of you are very certain on this. So now what you're going to do, you're going to fill in this one table so that we are certain. Before I start, INI-CET likes to ask you these kind of questions of normal values. They might not give you, they might say serum iron is this much and you're supposed to know the normal value. So serum iron is between 50 to 150. How I have learned is somewhere in between 100. Average याद करके चले जाओ. Iron कितना होता है हमारे पास? We have 100 micrograms per deciliter of iron. ठीक है, तो 50 to 150, 100. And the formula is that, see, how much iron you have is meaning how much food you have in your body. But ma'am, food how much I have versus how much hunger I have is very different. I mean, I should be eating one slice of pizza, but how much hunger do I have? Hunger to ma'am, I can have 3 to 4 slices of pizza also. So same way, iron how much I have in my body is going to be 100. Okay, but TIBC is total iron binding capacity. How much capacity do I have is 3 times of iron. Can you see the capacity is going to be 300. So how many slices of pizza you have eaten? 1. But how many can you eat? You can eat 3 easily. So 3 times of iron is your capacity. After that, what is the transferrin saturation? Transferrin saturation average, I want all of you to learn, is 33%. They range from 15 to 50, but average is 33%. So my way of learning has always been this, so that you can have, otherwise you can't learn normal values. For practice also this helps you. Iron is 100, TIBC is 3 times, so that is 300, and transferrin saturation is 33%. So now tell me, iron deficiency anemia, serum iron deficiency, of course iron will be less. If iron is less, who will get transported? No one. So transferrin saturation will also be less. Ferritin is what form? It's the storage form, but यहाँ तो deficiency है, bank account storage is also less, so ferritin is also less. If everything is less, what will happen to the hunger? The hunger is going to be more. So iron deficiency anemia means everything is deficient, and that is why the hunger is going to be more. Versus sideroblastic, this is an anemia where there is an iron excess, means iron levels are going to be more. If iron levels are more, transferrin saturation will also be more, bank account will also have more iron, everywhere there is more iron, that is why the hunger of iron is going to be less. So can I say iron deficiency anemia is full garibi situation, full beggar situation, that there is no money at all, that is why the hunger is a lot. And sideroblastic anemia is full Ambani situation, that there is so much of money in the circulation that this family has, that there is no hunger for new money, they can waste money as much as they want. Now let's come to the tricky situation. Anemia of chronic disease. This is that pseudo beggar on the road nowadays who says that, oh, please give me money, I don't have any money, I don't have iron, देखो transferrin saturation भी नहीं है. He's very bechara, he's very poor, he's enacting to be very poor and very miserable in life. But when you go and check his bank account, he has more money than any doctor on this planet. Look at his ferritin. The ferritin is more. Why? Because of chronic disease. Because of chronic disease, which interleukin has been released? Interleukin 6 has been released, and because of that, the ferritin content has increased. And now tell me, if someone has so much money in his bank account, this though he is just showing miserable, but in his bank account he has so much of money, will he actually want any hunger in life? No, he has so much of money, he has all Rolls Royce and everything. Uska hunger nahi hoga, ma'am. That person will not have any hunger. So my advice is that in the exam, what you actually have to do is, rather than focusing on iron and all, always first pick up the bank account. Always pick up the bank account, and that will really help you. This means if a person is genuinely poor, this means, ma'am, he was showing to be poor and he is genuinely poor in his bank account. Sachi mein poor hai, iron deficiency. If he's showing rich, his bank account is also rich, he's an Ambani, he's showing it on the face. But if he's showing to be poor and his bank account has a lot of money, that is anemia of chronic disease. Usually the chronic disease given to you in the exam is going to be rheumatoid arthritis. It's their favorite chronic disease for some odd reason. And for anemia of chronic disease, the treatment is not, don't feel that iron kam hai, beggar ka treatment ye nahi hoga that he's acting miserable, so let me give him more money. No, the beggar will be, tell him to stop begging. What do you have to do? You have to treat the chronic disease. You will have to treat the rheumatoid arthritis, and the patient will be fine on his own. This is a famous question. Iron deficiency anemia mein everything will be low, full garibi, full poverty, and the hunger is going to be high, so there is increased TIBC. Just in case you forget in the exam that what was the story of TIBC, you should remember it is top in iron deficiency anemia, means in iron deficiency anemia tends to increase, and it is going to be bottom in chronic disease. In anemia of chronic disease, it is going to be decreased. You can apply it over here also. It is top in iron deficiency anemia and it is bottom in chronic disease. Just in case you forget your logic, then you can always rely back on these as well. Can we move forward to the next question, guys? Another HEMAT question coming up your way. Which of the following steps will not be included in the staining protocol of the image shown below? Don't focus on my fill in the blanks. Focus on the image. Give me an answer. Which of the following will not be included in the protocol of what has been shown below? Yes? A quick answer? Okay, so now we have option D, that is methanol fixation. तो ये कौन सा cell था? By the way, this cell that has been shown over here is going to be a reticulocyte. What is reticulocyte? It is, in simple words, it's a precursor of an RBC, right? It's an RBC precursor. And the next question is, why do you call it a reticulocyte? Because it is made up of reticulum of RNA. What it has inside it is RNA. So actually these blue color dots that you are seeing, these are nothing but RNA. But RNA is very finicky. You know, RNA has all tantrums. It says, okay, if you want to see me, na, I have certain checklist. If you fulfill this checklist, then you will be able to see me under the microscope. And the checklist number 1 is that it says that the kind of staining that you have to put for me is going to be the supravital stain. Supravital stain means vital, living. RNA says, if you add any chemical on me, na, like alcohol, ethanol, methanol, I will die, I will run away, and then you will not be able to see me. So dare you add any chemical on me. Supravital stain means that you are going to see the cells in the living state, and living state means you are not allowed to add any ulta pulta chemical to it. There has to be no methanol, ethanol. Methanol fixation nahi kar sakte. Kya kar sakte ho in this case? You just take blood, patient ka blood sample, and you add the stain. 1 drop of blood sample you will take, 1 drop of the stain you will take. Which supravital stain? Give me some examples. You can see blue color aa raha hai, to ya to ma'am we can add a blue color stain called new methylene blue, or we can add another blue color stain called brilliant crescile blue. Either any one you can add on this, and you add 1 drop of blood, 1 drop of the stain, and bas reticulocyte dikh jayega. So can we add new methylene blue? Yes. Can we add brilliant crescile blue? Yes. Should we add equal quantities 1:1? Yes. Should we do methanol fixation? No, because RNA says if you want to see me, you will have to keep me in living state. मेरे ऊपर कोई chemical डाला, I will run away. And this is how a reticulocyte looks like. What is the normal value of the reticulocyte? Normal count is 0.5 to 2%. Again, something that they will not be giving you in the exam, so you have to be knowing. Is everyone okay with this? Can I wrap up this set also? Can I move on to the last segment that I wanted to teach you? One more miscellaneous question that is left, which was asked in the last to last INI-CET, so I have to teach you that also, is this. Which method is employed for the detection of auto antibodies? Like you have that SLE hota hai na, anti-nuclear antibodies, anti-Smith antibodies. So for auto antibodies, what do we do? FISH, PCR, direct immunofluorescence or indirect immunofluorescence? Obviously, no one for antibodies, no one is doing FISH and PCR. So please remember, direct immunofluorescence is always done whenever you want to do antigen detection. Indirect immunofluorescence is always done when you want to do antibody detection. So over here, antibody was asked, that is why I will do indirect. Repeating, direct when I want to have an antigen detection, indirect when I want to do antibody detection. But please remember, jo humne, I'm not showing that to you, but in dermatology, have you seen all those skin biopsies? जल्दी से बता दो, पेम्फिगस में क्या दिखता है? फिश नेट अपीयरेंस ना, तो उसमें क्या किया जाता है? स्किन बायोप्सी में व्हाट वी डू इज गोइंग टू बी DIF. प्लीज रिमेंबर दिस. स्किन बायोप्सी में कौन सा इम्यूनोफ्लोरेसेंस करते हैं? दैट इज गोइंग टू बी DIF. वेरी गुड. आई शो यू क्विक दिस थिंग. दिस वाज द फिश नेट. I don't know if I can zoom in maximally to this, if that will be possible. Yeah, I think it is. So this is that famous fishnet pattern. By the way, I hope you remember, I had told all of you there will be some photos which will be given to you in the end as bonus slides. Derma, I am assuming you have studied with Khushbu ma'am. That is why I am not repeating it in the LRR. But when I give you bonus slides in today's PDF, it will have all these fishnet pattern. So skin में क्या किया जाता है? Skin में it is always going to be DIF. So whenever they want to do antigen detection, it is DIF, and whenever they want to do antibody detection, that is immunofluorescence. Okay, let's move on to the next set of questions now, and that is going to be this, a question that I am expecting in this exam. These are all one-liners which I think can come. Which of the following is said to be pathognomic for malacoplakia? Quick answers. What is the following that is pathognomic for malacoplakia? Very good. You are saying Michaelis, Gutman bodies. So tell me all questions of malacoplakia jaldi. Malacoplakia is actually a problem in what? It is going to be M for M. It is a defect in M for macrophages. And what is macrophage going to cause? Phagocytosis. So it is basically a defect in phagocytosis, as easy as that. Imagine, let's say this is a urinary bladder. Usually they give you a urinary bladder. Last INI-CET, they give you malacoplakia of the skull, of the skin, somewhere on the forehead. So it's not that malacoplakia only occurs in the urinary bladder because you've seen a urinary bladder photo. No. Malacoplakia is a defect in macrophages and phagocytosis which can affect head to toe anywhere in the body. So या तो ये वाला photo आएगा, or anywhere else in the body they will want to tell you malacoplakia. But how will they make you guess malacoplakia? They will say phagocytosis नहीं हो रहा. Okay, yeah, you remember this skin manifestation. So how do you pick it up in the exam that despite not having this urinary bladder, still I know it's malacoplakia? They will always say that acha, there is a person who's having an infection and he's not able to clear that infection, because obviously if my macrophages are not working, how will I clear the infection? So like in the urinary bladder, most common example is that there is going to be E. coli infections, but anywhere in the body multiple infections will occur. So look at this, in the urinary bladder, these yellow plaques started forming. So the urologist did a cystoscopy, endoscopy, and saw that acha, urinary bladder mein there are plaques present. This means maybe the patient is going to have some kind of you can say there's some kind of cancer, because bladder mein to plaques, you think of cancer. Can it mimic cancer? Yes, it can. So what will the urologist do? He will take a biopsy and send it to the pathologist. Pathologist saw nahi, cancer cell to dikh hi nahi raha. I am seeing these blue color inclusions, and these blue color inclusions, this is the best one that I can see. These blue color inclusions are what? They are going to be the Michaelis-Guttman bodies. Michaelis-Guttman bodies are nothing but calcium. So ये बना कैसे? The pathophysiology you know, then you will be able to solve every question which comes your way in the exam. Just imagine if E. coli comes in the body, who is going to engulf it? It is going to be engulfed by obviously macrophage. So this is one macrophage over here that I have drawn, and inside this macrophage I have drawn this E. coli. Let's draw these chota bacteria, these E. coli. But now tell me, kha to liya, can macrophage kill it? Will it be able to do phagocytosis? No ma'am, that is the problem, it can't do phagocytosis. This E. coli is sitting inside, like a baby, he's sitting inside. Dheere dheere, what will I start depositing it around it? I will start depositing calcium around it. So what is this calcium known as? This calcium is known as the Michaelis-Guttman bodies. It is nothing but E. coli ke upar I have started making calcium. And what is this entire cell known as? This entire macrophage which has all those Michaelis-Guttman bodies, the entire cell is known as the von Hansmann cell. So repeating, M for malacoplakia, it is a problem in M for macrophages. It shows you M for Michaelis-Guttman bodies, and this full cell is named after a scientist, and that is known as the von Hansmann cell. Now this same story comes to you on the skin, on the forehead, on the abdomen, on the intestine, or on the urinary bladder. It is going to be the same. Yeah, Khushi, this can be an example of dystrophic calcification because somewhere it is happening on a bacteria which is going to die. So if you have to categorize it, dystrophic calcification. Are we okay with malacoplakia? यहाँ पर simple question था. What is pathognomic for malacoplakia is going to be Michaelis-Guttman bodies. Asbestos bodies are seen where? In asbestosis. No answer to that. What is the shape of asbestos bodies? They are dumbbell shaped. Aschoff bodies, we all know they are seen in rheumatic heart disease, so that we know. And Samoma bodies, I think again like Gaucher's का crumpled tissue paper के बिना no session is complete. Samoma bodies के बिना no session is complete. So I'm not gonna write it today because I think, or I'll write it only, else I will have the FOMO of not teaching you. We all know Samoma body is going to be PSM square. So jaldi se write in a short form and tell me within 30 seconds. One is going to be papillary carcinoma all over the body, thyroid, endometrium, ovary, colon, kuch bhi chalega. Then there are going to be two hormone tumors, that is going to be prolactinoma and somatostatinoma. Okay, next one, the most important in gynae you are asked, that is serous ovarian tumors. By the way, serous ovarian tumors ka CA marker is also asked, that is going to be CA 125. I'm sure everyone knew. One brain tumor is going to be meningioma, and one lung tumor is going to be mesothelioma. So for my I should not feel bad, I have taught you Samoma bodies, but I'm very sure that all of you already knew it. Now let's move on to the next question. This came in your exam, and very bad question, but it came, so we have to settle this. Which anticoagulant is used in a light blue colored vacutainer for measuring plasma glucose levels? This was the INI-CET last year repeat 2023 में आया था, जल्दी से बता दो. Option A everyone is saying. Okay, now the thing is that as soon as, ideally, should you be testing glucose levels in light blue vacutainer, ma'am? Technically the question is wrong. Technically the question is wrong because glucose levels should be tested in the grey vacutainer. But maybe this was an intern on day 1 of duty, उसे नहीं पता था, उसने उठाया light blue vacutainer. So now I don't see that what mistake someone has done. So many times I also receive it. I sometimes receive glucose testing that has come in a blue vacutainer or a green vacutainer or a purple vacutainer. I ignore because I know that, listen, manufacturer ने light blue vacutainer दिया होगा, तो light blue vacutainer में हमेशा क्या होता है? It is always going to have trisodium citrate. Now the intern has made a mistake of testing glucose in it or testing something else in it. वो तो human error है. Manufacturer machine error नहीं मानेंगे. We will say light blue vacutainer था, उसमें क्या होता है? It is going to have trisodium citrate, right? Okay, now coming to the next thing is all the vacutainers. So what if now the intern was right? उसे पता था कि नहीं मुझे तो पता है मैम कि ग्रे में ग्लूकोज जाता है. So now I'm asking you, which is the most common anticoagulant in this grey color vacutainer? You are a good intern, you are not a bad intern. What is हाँ? So now the next mistake, पता है कि glucose goes in grey, but जब मैंने anticoagulant पूछा, all of you mark sodium fluoride, which is wrong. The anticoagulant is potassium oxalate, so I will actually start from here only. When I talk about a grey vacutainer, G for grey and G for glucose, and I'm not writing it all types of glucose. फास्टिंग ब्लड शुगर हो गया, रैंडम ब्लड शुगर हो गया, पोस्ट प्रैंडियल ब्लड शुगर हो गया, ग्लूकोज चैलेंज टेस्ट हो गया, ग्लूकोज टॉलरेंस टेस्ट हो गया, ग्लूकोज का कोई नया टेस्ट हो गया, all glucose stuff goes in gray. Does HbA1c go in gray? No. All of these go in gray except glycated hemoglobin, because glycated hemoglobin में सिर्फ glucose you are not testing, you are also testing hemoglobin, so that will go in our usual lavender or purple vacutainer. HbA1c goes in purple, rest दुनिया का सारा hospital glucose is going to go into the gray vacutainer. Now please note that this gray vacutainer that you have, for which you are testing all the glucose, this has two things, be very certain on it. Number one, it has an anticoagulant so that your blood should not coagulate, and second, it has an additive. Now all of you marked sodium fluoride. Guys, sodium fluoride is an additive, not an anticoagulant. The anticoagulant is potassium oxalate. This vacutainer has two things filled inside it. One is potassium oxalate, which is going to be the anticoagulant, and one is going to be sodium fluoride, which is the additive. Question ध्यान से पढ़ो. I had asked you anticoagulant. Anticoagulant is going to be potassium oxalate. If I would have not written this word and I would have asked you what is the additive, then your answer would have been right, and that was sodium fluoride. समझ आ गया how you mess up on this exam? You know everything. Everything is there in your notes, in your memory, but application is so important sometimes. Now coming back, what about the vacutainers here and there? What about the ones next to it? If I see the green color, green is for hara, and the hara one is going to be heparin. Hara one is going to be which anticoagulant? Heparin. And what do I do? Nowadays I don't do much, but once upon a time osmotic fragility testing used to be done in this. Aajkal to no one does osmotic fragility testing. These days it is used a lot in the anesthesia department. Yeah, for arterial blood gas analysis, heparinized vials are being used. Now we come to these. There is a light blue vacutainer. Now when I say light blue vacutainer, what is the anticoagulant inside it? It is 3.2% trisodium citrate. What am I going to do with 3.2% trisodium citrate? Number one, I measure ESR. कौन सा वाला ESR do I measure? I measure the one that is by Westergren, the better one. And I do all coagulation studies. Coagulation studies means PTA, PTT. Do you know the black vacutainer also has the same anticoagulant? It also has trisodium citrate. I am also going to measure ESR by it, but not the Westergren method. I am going to do ESR, which is going to be from the machine. So now listen to me carefully. There are multiple ways of doing ESR. 3.2 to 3.8%, Dr. Subhashini, it goes as a variation. For some things we use 3.2% and for some we use up till 3.8%. Coming back, so you will say that, ma'am, when examiner asks me, how do you do ESR estimation? I will ask the examiner back and I will read the question again. कि ESR कैसा हो रहा है? Is it being done manually by the pathologist in a tube, in a Westergren pipette? Then to I am using the light blue vacutainer. But is it being done by machines? Are they putting that vacutainer in the machine and machine is calculating ESR value? Then I'll be using a black vacutainer. But what if ESR is being done by the Wintrobe tube? तब क्या यूज करोगे? Then you will be using this usual, what is this set of vacutainers? And don't read what is written. I hope you've not read it by now. Anyway, so what is this set of vacutainers that you have? These are all the K2-EDTA vacutainers, and I think the K2-EDTA vacutainers are something that they will, if method is not given, then they cannot do that to you. They cannot tell you that, they won't tell you the method and they'll give you all options. नहीं होगा, then options में कोई एक ही होगा. Coming back, this is the vacutainer which all of you have used multiple times in your internship, the purple or the lavender vacutainer. Purple or the lavender vacutainer. So now tell me, firstly they will ask you, acha, anticoagulant is EDTA. Then they give you options. Which EDTA is used? Na2 EDTA, lithium EDTA, sodium, potassium, calcium. Remember, K2 EDTA is used. Others can be used. Sodium, K3 EDTA can also be used. But best कौन सा होता है? K2 EDTA. So best आपको याद करना है K2 EDTA. Which are all of these have K2 EDTA? Yes. So this pearly white one also has K2 EDTA. And I'm going to tell you a story. There is a pearly white girl. That pearly white girl belongs to the royal family. So the royal blue vacutainer is also K2 EDTA. Anyone who's dark wants to become fair. Anyone who's fair wants to become dark. That is somehow the bad part of the universe. So this pearly white girl says, I'm sick of being white. I want to be dark. So what does she want? She wants a skin tan. So tan color vacutainer is also K2-EDTA. Then every girl's favorite color is pink and purple, so they are also K2-EDTA. So there is a pearly white girl from the royal family who wants a skin tan with her favorite colors of pink and purple. इस पूरी story का एक ही anticoagulant है, that is K2-EDTA. So now tell me, if all of them have K2-EDTA, why have you kept different colors? Only to make your life tough. So P for pearly white and P for which samples are put inside the pearly white vacutainers, the ones which are being sent for PCR. Okay, royal blue, royal family to thoda rare ho gaya na, so any rare thing like trace elements if you want to detect, then you are going to use the royal blue vacutainer. Okay, coming to the next, pink. Pink is girls ka favorite color. Sensitive, girls are sensitive. Which is the most sensitive part of the hospital? It's going to be the blood bank. So you are going to actually send it, any blood group or cross matching sample has to be sent in the pink vacutainer. Now coming to tan. Tan sounds like tin, lead. Lead poisoning या lead के levels test करने हैं, तो you are going to put it inside the tan vacutainer. Then comes the bread and butter of my life, the purple vacutainer, in which everything is sent. If you want to do complete blood count, if you want to do that retic count, if you want to do say peripheral smear analysis, if you want to do glycated hemoglobin, remember I told you all glucose go in gray, but glycated hemoglobin wants to test hemoglobin also, so that comes down into purple. Coming to the next, the last one, if I want to do ESR by the Wintrobe method, that is going to be by EDTA. So now before I proceed forward, all of you are going to make that small little table. If I want to do ESR by the Wintrobe method, तो Wintrobe method के लिए हम कौन सा vacutainer use करते हैं? EDTA वाला vacutainer, means I'm going to use the purple vacutainer. If I want to test it via Westergren method, then I'm going to use the light blue vacutainer that we had seen. And if I want to, I don't want to work so much, I want to put it in a machine, तो machine में automation में करना है, then I'm going to use the black vacutainer. So my personal recommendation is, the examiner will catch you in two places. One, that glucose wala story, that in the gray vacutainer what is the additive and what is the anticoagulant, that story he will catch you. Then he will catch you all glucose goes in gray but HbA1c goes in lavender, purple, and he will catch you in this ESR story. Did you notice in all of them, I was making you block the production, or I was making you say that don't let the blood clot. Anticoagulation करना है, मतलब you don't have to let the blood clot. But now I'm saying होने दो, let the blood clot. So means, why am I wanting that the blood should clot? Because if the blood will clot, what will separate out of it is going to be the serum, and now I want the serum to come out. So can I say these are SSTs? These are serum separator tubes. We have red, then we have a little yellow golden type, and then we have orange. तीनों में क्या difference है? तीनों का काम वही है. इसमें is there any anticoagulant in it? No, because I want the blood to clot. So in this, the clotting time is going to be 60 minutes. In the yellow one, it comes down to half, that is 30 minutes, and in the orange one, it comes down to hardly nothing. The blood will clot in 5 minutes. Why? When all of them are the three same tubes, why is there blood will clot faster in some and later in the others? Because in all of the three, the common thing that is added is going to be a clot activator. What I've added to all of them, let the blood clot, please let the blood clot, clot activator डाल दो. But yellow वाले में I have added something extra, which is a gel, and that gel will make the blood clot faster in 30 minutes. And in orange one, I have added thrombin. Thrombin will make the blood clot even faster in 5 minutes. So remember, the red one only has clot activator, the yellow one has clot activator and gel, the orange one has clot activator plus a thrombin gel, and that thrombin gel will make sure that the blood clots very, very fast. But the purpose is the same, let the blood clot, let the serum come out. Because what do you want to do with the serum, guys? You want to do all, like you say for example, you do liver function test, kidney function test. So liver function test में you do serum bilirubin, serum SGOT, serum SGPT. Kidney function test में you do serum urea, serum creatinine. Then whenever you want to test any hormones, serum T3, serum T4, serum TSH, serum prolactin, serum testosterone, serum beta HCG, serum whatever, estrogen, progesterone, all hormones, all enzymes, G6PD, and all antibodies. Ma'am, in COVID, when we wanted to find out kya antibody bana nahi bana, all of those are also going to be in the serum. So all these are serum related tests which you can do in red, yellow and orange Vacutainer. But now comes the most important question. You've seen this question, I'm sure, in the exams. What is the order of the blood draw? And before you ask me, let me ask you, because this is a question that I always get from the students. What is the order of the blood draw? So please remember, the order is a red light. What are the colors? Let me ask you some some kindergarten questions. What is the red light? Red, yellow, green, है ना? तो red light क्या होती है? Red light is stop light. Ma'am, the stop light is going to be red. After red, the next color that comes is going to be yellow. After yellow, the next color that comes is green. And then the green light finally tells us that you can go. ऐसा ही होता है ना, stop light is red, red, yellow, green, green light is go. So this is the order of the blood draw. The first part of the blood that you put is not in any Vacutainer. You put it in a sterile bottle so that you can send it to the microbiology lab. Before you expose it to the air around you, you put it in a glass sterile bottle and you send it to the micro lab. After that, what is with light? You next put the blood in the light blue Vacutainer. Next, you put it in the red Vacutainer. Next, you put it in the yellow Vacutainer. Next, you put it in hara, heparin, green Vacutainer. Now, you are going to put it in the lavender or purple Vacutainer, and in the last you are going to put it in the gray Vacutainer. So repeating once again, sterile, light blue, red, yellow, green, lavender, gray. Ab yaad rahega, next time till your exam. I always tell students till the exam, whenever you are on the road, you see a red light, no matter how insane someone might find you for speaking this out, but start saying this. Stop light red, red, yellow, green, green light go. Ye bolte raho. Jab tak exam nahi hota, har red light pe this is what you're supposed to revise. This is the order of the blood draw. Is that okay with everyone? Can I move on to the last two techniques of the day? And I think, yeah, and 2:45 was our target, so I believe I will be able to wrap up by then. दो चीजें बची हैं now. One is platelet aggregometry and one is TEG. Are you ready for the last two things? Yes. And I think how much of ml of sample is sufficient? Khushi, nowadays on every Vacutainer they say 5 ml at least, but on every Vacutainer there is one line on the top. I don't know if these images will show you. इतना high quality image नहीं है, but usually यहाँ पे एक line होता है, that is the line of sufficiency that is mentioned. So there are different Vacutainers. Like if I can show you in this photo. Can you see there are two types of Vacutainers in this photo? One is a thicker Vacutainer which might need 5 ml. One is a thinner Vacutainer which might need 3.2. So they adjust the anticoagulant also as per that, and then they mention the line up till which you have to collect adequate amount of blood, so that the manufacturer has put accordingly. Like if the manufacturer wants you to collect 5 ml, he has put anticoagulant as per 5 ml. If he wants you to collect 3 ml, he has put anticoagulant as per 3 ml of blood. So that line will always direct you towards till where you have to collect the blood. Okay, but in this microbiology wala, usually 10 to 50 ml of blood, anywhere between that, depending on how much of culture media is there, it is used. Okay, now coming to the next one. The last two topics, let's start. Let's give 5 minutes to each and wrap it up. Chalo, what is false regarding Bernard-Soulier syndrome? BSS, false regarding. Two more questions on your way. Question 1 ka answer bata do. False regarding Bernard-Soulier syndrome. Does it have large platelets? GP1B9 defect. Ristocetin is normal. Platelet aggregation in response to collagen and ADP is normal. Soumya says C. Very good. Anyone else who wants to comment? Everyone says C. Okay, ristocetin is normal. You are saying a galat statement. So as per you, ristocetin should be abnormal. Okay, so first what you will tell me, whenever I want to make a blood clot, what are the two things that I require? Like for example, if this is a platelet has two receptors, ma'am. एक platelet का receptor होता है GP1B9 और एक platelet का receptor होता है GP2B3A. Both of them are present on the same platelet, GP1B9, GP2B3A. GP1B9, 1 जैसे लिख रहे हो, it binds with what? It goes and binds with 1 Willebrand factor. याद रहेगा, GP1B9 is going to go and bind with 1 Willebrand factor. इस step को बोलते हैं platelet adhesion. This is how platelet becomes stuck. But अगर एक platelet को दूसरे platelet से जोड़ना है, if one platelet wants to combine with another platelet, that is known as platelet aggregation, and that is done by GP2B3A. So please remember, 2b3a. Like for example, if one platelet wants to stick to another platelet, then 2b3a is going to come into effect, and then all these platelets will get stuck to each other, and then this will be known as platelet aggregation. This is something I'm telling you that happens in my body. I'll repeat it once again. GP1b9 binds to what? 1 Willebrand factor, and that is known as platelet adhesion. GP2b3a, 2b3a आपस में they keep binding, that is known as platelet aggregation, and that is how a blood clot is formed in you and me. But now when I'm trying to do platelet aggregation studies, I am trying to do this entire situation in a lab. So what happens, like if I take 5-10 ml of your blood sample, and I have a machine which is known as a platelet aggregation machine, I will put your 10 ml of blood into that machine. Now that blood machine has to do all this. कैसे करेगा ma'am? How will the machine do it? Machine can't copy your human body. You will have to add some chemical. So if I want this reaction to occur, I will have to add which chemical? A chemical known as ristocetin. So when I'll take your blood sample, I will add ristocetin. Then these two chemicals will come and meet. GP1b9 and 1 Willebrand factor will meet. Then if you want GP2b3a, 2b3a आपस में aggregate हो जाए, for that you can use ADP, epinephrine and collagen. What are the three chemicals that you will be adding? ADP, epinephrine and collagen. These three you shall be adding over there. So repeating once again, I will take 5-10 ml of your blood sample. I will add ristocetin to check for the GP1b9 and 1 Willebrand factor binding. Then I will add ADP, epinephrine, collagen. That will check the GP2b3a finding. So just remember, if I add ristocetin and these two don't combine, imagine you added ristocetin to your blood sample, GP1b9 and 1 Willebrand factor did not combine. Can I say GP1b9 is deficient? What is that disease known as? GP1b9 is absent, ma'am. That disease is known as Bernard-Soulier syndrome. Bernard-Soulier syndrome is a defect in GP1b9, that is correct. And Bernard-Soulier syndrome shows you big platelets, it shows you large platelets, that is also correct. Today, which disease did I tell you the only disease which shows you smaller platelets was? Wiskott-Aldrich syndrome. Wiskott-Aldrich was smaller platelets, Bernard-Soulier is big platelets. So it is a GP1b9 defect. So obviously, if someone doesn't have GP1b9, when you will add ristocetin, will you get a normal response? Of course not, ma'am. If GP1b9 is not there, I add ristocetin or I add anything on this planet, this reaction will not occur. So will the ristocetin test be normal? No, the ristocetin test will be abnormal. But when I'll add ADP, epinephrine, collagen to Bernard-Soulier patient, GP2b3a तो ठीक काम कर रहा है ना, तो प्लेटलेट एग्रीगेशन टू एपिनेफ्रिन, एडीपी, कोलाजन, इनके लिए तो ठीक होगा. सो द प्लेटलेट एग्रीगेशन टू कोलाजन, एडीपी, एपिनेफ्रिन इज नॉर्मल, दैट इज करेक्ट. What if on adding ADP, epinephrine, collagen, this reaction did not occur? What if GP2b3a was not there? What if GP2b3a was not there? What is that disease known as? Who will tell me? That is known as Glanzmann thrombocythemia. That is known as Glanzmann thrombocythemia. Do you know? Now I'm gonna do the I can say the mother of all integrations that I'm gonna do. Do you know GP2b is known as CD41 and GP3a is known as CD61? Where did I teach you 416 gun, 41, 61? कहाँ पढ़ाया था? Ma'am, this you had taught us in flow cytometry. Somewhere in megakaryocytic. I don't know how many pages before I will have to go to find for that table. But if you remember, I taught you a CD marker and that CD marker was 4161. I've actually lost track. I can't find. But I have to. Meanwhile, yaad aaya sabko megakaryocytic lineage was 4161. Okay, very good. Yes, finally found it. So if you remember, megakaryocytic lineage was 4161. Because now the mother of all integrations is this. When they'll give you a flow cytometry chart with CD41 written over here and CD61 written over here, and you know where are the majority cells falling? Majority cells are falling here in the double negative quadrant. This patient 41 negative, 61 negative, and you're wondering ye kya disease hai? 41 and 61 are nothing but GP2b and 3a are not there. When GP2b and 3a are not there, what does that disease become? Glanzmann thrombocythemia. Exactly. So how from Platelet chapter, they have gone all the way up till flow cytometry is how they integrate things for INI-CET. Now coming back to what I wanted to teach you, platelet aggregation. So 5 minutes के लिए ये सब भूल जाओ and look at this. This is a platelet aggregation machine and they will ask you what principle does it work on. This works on a principle known as light transmittance, and I will ask you something. It works on the principle of light transmittance. So look at this. Don't ratta lagao, it's nothing to mug up. What have I done? I have taken a blood sample of a patient in this tube. And what do you think? Which kind of blood sample? Platelet study कर रहे हो तो should I take PRP, platelet rich plasma, or should I take PPP, that is platelet poor plasma? Tell me some common sense question. Ma'am, platelet का पढ़ाई करना है तो you will have to take the platelet. You will take platelet rich plasma because this is a very common confusion that students have. For platelet aggregometry, what I take is platelet rich plasma. But when I want to test for PT-APTT, or in other words coagulation studies, you want to test for blood clot, but you don't want to test blood clot because of platelet. In PT-APTT, you want to test for blood clot because of factor 8, factor 9, factor 10, so on and so forth. So over there, do you need platelets? You don't. So which kind of plasma do you use? You use the platelet poor plasma. Concept or logic समझ आ रहा है? When I want to see blood clot because of platelets, I will use platelet rich plasma. When I see blood clot formation because of clotting factors, then over there I will be using platelet poor plasma. Is it okay? Nothing to ratta lagao, common sense, वापस आओ. Platelet aggregometry is all about platelet rich plasma. So look at these. These are all these PPP. These are all the platelets that are normal blood. In a normal blood, all these platelets are roaming around. Very nice. So just imagine if I take a normal blood sample and I make light pass through it. Do you think light can pass? No ma'am, there are so many obstacles. इतने सारे platelets है रास्ते में. How will this light transmit? Light cannot transmit. Very little, hardly little light will go, that's it. But now, if I add some chemicals like I add ristocetin or I add ADP or epinephrine or collagen, now धीरे धीरे I will see that the platelets have started clotting. Now imagine they have made chota chota clumps and they will all come down. Now will the light be able to pass easily? Yes, and that is why I said that what is the principle of platelet aggregometry? It is going to be light transmittance, because once you make the blood clot, the light will transmit. Have you got the principle of platelet aggregometry, light transmittance? Because now I will show you the graph. There are two graphs and then platelet aggregometry is done. Darna nahi hai is the first point of this graph, okay? Listen to me. What you're seeing on the x-axis is going to be the time, and what you're seeing on the y-axis is going to be optical density. It is going to be optical density. So now tell me, for example, you tell me yourself, इस वाले blood sample में when platelets are all over, full, packed with platelets, do you think this sample has a density of 5% or this sample has a density of 100%? Is it very, very dense or is it very, very light and faded? Ma'am, it is so dense that light can also not pass through. That is how dense it is. So I would say the density of this sample is 100%. It is an optically dense sample because इतने platelets हैं कि full 100% density है. Versus अगर ऐसा छोटा छोटा clots बन जाएगा and after some time with gravity, you know, all those clots will come and settle here in one bottom. Now what do you think has the density of this area become? Now it has become almost 50% or 10% or 0%. Do you all understand? Originally your blood has how much density? Originally your blood has 100% density. But dhire dhire if a blood clot will form, now your blood will start having 50, 40, 30% density. So just imagine in this, what will not be written to you in the exam is that the blue color has been given to a normal person, a normal sample. आपका मेरा blood sample लिया. And the red color has been given to the patient's sample. This is never written for some reason in the exam. So common sense, we always give red color to the patient, and blue color always signifies that we are giving this in the to the normal person. एक और graph है, इसमें भी वही blue color has been given to a normal person, so blue color has been given to normal person and red color has been given to patient. तो चलो और क्या क्या है, maybe you cannot read it, I will write it for you. In the first column on the top will be written ristocetin, In the next column is written collagen, in the next column it is written epinephrine, and in the third column it is written ADP. Labeling समझ आ गई सबको? This is going to be the time graph, this is going to be the optical density. Blue color is the patient, blue color is the normal, red color is the patient, and these are the 4 chemicals added. अब हम इसका interpretation पढ़ते हैं. Start from the top. Only focus on the blue color person. Normal पढ़ो पहले, normal देख लेते हैं. Tell me what is the optical density of a normal blood sample to begin with. Of course, normal blood sample has an optical density of 100%. Okay. As soon as I will add ristocetin, ma'am, ristocetin से क्या हुआ? Platelet aggregation, platelet adhesion शुरू हुआ. Because of ristocetin, little bit of platelet adhesion started. So छोटा छोटा clumps बना. So I realized that the blood density started going down. And when you added these 3, all the platelets aggregated and all of the blood density came down. Ultimately, the blood has come down to a 0% optical density because clot ban gaya. This was normal, I expected it. Just imagine, on adding ristocetin in the patient's optical density only fell from 100 to 90%. It did not fall till 0. But on adding ADP, epinephrine and collagen, the patient's optical density has fallen to 0. So problem kahan aa raha hai? The problem is coming with ristocetin. If the problem is with ristocetin, remember abnormal ristocetin test, तो क्या problem हुआ? This is a case of Bernard-Soulier syndrome. Why? Because GP1B9 में problem है. Versus look at the previous graph. Ma'am, in the previous graph, I can see if I compare a normal person, the people are having a problem with these 3 chemicals, collagen, epinephrine and ADP is a problem. If इनका patient का optical density देखो, ma'am, it is not falling from 100 only to 90%, means this is a case of what? This is a case of Glanzmann thrombasthenia. That is what. पढ़ने में 10 minutes लगा. Last day एक line. The only line is, if it's a problem with ristocetin, it's a case of Bernard-Soulier. If it's a problem with ADP, epinephrine, collagen, it is a case of Glanzmann thrombasthenia. Simple. Repeating, if it's a problem with ristocetin, it is a case of Bernard-Soulier. If it is a problem with ADP, epinephrine and collagen, उसका patient नहीं response कर रहा, so then that is a case of Glanzmann thrombasthenia. Okay with this, everyone? और कोई third graph नहीं बनेगा. These are the only 2 graphs that are possible. The last question of the day. In the emergency department, a child presented with a sizable lesion on their forearm and a surgery resident said that the lesion had to be removed in an emergency OT. Which of the following investigations will assess the complete coagulation pathway? APTT, PT, TEG or BT? Complete coagulation pathway will always be tested by TEG. Even by bias, you knew that was the last topic. Let me tell you, bleeding time only tests platelets. I want to test the complete coagulation pathway. Complete coagulation pathway will mean platelet also. Along with that, the clotting factors also, matlab intrinsic pathway, extrinsic pathway. Bleeding time only tests platelets. PT only tests which pathway of the clotting factor system? Extrinsic pathway. And APTT tests what? It tests only the intrinsic pathway. तो मैम ये तो एक टेस्ट हो गया. आपने कहा you want complete analysis. Complete analysis is only done by TEG. So this is the machine of TEG thromboelastography. Only thing that you get. या तो you will get a picture of this machine or you will get a picture of this graph. And these are the only 2 things in the last 5 minutes. Sorry, it's 2:50, but you will have to give me just 5 more minutes, okay? I've extended this, but after this, our INI-CET patho becomes, in a way, a lot more complete. What do I do in this? I am taking blood from the patient and इस cup में डाल दिया. Can we all see there is a cup over here? And इस पे ध्यान से थोड़ा सा सुन लेना. I can see that there is a cup over here and I can see there is another cup over here. And inside this cup, I have put a blood. On top of that, from the machine, there is a pin that is going to come. This is the pin that has come. Now, for example, if this pencil of mine is the pin and this is a cup. So the pin has come and now this cup is going to move. Just imagine the blood is moving. If the blood is moving, the tip of the pin will constantly act as a trigger. It will start creating a clot. वो जो blood होगा, वो इस pin के आसपास clot होने लग जाएगा. That is what will happen. Imagine the clot is forming over this pin. This cup is moving and the clot is forming over here. Imagine there's a clot. Something is pulling this pin again and again down. Clot is like a heavy gravity source. It is pulling the pin down. इस machine को लगेगा what has happened? My pin is being pulled down again and again. Machine will get a signal that blood clot has started forming, and the machine will end up making this entire graph for you. And this is the graph of thromboelastography that you all have to know. So everything is written. You just need to understand what exactly is happening in this graph. So listen to me a little carefully. Firstly, if I have to delineate the shape of this graph, this is how it's going to look like. It's this kind of a graph, normal graph that you have. ध्यान से देखो. तो इसमें आपको क्या देखना है? How is a blood clot formed? You started, this needle started moving. मैम पहले जो blood clot बना, that is known as the R time. R time refers to what? It is going to be the reaction time. Blood clot has started forming. So blood clot has started forming due to what? It is due to clotting factors. It must have been the intrinsic and the extrinsic pathway. So it is because of the clotting factors or the clotting pathway that is going to be the blood clot formation. So R time कितना होता है? It is roughly between 4 to 8 minutes. In some books it is written as 5 to 9 minutes. चलेगा. When it's machine values plus minus 1 minute we ignore because lab to lab variation occurs. So 4 to 8 लिखा, 5 to 9 लिखा, चलेगा. 4 to 8 minutes is the time taken for the initial clot to form. So now if I have to highlight, it is from here till here. This is the R time. After that, clot तो बन गया. But now, do you want the clot? Everyone tell me, you want the clot to be very weak or you want the clot to be very strong? Of course, you want it to be very strong, and that is now known as the K time. This tiny little time that I have over here, this tiny little time is known as the K time. This tells me the clot kinetics, and ये उससे कम है, R time से कम है. It is, R time was 4 to 8 minutes. K time is going to be 1 to 4 minutes, and K time, how I have learned, is for clot strength, or in Hindi we can call it K time is to make the clot kadak. Okay, if you want to make the clot kadak and you want to make it strong, that is going to be the K time. And who makes the clot strong? It is due to fibrinogen. The final strength fibrin clot hota hai na, fibrinogen makes the clot strong. Then you will say, okay, now comes the alpha angle. Can you see the graph has started going up like this? It has started making an angle. So this angle is referred to as an alpha angle, which is 4474, between 44 to 74 degree. And this alpha angle is going to actually tell me the speed of the clot formation. At what speed is it occurring? And this is also dependent on what? This is also dependent on fibrinogen. Finally, ma'am, I realize दोनों तरफ से alpha angle बना, and this is the maximum strength of the clot. यहाँ तक maximum clot बना. Maximum is known as MA, that is maximum amplitude. कितना maximum clot बनता है? 50 to 70 mm. Now tell me, this was your last year INI-CET question. This maximum strength of the clot is dependent on platelet alone, clotting factor alone, or a combination of both. Platelet alone, clotting factors alone, or a combination of both? Answer is both. Obviously, clot दोनों से बनता है. Platelet also, clotting factor also. But the question in INI-CET was, the maximum amplitude is majorly dependent on what? The platelets or clotting factors? And then the answer was, it is majorly dependent on the platelets. After that, blood clot bana. Your body is so beautiful that after making a blood clot, it has the property of breaking a blood clot also. It can do fibrinolysis. So that is now the last. Now the decline starts. That is lysis, LY30. Why do we call it LY30? Because we check for lysis at how many minutes? We check for lysis at 30 minutes, and it should be between 0 to 8%. And how? Everyone learns it by Ranbir Kapoor is an alpha male. What is Ranbir Kapoor alpha male? सबसे पहले there is reaction time. Next is going to be kinetics. Third one is going to be alpha angle. MA is going to be maximum amplitude, and LY is going to be lysis. I will repeat this once again, and all of you are going to this time draw it with me. What is the first thing that happens? Ma'am, you have given us a mnemonic, Ranbir Kapoor alpha male, which means the first one is going to be, keep telling me, reaction time. Reaction time ka timing kitna tha? 4 to 8 minutes. Reaction time is 4 to 8 minutes. What is it dependent on? It is dependent on all the clotting factors. Then comes the K time. The K time is lesser. It is 1 to 4 minutes. It is making the clot kadak, kinetics, and that is dependent on fibrinogen. Then comes the alpha angle. The alpha angle is going to tell me the speed at which the clot formation is occurring, and the alpha angle is between 44 degree to 74 degree. Then comes the maximum amplitude, the maximum that the clot can reach, which is primarily dependent on platelets more than the clotting factors. It is between 50 to 70 mm. Very good. And then finally comes the lysis part, and lysis you check at 30 minutes, which should be between 0 to 8%. So Ranbir Kapoor alpha male. Yaad rahega, put it in an order. If you understood, this is your last test, and I promise this is the last for the day. Normal to aa gaya. Till now, every time the question has come on normal, but what further can the examiner give is what we have to reach. What else can be asked? So for example, they've given you the first one on the top has been given to you for comparison, normal. What do you feel is the problem in the first graph given over here? Ye wala. This one, what do you think is the problem? Which time has suddenly looking very, very more normal se compare karo? Ma'am, I can see that there is an increase in the R time. R time was dependent on what? R time was dependent on all the clotting factors. Matlab ye koi clotting factor nahi hai. That is why the R time is taking so much of time. Yes, this is probably a case of clotting factor deficiency, because of which there is increased R time. Clotting factor deficiency could be there is a patient of hemophilia A or hemophilia B, or maybe the patient has been given some kind of anticoagulant drug therapy, so usko clotting factors nahi kaam kar rahe, so his R time has increased. Okay, look at next graph. What is the problem? I can see normal se compare karo, R time is same. What has happened to the maximum amplitude? Don't you think this glass is looking like, if this was looking like a proper wine glass, then this is looking like a champagne glass. Usually that is how these graphs are defined on Google also. They've compared it to different types of glasses used for alcohol. So they say this glass looks very patla. What has decreased? Yes, very good. Maximum amplitude has decreased. If the maximum amplitude, right now all of you told me that maximum amplitude majorly dependent on platelets. This means this patient has been given some kind of platelet blockers. Perfect. Okay, let's look at this. This looks like a sword, wo jo movies mein use karte hain. I can see that the main extension over here is that LY30. The lysis is very much. Maybe this patient has been given some drugs, fibrinolytic drugs. We have given drugs to break the clot. So there is fibrinolysis that has happened in this patient. The last one, this is very interesting. What do you see over here? Look at this graph. It has become so broad, so mota graph. The maximum amplitude has gone so big. Overall, the graph is only looking like a big cold coffee tumbler. It has started looking like. There is too much of everything happening. Maximum amplitude bhi zyada hai, R bhi zyada, alpha angle bhi zyada. Ma'am, this is a case of hypercoagulation. Everything has become more. This is a case of hypercoagulation. Maybe it is a case of DIC. Disseminated intravascular coagulation. It is phase 1 of DIC, where so many clots are forming in the body that the graph has become big motu graph. That is known as a hypercoagulation. But tell me, last question of the day, what is the other name of DIC? Once DIC enters the last phase of phase 2, what is it also known as? It is known as consumptive coagulopathy. Consumptive coagulopathy means, yes, see, initially you are right, it is a hypercoagulable state. Ma'am, sab kuch bahut zyada blood clot banta hai. That is why the graph is looking so motu. But after some time, all your platelets will be exhausted. All clotting factors are exhausted. Sab khatam ho gaya. Kitna clot banega na? Everything your body has exhausted. After that, can you see your graph has become so patla? Basically, consumption. All the clotting factors have been consumed. Now your body has no platelet to give to you, no clotting factor to give to you. Everything has been consumed. So now the body enters into this patla wala graph. So in DIC, actually there are two phases. The first phase is when there is too much of coagulation, and the second phase is when all the clotting factors have been consumed and now the clotting is not possible thereafter. So repeating once again, agar R factor zyada hai, clotting factor ka problem hai. Maximum amplitude mein problem aaya, this means platelet is an issue. If it looks like a sword in lysis, means you are giving some fibrinolytic drugs. In DIC, initially motu graph, because there's too much of clotting happening, and in the later stage everything is exhausted, so there is too little clotting happening. Okay, so this happens to be the end and finally the end of today's class also. So we have finished everything that we have thought of, but I know that there is something that is missing, which अब ये सब तो हो गया हमारे, ये तो last time वाली चीजें थी. What is missing is this, which I have added in the PDF. Okay guys, thank you so much for joining in. Thank you.